A very good morning to our distinguished guests, speakers, and delegates. Welcome to the second day of the Resident Education Program, organized by IRIA, conducted by ICRI in association with the Department of Radiodiagnosis here at Some Hospital. Yesterday's sessions provided valuable insights into a vast array of topics, and we are grateful for the contribution of all our distinguished speakers. Today, we look forward to continuing those discussions with an equally distinguished lineup. Without further delay, let us commence with our first talk of the day. It will be delivered by Dr. Manoj Nayak. He is an assistant professor and interventional radiologist at IREP Bhubaneswar. Sir has super specialized in neuroradiology and has been an enthusiastic participant in academic deliberations, both in journals as well as symposiums. We would like Sir to begin his talk on imaging and interventions in acute stroke.
Thank you for the kind introduction. Good morning, everyone, respected teachers, my dear colleagues and students. At the outset, thank you to the organizing team, especially Satya sir and the Adya sir, for giving me the opportunity to present in this forum. Today I am going to discuss about the acute stroke imaging and the basic interventions related to it. Nothing to disclose in my talk. I am going to divide into two parts. One is the diagnostic part related to the stroke, and another part is the interventions related to the acute stroke. Basically, when the suspected a stroke or not, or a stroke mimic, and if it is a stroke, whether it is a ischemic stroke or hemorrhagic stroke, and if it is a ischemic stroke, how much the brain is affected, and how the vessel is, whether there is a large vessel occlusion or not, and the patient comes beyond the window period, then you have to assess the penumbra tissue, and according to that you will decide, and the imaging has a role in the follow-up as well as the long-term impact. Actually, what happens to the brain parenchyma when a brain artery gets occluded? First, there will be decreased flow to that area. Subsequently, when the time will pass, you will see the area of infarct gradually increase and the area of penumbra will gradually reduce. As you know that for every 1 minute, around 1.9 millions of neurons will die. So, time is very crucial in case of acute ischemic stroke. And you can see how much the aging in the for 1 minute around 3 weeks of aging will be there. When the brain normal blood flow of the brain will be around 60 to 60 ml per 100 gram per minute. When it comes down to below 20, there will be loss of synaptic transmission. When it comes below 12, there will be formation of the infarct. Before that only we have to recanalize that vessel so that the neurons will recover. If it comes below 12, there will be formation of the cytotoxic edema, and that we will see on our imaging. So we will have a core followed by the penumbra, followed by the benign oligemic region due to filling of the collaterals. As I told, when the time will pass, the core will progress and penumbra will reduce. So basics of the imaging of acute ischemic depends upon 4 P's and 3 C's. 4 P's stands for parenchyma, pipes, perfusion and penumbra. 3 C is for clot, core and the collateral tratus. We will discuss one by one. we can have a CT-based algorithm or MR-based algorithm. CT-based will CT angiography, CT perfusion, and MR-based FLAIR, DWI, SWI, top MRI, and MR perfusion. Particularly, CT perfusion and MR perfusion has a significant role in wake-up stroke, post-reposa stroke, and stroke beyond the window period. That means 6 to 24 hours. And the wake-up stroke, the patient went into sleep normally when the exact onset of the stroke is not known, that is wake-up stroke. The most commonly widely available investigation is the CT scan, CT angiography, and CT perfusion. And the CT angiography will see the level of occlusion, and the CT perfusion will assess the penumbra. These are the CT armamentarium for the acute imaging stroke, CT brain, CT angiography, multiphase CT angiography, and the perfusion will assess the penumbra as well as the collaterals. When a suspected stroke patient comes to our emergency, first the neurologist will assess the patient. They will calculate how is the NIH score, National Institute of Stroke Scale. It is a 42-point score. If it is more than 10, usually a large vessel occlusion. After that only they will send for imaging. We will do CT scan, CT angiography, and if required CT perfusion. Normally the door to imaging time as early as less than 20 minutes. If they are giving thrombolysis, it should be less than 60 minutes, and if you are doing thrombectomy, then ideally it should be less than 90 minutes, because time is very crucial in case of acute imaging stroke. Then what are the early features of stroke? How to detect early stroke? There are 4 signs like hypotense MCA sign, obscuration of the lentiform nucleus. You will not able to differentiate the lentiform nucleus. You will not able to separate the caudate, internal capsule, different structures, and loss of insular Liborn sign and loss of gray-white matter junction. These are the early features of the acute ischemic stroke. And the amount of infarct can be quantifiable by aspect score, Alberta Stroke Protocol early CT score. It is actually a 10-point score. Caudate, internal capsule, lentiform nucleus, insula, and lateral to the insula M1 to M3, and the supraganglionic level above basal ganglia M4 to M6. So if the 4 areas are affected, then the aspect will be 10 minus 4 is equal to 6. The score is bigger, near about 10, it means a small impact. If it comes near 0, then it is a very big impact. Likewise, there is a posterior circulation impact. The posterior circulation impact is also of 10 points. Bilateral cerebellar hemisphere 1 point, bilateral thalami 1 point, bilateral occipital lobes 1 point. So 6 points, and pons and midbrain assigned as 2 points each. So 10 points will in the posterior circulation also. Likewise, 0 to 4 aspect usually considered as poor aspect, 5 to 6 as moderate aspect, and 7 to 10 as good aspect. Like this example, you can say the M3 and M6 is spared in this case, so aspect will be 10 minus 8 is equals to 2. And when you are dealing with a acute stroke, then you have to adjust the window properly. Normally in normal CT scan we see as window width as 80 and window length as 40, but you have to make little dark, like window width of 40 and window length of 40, so that the stroke will be better visible. Now, after CT scan, we will do the CT angiography. We will cover from arch of aorta to the vortex, preferably a cannula in the right antecubital vein to have the reduced streak artifact of the brachiocephalic vein, so that the origin of the vessels we will able to see properly. And that will detect the large vessel occlusion, the length of the clot, clot permeability, presence of any tandem occlusion, whether there is occlusion behind like carotid bulb or any other site, because that will decide the management, how you will going to manage, whether you will first treat the proximal lesion or not. You can calculate the CT angio aspect and arch anatomy, that is important in case of we are taking for mechanical thrombectomy. Then we have to do the MIP images, 25 mm MIP images, like in this case you see to better visualization of the site of occlusion. Like in this case there is the right M1 occlusion, and there is a tandem lesion, that is right carotid bulb stenosis. And this is a good article regarding the multiphase angiography in radiology. You can go through it. Usually within 24 hours we will do 3 phases. So first phase from the arch of aorta to the vortex, and second and third phase are skull base to vortex for better delineation of the collaterals. with 8 second of interval, so we will have a arterial phase, venous phase and delayed phase for assessment of the collaterals. Collateral scoring is very important in case of acute stroke because that will tell the pace of the impact. If it is a good collateral, then usually have the good prognosis because these are all the slow progressors. And we will calculate different scoring systems are there. What we usually follow, we have to compare the opposite side. How is the collaterals on the contralateral normal hemisphere? If it is similar, then good collaterals. If it 50 to 100%, then it is moderate collaterals, and it comes below 50%. These are the poor collaterals. For example, in the case, she is a 40-year-old female who presented with 4 hours of stroke. There was left MC occlusion. You can see how big is the impact because the collaterals was very poor in that patient. But contrary to that case, he is a 48-year-old male who presented with 6 hours of stroke. You can see the impact core is very much less because of the good collaterals. As I told that collaterals set the pace of the impact, how the impact will form. Second thing we can assess in the CT angiography, how is the clot length, clot burden score. And usually the larger is the clot, those are all resistant to IV thrombolytics. The literature says that there is increased chance of hemorrhagic transformation if the clot length is very high. Like in this case, you can see the clot length is very small in the left M1 MCA. And in this case, the clot length was big from the T occlusion, that is the left ICA bifurcation up to the division of the MCA. You can see a clot length was little big. One more thing we can assess is the clot pervasiveness, that is how the clot is permeable. Whether because these are the areas where the IV thrombolytics works better. Like in this case, you can see the faintly contrast is going through that clot. That means that you are when the neurologist give the thrombolytics, it will pass through that clot and it will lyse the clot. Usually when we take this cases for mechanical thrombectomy, we will find that the clot has been lysed by the IV thrombolytics. And multiple CT angio can be a surrogate marker for CT perfusion. Usually the first phase and second phase correlates with the cerebral blood flow map, whereas the third phase with the blood volume map. Like in this case, the first and second phase of CT angiography is similar to the cerebral blood flow map, and the third phase is more towards the cerebral blood volume map. There was significant mismatch between you can see the color flow between the mismatch between the cerebral blood flow and blood volume. For that patient, we took the patient for mechanical thrombectomy and she recovered very nicely. And third thing, after CT angiography, if required, we will do CT perfusion, where a predefined area has to be selected and the contrast has to be injected, and there will be relative increase in density followed by peak and followed by decrease in density, and that has to be plotted in a time attenuation curve, and the different color maps will be generated by the deconvolutional and kinetic models. How you do in our setup? We have 128 MDT scan. Usually 8 centimeter region of interest has to be selected, and preferably in the right antecubital vein will give the contrast, and 40 to 45 ml of contrast to be given, and multiple dynamics will be taken, one dynamic for 1.5 second, nearly about 45 seconds, so near about 30 dynamics will be taken, and that dynamics will generate the different types of color map, and we can calculate. Normally the core region, the cerebral blood flow will be significantly reduced compared to the oligemic region and the penumbra region, and the blood volume, that is the main difference, where the core it will be reduced. However, the penumbra and oligemic region it may be normal or increased. The mean transit time will be significantly high in the core region, but it will be less in penumbra and the oligemic region. A basic difference will be in penumbra region the cerebral blood volume will be normal, will be increased. For example, in this case there was occlusion and pen peeling of the MCA. We did the perfusion scan. You can see the blood volume and blood flow. There was not much significant difference. The penumbra recuperation ratio, that is the penumbra salvageable tissue ratio, was coming around 32%. If it is above 50%, usually the candidates are the good candidates for the mechanical thrombectomy. What the guidelines say that if the large core volume more than 70 ml, the penumbra core mismatch ratio less than 15 ml, and the penumbra core mismatch volume less than 15 ml, and the ratio less than 1.8. These are all poor outcomes for the mechanical thrombectomy. CT perfusion will give this data. You can assess whether to go for any procedure or not. After CT, we can have MR based protocol. MR is very sensitive for detecting early stroke, and it is very informative in posterior circulation stroke, stroke mimics, and the wake up stroke. What we do in our setup, we do diffusion, flare, SWI, top MRA, or if required MR perfusion after giving 10 cc of contrast. If you are not going to give contrast, then we can have non-contrast based perfusion, that is ASL. As I told that MRI can detect early infarct as early as 11 minutes because of its cytotoxic edema. Suppose a patient comes with a suspected case of stroke and you are not getting anything on MRI, then sometimes you can increase the B value from 1000 to 2000. You can able to see the infarct proper. Like in this case, there was multiple infarcts in the left occipital lobe in the left PCA territory. One more important aspect is the diffusion flare mismatch. Usually it comes within 4.5 hours. The neurologist will specifically ask you whether there is diffusion flare mismatch, because they are going to thrombolize, because thrombolysis period is within 4.5 hours. You can able to tell that diffusion. You can below that image you can see there is no infarct in the flare images. However, the infarct is established in the diffusion image. And on SWI, you can see the susceptibility vessel sign. These are all RB series clots, and usually shows better outcome with stent retriever thrombectomy. And this is the diffusion, SWI, and the perfusion mismatch. You can see the impact is very much less on diffusion. However, you can see the perfusion abnormality as well as the congested vessels on SWI. That is the mismatch between the diffusion, perfusion, and mismatch. In ASL, you can calculate the perfusion value. You can see the infarct is very much less compared to the perfusion abnormality, but it can show arterial transit artifact. So usually we prefer to have the contrast based perfusion rather than the ASL based perfusion. But in this case, there was no mismatch between the diffusion and perfusion. In the era of artificial intelligence, the AI can calculate the mismatch volume for you. Like in this case, the mismatch volume was 116 ml. Those are the candidates for the mechanical thrombectomy. So imaging approach will be, we have to calculate the aspect. After that, we will do for the angiography, whether there is large vessel occlusion or not. Large vessel occlusion means that up to the M1 or P1, how if the brain vessels gets affected, then we can take for mechanical thrombectomy. Actually, what the guidelines say, when the Mr. Clean trial came in 2015, up to 4.5 hours, there will be both mechanical thrombectomy and the thrombolysis, but 4.5 to 6 hours only mechanical thrombectomy. But in 2018, Dawn and Diffuse trial came, the thrombolysis remains the same, but the mechanical thrombectomy period extended up to the 24 hours. Generalizely, we like the large vessel occlusion with good aspect, we will take the patient for mechanical thrombectomy. If it is poor aspect, the patient will not do better. So, we will not take this case for mechanical thrombectomy. Suppose there is a large vessel occlusion and there is significant mismatch. Suppose diffusion getting small amount of impact and the NIH score is very large. So, this is a case for mechanical thrombectomy. We usually do mechanical thrombectomy by different techniques: stent retriever technique, aspiration catheter technique, or the combinedly both stent retriever aspiration, that is known as the Solumbra technique. You can see in this animated video the stent retriever technique and the aspiration technique. Normally for stent retriever technique the microcatheter and microguide will pass through the clot. After that only we will take out the microguide wire from the microcatheter. Then we will subsequently advance the stent retriever, and then we will take out the microcatheter, and the stent retriever will engage that clot. We will wait for around 3 to 4 minutes. After that only we will take out the stent retriever along with the clot. Similarly, for aspiration catheter, we will advance the aspiration catheter to the mouth of the clot. Then we will engage the aspiration catheter to the mouth of the clot. The proximal end of the microcatheter will be attached to the aspiration machine, aspiration pump, and that will suck out the clot from the intracranial circulation. There is advancement of the different types of hardwares over the period of from 1999 to 2018. Now the materials are also evolving. This is balloon guide catheter. There is significant advancement of the microcatheter, micro stent retriever, as well as the aspiration catheter. You can see it is also evolving, and it will in future it will come in a robust way. What the guidelines say that this is a class 1 indication for mechanical thrombectomy. The number needed to treat as low as 3. So the guidelines is more in favor of the mechanical thrombectomy. Coming to some of our case which we did in our institute, she is a 29-year-old female, known case of cardiomyopathy, presented with 3 hours of onset with right side hemiparesis and aphasia. Her NIHS was 11. We did the CT scan and CT angiography. There was infarct in the left basal angular region, as well as left M1 was occluded on CT angiography. Aspect was 6. We did the mechanical thrombectomy for that patient, and clot was taken out from the intracranial circulation. On follow-up CT scan showed no further progression of the infarct, and you can see the patient was not able to talk before the procedure, as well as right hand weakness, and immediately after taking out the clot from the intracranial circulation, the patient was able to talk, and she was completely normal. This is second case. She is a 47-year-old female who presented with left side weakness of 8 hours duration. Her NIHS was 12, and the aspect was 6. There was a right ICA occlusion. You can see the right ICA complete occlusion after the ophthalmic artery, and we did the mechanical thrombectomy in the middle of the night and took out the clot from the intracranial circulation, and TK3 flow was achieved, and there was not much progression of the infarct, and you can see how the result. You can see the patient was talking and going normally without being any deficit. To conclude, there is a paradigm shift from the time window to tissue window because of the collaterals. NCCT and CT angiogram is the time-saving approach for the stroke. MRI is very helpful in posterior circulation stroke, wake-up stroke, and rule out the stroke mimics. And if the patient comes beyond 6 hours of ictus, CT and MR perfusion can be done to assessment of the penumbra, and the mechanical thrombectomy has class 1 evidence for within 6 hours of onset, and class 2 evidence for stroke who presented with 6 to 24 hours of duration. Lastly, I want to say stroke treatment is not that difficult as we think. We just need confidence and proper training for especially our resident to take up the intervention as a future course. Particularly, you can save lives in the emergency period. I definitely request all the residents present here, because in the PG time I also did not do any intervention, but now I am doing all part of neuro intervention. So it is not that difficult. Just we need that confidence and the proper training. Thank you.
Thank you, sir, for starting us off with a thorough presentation. I would now like to request Dr. Amit Kumar Sahu to felicitate sir. Our next speaker is Dr. N. Jayaseelan. He is the head of neuroimaging and interventional radiology at MOSC Medical College Hospital, Kerala, with an interest in pediatric neuroimaging and stroke interventions. He has made significant contributions to the field, spanning more than 40 publications. He will be laying out the 2021 update in the WHO classification of adult diffuse gliomas, followed by his second talk on a case-based approach to leukodystrophies.
Very good morning to everyone. Thank you for the kind introduction. At the outset, I'd like to thank the Odisha IRA and ICRI and the team from IMS and SUM for giving me this opportunity. So the first talk is on adult diffuse glioma, the changes in 2021 classification. Disclosures none. So this is the objective of what I'm going to talk in another 20 minutes. So the key changes in 2021 classification and how it's impacted and changed the way we report tumor, and about radiogenomics, the imaging markers in predicting genomic phenotype, and a few newly described tumors, and the new buzzword, that is AI in neuro-oncology. So why there is a need for 2021 updations, that we need to understand. So when you look at the tumors, previously, what we do is, once we find a tumor, we try to grade the tumor based on WHO classification, based on the histopathology. So, but what they found is some other tumors may appear low grade without any enhancement. We will label it as low grade tumor, but ultimately when you look at the prognosis, some other patients doing bad. Same way, some tumors on imaging will appear very aggressive, but these patients with the proper treatment, their survival is good. So the reason is kind of difficult to understand, especially for the oncopathologist, when we follow the dual classifications. So the answer to the difference lies in the molecular genetics. So that's why WHO 2021 classification becomes important. So if you look at the slide, now it is more simplified. We are able to achieve the simplified definition because of the incorporation of molecular factors in the diagnosis of tumors. And it has a direct prognostic implications. So this is the most important slide. I think the residents should follow it. So when you consider the diffuse gliomas, first thing we have to see is the IDH status, whether it is mutant or wild type. So in the wild type, if there is a microvascular proliferation, necrosis, TERP2 mutation, EGFR, then we'll call them as a glioblastomas. That is IDH wild type, CNS WHO grade 4. So if it is IDH mutant, then next stage is they look into ATRX mutation, TP53 mutation. If it is retained and with 1p19q co-deletion, it is IDH mutant oligodendrogliomas. If it is ATRX mutation is there with microvascular proliferations, we got the separate entity is called astrocytoma grade 4. And another important thing we need to observe here is so even though if a tumor is of astrocytoma IDH mutant grade 2-3, if it shows the specific mutation, that is CDK2A/B deletion, then it is automatically upgraded to WHO grade 4. So the imaging becomes relatively irrelevant at this point. So when we compare the glioblastoma with astrocytoma IDH mutant, there is a difference in prognosis. Astrocytoma grade 4 relatively do better compared to glioblastoma wild type. So since we are incorporating the molecular genetics, can we actually grade the gliomas based on advanced neuroimaging? The answer to the question is definite no. So the way we report needs to change when we are reporting any gliomas. So let's see one example, case-based example. So it's a middle-aged male presented with the first episode of left focal seizures. This is a diffusion, T2, flare, and coronal T2-weighted images. Here we can see a classic tumor. There is a right medial temporal is expanded and it shows altered signal intensity lesion, which is hyperintense on flare, and it is also extending deep to insula and into the gangliocapsular region. And in perfusion, there is not much increased perfusion and there is no enhancement. And in MR spectroscopy, there is some choline peak and some myoinositol peak with fall in Na. There is no lipid lactate. So imaging wise, we will label it as a low-grade gliomas, maybe grade 2. So can we actually do that? So if you see here, if you go by WHO 2016, we will label them as a astrocytoma grade 2. But if the same tumor on histopathology, if it is showing homozygous CDK2A deletion, it will be automatically upgraded to IDH mutant grade 4 tumor. So we can't label them as a low-grade tumors. One thing we can say is a diffuse glioma needs further molecular testing to say whether it is low-grade or high-grade tumor. So similar kind of lesion, medial temporal lobe. Again, the medial temporal is markedly expanded. There is a lot of hemorrhage. The enhancement is intense. There is a lot of necrosis. And in ASL, the perfusion is increased. And in MR spectroscopy, again, there is a huge choline peak with lipid lactates. So imaging wise, it shows all the aggressive features. So previously, we used to label it as a directly glioblastomas. But the thing is, we can't. So with the same tumor, which is IDH mutant, so it can be still astrocytoma grade 4, not just glioblastomas. So even the tumor which is showing the very aggressive features with necrosis, lot of enhancement, increased perfusion, with marked lipid lactate peak, don't label as a glioblastoma. You can label it as a high-grade features are there. It could be either glioblastoma or grade 4 astrocytoma depending on IDH status. So why this difference is important is the patient with grade 4 astrocytoma, the prognostically they will do better with maximal resection, RT and chemo compared to glioblastoma IDH wild type. So this is a crux of story. Some grade 2 and grade 3 tumors behave like a glioblastomas due to specific genetic features, that is CDK2A. And not all the grade 4 tumors are glioblastomas. Imaging wise, it may look glioblastoma, but still it could be astrocytoma grade 4. So similarly, in pediatric type diffuse glioma also there are few changes. They have been grouped into high grade and low grade depending on molecular factors. The specific mutations are RAS, MAPK pathway and also histone H3. The histone H3 is associated with the high grade features, whereas RAS MAPK is often associated with low grade features. So let's see one example. So this is a 12-year-old girl presented with her headache, vomiting and mild right hemiparesis, diffusion T2, post-contrast images, expansor lesion which is extending from midbrain all the way down to pons. There is no enhancement. It looks low grade. But if the same tumor which is showing H3 histone positive, then it will become high grade tumor. So the molecular features becomes the primary differentiating factor to consider whether the tumor is low grade or high grade. Imaging, yes, is definitely adds to it, but if the tumor which is having low grade features on imaging, you can't certainly say that it is a low grade tumor. Same way, if it is a high grade features, you can't say that it is a glioblastoma. So with this, the role primarily in grading the tumor is limited. So now we move to radiogenomics. So is there any imaging wise we can able to find out the particular genotype? Why it is important is this IDH 1p19q co-deletion CDK2, it's not available everywhere. And these tests are relatively expensive. So imaging wise, if you are able to tell particular mutation status, it adds immense value to the management. So if we are adding the high grade features, then obviously the surgeon will be more aggressive in treating that lesion. So that becomes very important. So the ultimate goal is to non-invasive prediction of tumor behavior and to assess the response to treatment and prognosis. So some of the radiogenomics which we consider are T2 flare mismatch and MRS in predicting IDH and imaging markers in detecting 1p19q co-deletion and BRAF mutation. So what is T2 flare mismatch? So it is something has been described has a specificity close to 100% for IDH mutant 1p19q non-co-deleted tumors. So the important core criteria is complete or near complete homogeneous high signal on T2-weighted images, which is showing suppression on flare images. Some additional features are there should not be any contrast enhancement. The cystic and necrotic region which are showing suppression should not be considered as flare mismatch. And suppression can be inhomogeneous, not necessary that it has to be completely black on flare images. That also another factor which we need to consider. So let's see one case example. So axial T2 flare images is a fairly large, well-defined lesion in the left frontal lobe, which is also extending into insula and temporal lobe. As we can see, flare images, the central region shows the inhomogeneous flare suppression, and the lesion is not showing enhancement, no increased perfusion, and some choline and lactate. So this is a typical imaging appearance of T2 flare mismatch. If you find this T2 flare mismatch, you can label it as IDH mutant non-co-deleted tumor, that is astrocytomas, not ODG. So coming to role of MRS, yes, it can be helpful to detect the IDH mutant gliomas. So once this IDH mutant wild type happens, it's a TCA cycle. The alpha ketoglutarate is converted to hydroxyglutarate because of the mutant IDH1 and IDH2 status. So this peak can be picked up on MRS, but in routine day-to-day practice we try to apply, but it's very difficult to pick up because it is often overlapped with your glutamate peak. So here we can see IDH mutant wild type, we are not seeing any peak here, but here we can see a small peak which is located somewhere in 2.3 ppm. So this is your 2-hydroxyglutarate peak. But routine day-to-day practice very difficult to apply because of these issues, because often glutamate and glutamate peaks often overlaps in this region, and we need advanced post-processing tool to be able to apply this in routine day-to-day practice. So coming to 1p19q co-deletion, these are typical features which we need to consider. If the lesion in frontal lobe, more of cortical involvement, presence of calcification, ill-defined margin with minimal edema, and enhancement which is variable with increased perfusion. If all these features are fitting into a particular tumor, we can tell them that it is ODG. ODG means nothing but 1p19q co-deleted tumors. So here is an example, frontal lobe lesion, presence of calcification, more of cortical involvement with some white matter extension, there is no hemorrhage, there is a focal enhancement which is showing increased perfusion. So it's a typical feature of ODG, we can label it as a 1p19q co-deleted tumor. So another is a BRAF mutation. BRAF mutation is being described with some low-grade tumors. So they have this typical appearance. They have the cyst with enhancing mural nodules. Although they are low-grade, they do tends to show low ADC values with the peritoneal edema. So here we can see one example. This is from the article Pediatric Neuroradiology. So this is a tumor which is located in right capsuloganglionic region. Here we can see low ADC with the peripheral cystic changes and central region which is showing contrast enhancement. So this is another tumor which is similar morphology, but ADC is not low. So this is a mutant, these are all wild types. So there are few newly described tumors that have been included in description, that is includes the MVNT and plenty, that is multilocular vacuolating neuronal tumors and pleomorphic neuronal tumor in young. So this is one of the classic example of MVNT. So the lesion is very striking. Here we can see multiple VR space-like lesions which are subcortical in location, and they will be in chain. They will be like a necklace. And most importantly, they will be giving bright signal on diffusion, by which we will differentiate from VR spaces. VR spaces will follow the CSF signal, whereas this MVNT most often they will appear bright on diffusion-weighted images, and obviously there will be no bleed, and C sequence is particularly helpful to see this pattern. So when you have this kind of appearance, we are dealing with the MVNT, and these are no-touch lesions, and they obviously don't need any follow-up also. They are benign. So this is another described tumor in WHO21 classification, that is a plenty. This is from an article case. It's a densely calcified lesion which is showing some peripheral enhancement, so subcortical in location. If it is the same lesion cortical, we would call them as a ODG. Subcortical, densely calcified, few peripheral enhancement without increased perfusion is almost typical for plenty. So the final segment is the AA. So AA comes in a big way because we know by using the texture analysis, every step in the disease diagnosis to the treatment to the follow-up. Now AA has been studied, and it adds to the value because it can able to do the texture analysis which we can't humanly possible. So it can able to quantify the ADC volume. There are a lot of studies are going on, and they adds to the diagnosis as well as in the follow-up these deletions. So these are some of the studies which have been published. Use of AI in differentiation of glioma, meningiomas versus pituitary lesions, hemangioblastomas, pyrocytic astrocytomas, ependymomas, medulloblastomas, and differentiating GBM from PCNL, LGG, and results were quite impressive. And how far it will be useful for routine day-to-day practice, only future can tell. But it's coming in a big way, and maybe in another 5-6 years becomes part of our routine day-to-day practice. So these are some of the cases where AI has been studied to know the mutational status. So 1p19q co-deletion, ATRF status, and other steps. So important thing is we need to understand the molecular factors which will determine the prognosis. And in imaging point of view, when you deal with the low-grade features, just add it is a low-grade features, but you can't say that the tumor is definitely low-grade, because if the CDK2A mutation is there, it becomes automatically grade 4. And a similar way, if a high-grade features are there, yes, you can say that it is a definitely high-grade tumor, but don't label as glioblastomas, because they can be still to be astrocytoma grade 4, which is having relatively better prognosis compared to the poor prognosis IDH wild-type glioblastomas. And obviously, the technology continues to evolve. There needs to be a collaborative effort among the clinician pathologists as well as radiologists, will help to further shape the future of neuroimaging and in diagnosis as well as treatment. So any question on these tumors? So this is a second part of talk, the case-based approach to leukodystrophies. Disclosure none. So this will be the brief overview of what I am going to talk. So introduction, imaging modalities, the approach, and case-based discussion for pediatric as well as adult white matter disease. So coming to white matter disorders, what are white matters? These are the tracts which are connecting the gray matter to different parts of the brain. The key components are axons, oligodendrocytes, and myelin sheath. So these terminologies which you all should know. What is leukodystrophy? This is abnormal myelin. That is a white matter which is growth is abnormal. Then demyelinating disorder is already formed myelin is getting destroyed due to some disease process. The classic example is multiple sclerosis, neuromyelitis optica, spectrum of disorder, and MOG. And group of hypomyelinating disorders where the myelin formation is very slow process. So we need two imagings. We can't label on single imaging whether the lesion is hypomyelinating or leukodystrophies. We need two imagings to see there is no internal progression. And vascular disorders, hereditary as well as acquired, can affect the white matters. And also metabolic disorders like the vitamin B12 deficiencies, electrolyte sugar imbalance, drug toxins can affect white matter. And obviously the infection that is a prototype for white matter involvement is PML. So the imaging is mainly based on the pattern recognitions. And the important thing which we need to understand is the change. The imaging pattern is kind of dynamics. We image at the particular point in time, so that time the findings may not be typical, or it may be typical, but if the disease is advanced, everything will look the same. So that we need to understand. So modalities, we have ultrasound, CT, MRI, PET. I am not going to the details. So ultrasound is basically useful in neonatal period. Mainly we limited to PVL and intracranial hemorrhages because we have the window to look into the brain. So these are the different stages of PVL, hemorrhage, confluent areas, IVH. So CT, as far as white matter disease, the role is limited, but except in few situations. It helps to identify the calcification because there are the few disease entities which I will be discussing later where finding calcification is adds to your diagnosis. And obvious drawback is radiation. And MRI is often the modality of choice, but problem is in doing this MRI in neonatal period because it needs sedation. And use of gadolinium is also an issue nowadays because we do see cases which have gadolinium deposition in brain. So try to avoid contrast, especially in young people, because we don't know how the things will be in future. So the typical protocol is T1, T2, FLIR, SWI, D2. It doesn't require any advanced imaging. The basic sequence is more than enough to make a diagnosis for white matter disease. So before going to the abnormal, we need to know what is normal, because if you know the normal, then only we will be able to find what is abnormal in it. So as a residents, we all should know what is a normal myelinations, which area of the brain which myelinates first, and how it is progresses, so that we need to understand. So at birth, there should be the myelination in the posterior limb of internal capsule and also in the brainstem and in the perirolanic regions, and gradually the myelination progresses posterior to anterior and deep to periphery. And subcortical region is the region of the brain which myelinates last. Usually myelination is completed by 3 years, but except the peritrigonal region, which may persist even in adult also. And temporal lobe subcortical wave matter is something which myelinates last. So coming to the approach, most important thing is clinical profile. So the typical presentation is the birth history, which will be uneventful in most of the situations, except in few metabolic encephalopathies with progressive deterioration. That is entirely something which is entirely different from hypoxic ischemic encephalopathy, where the presentation we have some history and they will progress. So uneventful birth history with the progressive deterioration, we are dealing with most often it is a leukodystrophy. And the further clinical presentation is depending on whether there is involvement is predominantly white matter or it is a gray matter. If it is a white matter predominate, the presentation is usually late with motor dysfunction, ataxia, and they may have megalencephaly. Whereas if it is a gray matter as involvement, often there will be microcephaly, and the presentation will be more of seizures, mental retardation with extrapyramidal signs. So the clinical profile is important. Once we are done with the clinical, we are suspecting leukodystrophy. The second is we need to look at the involvement of brain, how the brain is involved, whether the involvement is symmetrical or asymmetrical. If it is a symmetrical involvement, obviously we are dealing with diffuse process. Most often it is leukodystrophies. So here we can see the involvement is symmetrical, bilateral. So this is a leukodystrophy, but here the involvement is kind of asymmetrical, some of them are the discrete lesion. This is a simple white matter change. So symmetrical or asymmetrical involvement, that is the first thing to do. Once we are done with symmetry, second, we have to see which region of the brain is most involved, whether it is a frontal predominant, parieto-occipital predominant, periventricular predominant, subcortical, brainstem, or cerebellar involvement. That we will see in case-based examples. So that is the second step. Then third thing we need to look is a certain leukodystrophy has a specific distinctive features by which we can directly we can label the particular leukodystrophies. That is something the residents should follow, because most often it will be in spotters in exams. So lesion with the CSF signal intensity, cyst cavitation lacunae, cadacil, leukoencephalopathy with axonal spheroids with Lebrun disease, that we will see in examples. And the presence of susceptibility signal abnormalities, that is in cadacil, and enhancement that we see in adrenoleukodystrophies, Alexander disease, and abnormal peaks in MRI, that is NAA peak we will see in Canavan's disease, and also there are few abnormal peaks in cerebrospinous anthematosis, and involvement of spinal cord, that is usually in adult onset autosomal dominant leukodystrophy. So that is the third. First is symmetry, second is which region of the brain is more involved, and the third is any specific distinctive imaging features. It's stuck. It's not working. Slide is not moving. I think you have to close. Okay. So let's start with some cases. 25-year-old male with progressive cognitive decline. So CT, the first thing is symmetry. So here what we are seeing is symmetrical involvement, which is involving the periventricular white matter. And in MRI, there is a symmetry. And which region of the brain is more involved? It is the periventricular region of the brain is much more involved than compared to subcortical and other regions of the brain. And diffusion, there is no changes, and there is no enhancement in post-contrast images. And in MRS, there is some choline peak with reduction in NAA. So this is another companion case. Again, the first thing is we have to look at the symmetry, bilateral symmetrical involvement. So we are dealing with leukodystrophy, and pattern is predominantly periventricular. And in this case, the lesion is becoming more advanced. So there are cystic changes are also seeing, and definitely there is no enhancement. And in spinal cord, there is some linear enhancement along the nerve root. So leukodystrophy with predominant periventricular white matter involvement with some without any enhancement. So it's a diagnosis for metachromatic leukodystrophy. So it is a lysosomal storage disorder, and the typical imaging appearance is centrifugal, confluent, symmetrical, butterfly-shaped periventricular deep white matter lesions, and U fibers and cerebellum is paired with tigeroid and leopard appearance, and additionally there is other features, that is a corpuscular involvement, and there will be no enhancement, that is more important, and sometimes we may see the enhancement of cranial nerves and cauda-equina nerve roots. So this is another case. Here again, the first thing is symmetry, but here the involvement is limited to parieto-occipital regions. Again, it is periventricular and confluent. But here in post-contrast images, here we can see enhancement, which is a leading zone of active area of myelin destruction. And in MRS, there is a choline peak with lipid lactate. So these cases differ from other cases. There is a diffuse involvement of periventricular white matter, but here the limitation to posterior periventricular regions with enhancement. That is the difference. So this is a typical for X-linked adrenoleukodystrophies. This is a classic imaging appearance which you get, and contrast enhancement is something which is very typical for X-linked adrenoleukodystrophy. So another case, but here the pattern is frontal, but enhancement is similar to what we saw in previous case. So adrenoleukodystrophy, there is a frontal variant of adrenoleukodystrophy. This is a frontal pattern of adrenoleukodystrophy with anteroposterior gradient. So this is another case. Again, first thing is symmetry. Here what is striking is both lamina which are appearing hyperdense, which are appearing dark on T218 images with some periventricular white matter changes, and clinically hypertonia, auditory and visual impairment. And what additional features we are seeing is involvement of posterior fossa with brainstem involvement, and even the optic nerve which are found to be thickened and they are hyperintense. So this kind of imaging features is typical for Krabbe's disease. So presence of basal ganglia and thalamic calcification, periventricular parieto-occipital infratentorial white matter involvement, and involvement of corticospinal tract, and thickening of optic chiasm nerves is something which is specific for Krabbe's disease. So another case, here again symmetry which favors the leukodystrophy. Here the involvement is more extensive, periventricular, but if you look at the FLAIR images, we are seeing the marked signal suppression. That means the entire region becomes liquefied. So the white matter is disappearing. So that it itself clinches the diagnosis. It's a case of vanishing white matter disease. So its appearances almost look like that of our metachromatic leukodystrophy with more aggressive form with the entire liquefaction of white matters that favors the vanishing white matter disease. So another case, female newborn seizure spore feeding. So the striking feature is symmetry. Again, we are dealing with the leukodystrophy, and diffusion changes are very striking. There is a normal diffusion restriction in posterior limb of internal capsule, which is extending all the way down into the brain stems, and also peri-Rolandic region involvement. That is a corticospinal tract involvement. So the diagnosis maple syrup urine disease. So one striking feature is presence of diffusion restriction, and more often they present very early. There is a newborn MRI with this kind of typical diffusion restriction. Most often the diagnosis is maple syrup urine disease. So here again symmetrical involvement, but here there is a frontal predominant. There is both periventricular as well as subcortical white matter is involved. And another striking feature is presence of cystic changes in the anterior temporal lobe, which are showing signal suppression without any enhancement. So this is a megalencephalic leukoencephalopathy with subcortical cyst, that is a Vandernapp disease. It's common in Agarwal communities. We can see in North India more often. So the typical imaging appearance is the presence of CSF-like subcortical cyst in the anterior temporal lobes and also frontoparietal cyst. So this is another case, female with the seizure disorder. Again symmetrical involvement, so we know we are dealing with leukodystrophy, but here the striking feature is the periventricular white matter is spared. the involvement is more of subcortical with typical sparing of periodical white matter, and corpus callosum is also spared, and there are few changes in the dendrite region and bilateral anti-temporal of involvement without any enhancement. So there are only very limited leukodystrophy which involves the subcortical with the sparing of periodical white matters. That is only say L2 hydroxyglutaric acidureas. So the typical pattern is subcortical white matter involvement, focal which become confluent and spares the periodical white matter. But if the disease become advanced, there will be the entire white matter involvement. That stage it may become difficult to make a diagnosis. But early stages, isolated subcortical white matter involvement, the diagnosis is almost certain that we are dealing with L2 hydroxyglutaric acidureas. So there's another case, 1-year-old male infant, macrocrania and seizures. So the important thing is macrocrania. So most of the diseases usually, destructive process usually present with microcrania. So macrocrania presentation is usually limited to few diseases. Here again, the involvement is symmetrical, so it is a leukodystrophy, and the white matter involvement is very diffuse. In addition, there is involvement of GB and bilateral thalamus involvement without any enhancement, and MR spectroscopy, we are seeing a tall NAA peak. So we know it's a case of Canavan's disease. It is due to the mutation in N-acetyl aspartyl acetase that leads to the accumulation of NAA-like metabolites within the brain. So macrocrania, diffuse involvement, symmetrical, with the MRI showing NAA peak, so we are dealing with Canavan's disease. So these diseases, most often what we described so far is a pediatric. And adult, there are few more entities. Some of the pediatric disease can have the adolescent and also adult presentation, like metachromatic leukodystrophy, Krabbe's disease, and adrenoleukodystrophy can present in adult also. And some of the disease which is specific to adult leukodystrophies are leukovasculopathies. And what we routinely see in day-to-day practice are CADASIL, CARASIL, COL4A1 mutations. These are the common lesions that I will show some of the cases. And in astrocytopathies, we have the Alexander disease, CLC2 related leukoencephalopathies, and also vanishing white matter disease have the varied presentation. Can be seen in pediatrics, adult, and in elderly also. So 25 male, gait instability, swelling over the posterior aspect of ankle. So here, what is most striking is presence of blooming in the bilateral cerebellar hemisphere. These are calcifications associated with the cerebellar atrophy and with some signal changes. So this is a image itself speaks the diagnosis. This is cerebrotendinous xanthomatosis, tendinous xanthomas, cataracts, diarrhea, leukoencephalopathies, dementia, and psychiatric symptoms. The classic is the presence of high signal intensity regions in the dendrite nucleus, which is very characteristic for cerebrotendinous xanthomatosis. So this is another case. Again, involvement is more symmetrical. It's adult with Parkinsonism symptoms, with cognitive decline and psychiatric symptoms. Symmetrical, so we are dealing with leukodystrophies. Here the involvement is bilateral frontal and perpendicular as a subcortical, and some cortical atrophy is also there. But more striking is involvement of corpus callosum, which is mainly involving the anterior part of the corpus callosum and also middle fibers. And there are few blooming foci in SWI, and if you look at CT, that clinches the diagnosis. There are multiple small stone-like calcification which is arranged in ring along the corpus callosum. So this is a case of CS of 1R related leukoencephalopathy. Previously it used to be ALSP and HDLS. This is the most common form of adult onset leukodystrophy. This case I got it from Manoj. So age of onset is 40, and important imaging appearance CT. CT we will find fine stone-like calcifications along the corpus callosum. So there are certain leukodystrophy which is involves along with the brain and spinal cord involvement, that is LBSL. This is one such case. Again symmetrical involvement, so we are dealing with leukodystrophies. There is involvement of posterior internal capsules and also posterior fossa along the corticospinal tract, dendrite, peridendrite regions, and also cerebellar peduncle with involvement of spinal cord. So we are dealing with LBSL. So coming to genetic vasculopathies. Middle-aged male, presentation is recurrent migraine with frequent EA. So changes, these are the flare images, some discrete white matter lesions, just like any other fasciculus white matter changes. What is striking is the presence of microbleeds, and there is involvement of anterior temporal lobe. Most often in simple fasciculus changes, temporal lobe involvement is not so common. If you see temporal lobe, subcortical white matter signal changes, you have to think other than the simple fasciculus changes. In addition, if you find microbleeds with involvement of external capsules. So that's how we will differentiate simple fasciculus changes from genetic vasculopathies. So this is a case of CADASIL. So we know the mutation Notch3 gene. So involvement of anterior temporal lobe, it will look like any fasciculus changes in a young with involvement of external capsule and anterior temporal lobe with microbleeds. If these features are there, we can suspect CADASIL. So this is another similar case, but here there is involvement of mainly brainstem. It is taken from article. So here we can see an arch of hyperintensities along the brainstem. It is similar, same vasculopathy, genetic vasculopathy, but it is a CADASIL, autosomal recessive form of arteriopathy. MRI findings are similar to CADASIL with typical MRI appearance in the brainstem, which is a arc of signal change along its middle cerebellar peduncle. So again, this case from article. Here, symmetrical involvement. There is a cystic cavitation with bleeds and multiple tortuous vessels. So bleed, ischemic changes with tortuosity of the vessels seen in COL4A related vasculopathies. There is another entity which is also related to COL4A1 mutation, recently described as a PADMAL, that is a pontine autosomal dominant microangiopathy and leukoencephalopathies. And the features are almost similar to what we see in COL4A1 with a predominant involvement of PONS, or sometimes it may be isolated to PONS. So this case is from the Calicut, from one of the private hospital. So middle-aged male, again recurrent stroke with cognitive decline. Again, extensive involvement with multiple cystic changes, which a few of them showing calcification. Just 2 more minutes. So what we are seeing, the extensive calcification. So leukoencephalopathy with the cyst with calcification. So it's a Lebrun syndrome. So the clinical manifestation: seizure, progressive pyramidal, extrapyramidal cerebellar sign, increased intracranial pressure, ischemic and hemorrhage. This is one of the conditions where the neurosurgeons have the role. Sometimes this cyst may be huge. They may obstruct the ventricles and produce hydrocephalus. So they may need neurosurgical intervention. So this is one of the recent case. Again, there is extensive white matter involvement. Elderly male with slowly progressive dementia, presented with acute onset left hemiparesis. So what is striking is the SW changes. We are seeing the multiple microbleeds which are typically located in gray white matter junction, and there is a diffusion restriction in the parietal region with cortical edema, with sulcal effacement, and there are numerous microbleeds in the corresponding region also. So elderly male, slowly progressive dementia with extensive vascular changes with microbleeds which is subcortical, with cortical edema in right parietal region. So this is a cerebral amyloid angiopathy related inflammation. So it is an inflammatory variant of CAA. Sometimes we do encounter these cases, patient present with seizures. And most striking feature is presence of microbleeds which is at the gray white matter junction with extensive white matter changes. So to conclude, the important thing is the structured approach. First thing is we have to see the clinical, whether normal child at birth, then progressive deterioration. Then depending on gray matter or white matter involvement disease, the presentation will vary. If it is a predominant gray matter disease, the presentation will be seizures. White matter will be ataxia. They may have macrocephaly. If it is a gray matter disease, there will be microcephaly. So the approach will change. And once we look at the images, look at the symmetry first, then move to which region of the brain is more involved. And the third is typical imaging features which I have shown. If you apply all these, we will arrive to the reasonably close differential diagnosis. But saying so, in spite of all, we apply almost 50% of cases we may go wrong also. And some other leukodystrophies will remain undiagnosed even with genetics. So always discuss with your clinicians, that is more important. And try to get the genetic follow-up also, by which your confidence will also increase. That is more important. Because most of the cases nowadays they do for exome genoing and try to follow it up, because it will take 1 month sometimes to get the report. But make sure that you note down the case findings and try to call the bystanders and patient relatives what was the genetic mutations, by which you will learn also. Thank you.
Thank you, sir, for all those updates and a very engaging discussion. I request Dr. Ambika Mishra to kindly come up on stage and felicitate the speaker. Now, I have an announcement for all the rest. Hello. Sorry about that. I have. Can the last person hear me? Announcement for all. Dr. Sikandar Sheikh has asked that we form teams of 3 participants each for the film reading session. I request all of you to kindly jot down your names on a piece of paper and please submit it to the registration desk outside. If you have any queries, then you can contact me or any of the organizing team members. And we request you to please do this as soon, because Sikandar is formulating questions according to the number of teams. Thank you. Next, we have Dr. Amit Kumar Sahu, Head of the Department and Chief MSK Radiologist at Max Smart Super Speciality Hospital, Saket, New Delhi. He will be teaching us about the diagnosis of inflammatory versus degenerative arthritis, followed by a session on MSK infections and their mimics.
Hello. Hello, hello. So good morning everyone. Before this mic problem is solved, I would just like to tell you that Dr. Manoj and Dr. Jason, they had an excellent presentation on neuroimaging. And so from neuroimaging, we will move on to musculoskeletal imaging. And I feel that musculoskeletal imaging is a no-brain imaging. So it will be much simpler imaging than neuroimaging. And I have clubbed 2 similar topics together. One is the inflammatory versus degenerative arthritis, and other is the infection in the musculoskeletal imaging, which is a similar topics. And then, hello, yeah. And so I will be taking some 40 minutes or so to complete both the topics. So when we come to arthritis imaging, it itself is a big disease process in itself. And till a couple of years back, it was all about clinical diagnosis which was made on arthritis. But with the advancement of the imaging perspective and also the radiologist more engaging with the clinicians, so the imaging also has come up in a big way as a role in diagnosing the arthritis. There are 2 major bodies in arthritis imaging and creating the criteria. One is the EULAR and one is the OMERACT. And very recently, they have also included the radiologist in that group. And as I will go on with my presentation, I will show you how the imaging has played such an important role in changing the diagnosis and also management of the arthritis. So why I have selected this inflammatory versus degenerative arthritis as a topic, because these are the 2 major group of arthritis which in the day-to-day practice, more than 95% of the times you will find this arthritis as your own practice. I don't have anything to disclose. Apart from that, after hearing the talks from Dr. Manoj and Jisum, that my talk will be much simpler than that. So when we talk of arthritis, so as is a very commonly what we think is a painful inflammation and stiffness of the joints. And during our medical school career, we have all read about the duller, ruber, calor tumor and functional issue, which we used to call as combinedly as an inflammatory arthritis. So inflammatory arthritis has various etiologies, and not to anyone's surprise, the infectious arthritis is also a part of the inflammatory arthritis, because in that also there is inflammation and involvement of the joint. The major category of the inflammatory arthritis is like comprises of autoimmune factors, and that's why I have included what we call as the most commonly is the rheumatoid arthritis. The second common which we find in practice is the seronegative spondyloarthritis. We do see commonly juvenile idiopathic arthritis in children, and there is a large group of inflammatory arthritis which is also separate from the RA and non-RA group, which is a group called as the Sappho syndrome, which is a syndromic thing, and in children this is also called as the CRMO, which is chronic recurrent multifocal osteomyelitis. There is a big group of arthritis which involves in the connective tissue disorders, as well as in some malignancies like ovarian malignancy. So the first patient comes to a clinician, and when they see the clinical examination is done, there is always a significant overlap between the types of arthritis. So that's where the history and the imaging plays its role. Even history and physical examination also has multiple overlaps. When the patient comes to the clinician, we ask about we also should not forget that we are also clinical radiologists. So we should also take history from the patients when we are talking of the imaging. So in case of crystalline arthropathies, which I will be talking in next couple of slides, so these are usually acute onset. Even the infectious arthritis, they also have an acute onset. Whereas in case of the autoimmune inflammatory arthritis, it is usually a subacute or an insidious onset. The infectious arthritis are usually monoarticular, but this is also always not a dictum, because with the growing tuberculosis in all over the globe, not only in the developing countries or underdeveloped countries, so they also involve polyarticular disease as a tuberculosis. Crystalline arthropathies, usually they start with monoarticular, they can move on to oligoarticular and then polyarticular. Similarly, the autoimmune inflammatory arthropathies, they also usually start with monoarticular, but gradually they progress to polyarticular pattern. So this is how, when the presentation to a clinician or to us is there of the arthritis patient, we can think of these possibilities. There are various lab parameters which are done. Most common but very non-specific are the ESR and CRP, which are usually raised, but they are definitely a marker. There is other things like thrombocytopenia, hyperuricemia, anti-CCP and RF factor, according to which the different classification of arthritis is based on. I would like to highlight one thing, that in case of gout, when there is an acute condition of gout in 80 to 80%, 88% of the cases, the hyperuricemia won't be there, right? So it doesn't mean that if it is no hyperuricemia, it is not a gout. The clinician's approach to arthritis is whether it is a articular disease or a periarticular disease. Articular disease is what I have already told in my last slide, whereas periarticular disease is a multiple causes which do not involve the joint, but they involve around the joint. So there can be anything from bursitis to like any pain in the joint or any around the joint. The rheumatoid arthritis, they comprise the major group of inflammatory arthritis, as you see from this pie chart. The second common is the spondyloarthropathy, which include 3 different categories. And then gout, CPPD, and polymyalgia rheumatica, they are also a major group which form the inflammatory arthritis. And there is another miscellaneous group which is also called as the unclassified arthritis. When it comes to imaging, so there are 3 like basic imaging by using which we can come to most of the conclusion of arthritis. The radiograph, which is indispensable and is the primary modality. Ultrasound is definitely very important, and I will show you very nice examples how ultrasound has helped us in doing that. MRI, yes, when there are some cases where we are not solving it by radiograph and ultrasound, MRI can be used. Other modalities which are less often used, but they are also helpful as the nuclear medicine. DECT is one of the imaging which has come up in a big way, not only in differentiating the crystalline arthropathies, but is also in other inflammatory arthritis. And definitely intervention has its role when we are not solving anything on imaging. The primary role of imaging is early detection and delineation of different types of inflammatory arthritis, and definitely we want to prevent this from happening of any patient. When we talk of imaging features, there are very limited things which we have to play around, and then we have to come to the diagnosis. The first thing which I spoke on in the first slide was the category of the pathological joint involvement. And when you see, like, hand is called as the basic radiograph which can talk of the type of arthritis. And if there is involvement of the proximal joints, like the wrist joint as per se the radiocarpal and intercarpal joints, so that is usually a rheumatoid arthritis. And if it is a distal joint involvement like PIP, the different interphalangeal joints and metacarpophalangeal joint, then you can think of non-rheumatoid arthritis such as psoriatic arthritis or other seronegative arthritis. This is a very nice example of two different patients. So this is a whole limb radiograph which we do for the alignment of the lower limb. If you see this in this patient versus this patient, here there is very uniform and symmetrical joint space involvement of both the knee joints. There is a lot of destruction which is happening, and there is new bone formation which is called as large osteophytes around it. Compared to this joint, and if you compare the knees of the same patient, both sides, here what you see, there is uniform joint space reduction which is asymmetrical if you compare with the other side. We are not seeing any large osteophyte here, and also we are not seeing any severe destruction or the articular surface which is sclerotic in this case. So we did a MRI, and this is the first case where you see there is cartilage is not so much destroyed. There is large soft tissue which is causing destruction, and this destruction or the erosions are marginal. So this is a case of rheumatoid arthritis. Whereas the second case, you can see here, there is joint space reduction of the patellofemoral, there is large osteophyte, there is subchondral marrow reaction which is happening with cyst formation, there is meniscal extrusion, and this is all a classical case of a osteoarthritis. The joint space narrowing is actually a very important criteria, because based on that we can talk of where is inflammatory versus degenerative. If there is a single joint involvement, it can be infection, and I told that infective arthritis is also a type of inflammatory arthritis. If we see more than one joint involvement, then it can be either rheumatoid arthritis or seronegative spondyloarthropathy. And as I told, the proximal involvement will be RA and distal involvement will be spondyloarthropathy. In case of degenerative, it can be typical or atypical osteoarthritis. In case of typical osteoarthritis, the example which I showed, there will be symmetrical non-uniform joint space reduction, there will be osteophytes, there will be new bone, there will be sclerosis at the articular surface. Whereas in case of atypical osteoarthritis, which can be secondary to any of these conditions, in such case, you will get osteophyte formation, but then along with that, you will get the primary disease feature also in that case. Also, there is a type of osteoarthritis, the typical osteoarthritis, which also present as an inflammatory stage or a destructive stage, or also is called as erosive osteoarthritis. In that case, you will get an angry looking joint, but the features of osteoarthritis will be preserved. So this is an image taken from the internet where it shows of a normal joint. Marginal erosions you will see in the inflammatory arthritis. In osteoarthritis, there will be central erosions. In erosive osteoarthritis, there will be central erosion with osteophyte formation, which is called as the gulving appearance, and also the central penicillin cup appearance, which we see in the psoriatic, where there is a marginal erosion causing the destruction of the side margins, and there is a central tip of the pen which is seen. In case of crystal arthropathy, typically tophus, you will get the juxta-articular erosion. So these are two different cases. Here there is proximal joint involvement. The distal joints are looking relatively fine, apart from one of the joint which shows some joint space reduction and there is some osteophyte formation, versus the other this one where I think the marker is working. I'll just use this marker. Okay, this is better. So here what you can see, there is a new bone formation around the joint, the periarticular new bone formation. So this is a case of rheumatoid arthritis, where the other one is a case of the psoriatic arthritis. Other two common examples, here the same RA patient where there is proximal joint involvement, and in this case what you see, there is involvement of the first carpo-metacarpal joint and there is involvement of the DIP joints. And as you see the DIP joint, so there is osteophyte formation, there is central erosion, and this is what is called as the gulving appearance, which is seen in multiple distal interphalangeal joints. So this is a rheumatoid arthritis versus osteoarthritis. This is the both wrists of a same patient. What we are seeing here, the left wrist is absolutely normal, whereas in the right wrist there are a lot of central erosions, which is involving the radiocarpal joint as well as the ulna and also the intercarpal joint as well as the carpo-metacarpal joint. So this is a case of a infective arthritis. Coming to the role of ultrasound, so if you see this, this is taken from one of the articles where they have reviewed articles and they found that from in 2000, from like 2005 to 2020, in fact, there are a lot of articles which have come up talking of different roles of the ultrasound. And there is one of the articles which talked of, I think, some 78 joints. So imaging 78 joints, which was not practical. And now currently what the role is, like ultrasound should be definitely used as a screening for arthritis, whether it is what type of arthritis it may be, apart from the radiograph, which is a baseline investigation, and then you can think of moving into any other investigations or then doing more of a detailed ultrasound imaging. The role of MRI comes when there is a bone marrow edema, which we cannot see in the radiograph or the ultrasound, and in case of assessing the various areas which are inaccessible to the ultrasound, such as the sacroiliac joint. And also in case of disagreement between the clinical findings and the ultrasound findings. Also in case of secondary complications of arthritis, definitely MRI plays a role. So couple of years back, I wrote this article on added value of high resolution ultrasound in MRI and MRI in the evaluation of rheumatological diseases in association with the North Carolina University, Dr. Girish. It is a nice article to go through. It's a comprehensive article where we have talked of the ultrasound and MRI. Okay, so when we talk of synovitis, so there are different grading. So the right side of the screen, this is all the grayscale grading, whereas this is the power Doppler grading of the synovitis, and this is being defined by Euler and Omeract groups, which I spoke of previously. When we talk of erosions in ultrasound, so erosion should be like seen in two planes, both in the short axis and long axis, which we call in ultrasound. There should be reverberation, there should be irregular margins, and if you put Doppler, if there is an active erosion, you will see neovascularization within it. So this is an active erosion versus a normal bone, which you see a smooth cortex. But there can be pseudo-erosions, which you see in the wrist, in the dorsum, in multiple carpals and metacarpals, where you will see a smooth margin, but there won't be same dip which will be seen in the other planes. So it will be just seen in the single plane, which is smooth margin without any reverberation. So that is how you differentiate between the erosion and the pseudo-erosion. In MRI also we can very nicely see all the erosions which is there in the carpals. There is a lot of synovitis which is happening, and there is also tendon inflammation, which I show in the next image. Tenosynovitis is a very nice thing which you can see in ultrasound. So here what you see is the central is a normal tendon, and around it which is the inflamed synovium of the sheath, which you are seeing in the long axis and in the short axis view. And if you put power Doppler, you can see very significant Doppler which is happening. So this is a active tenosynovitis which is happening. This can be also seen in the MRI, right? So before we move on to the crystalline arthropathy, I would like to talk of the concept of enthesis, which is very important to differentiate the psoriatic or seronegative arthritis. So enthesis is the site of attachment of the tendon, ligament and the joint capsule. It can be fibrous or non-fibrous, and it can be it has the attachment to the muscle and the bony attachments, where it can attach by a ligament or a tendon, and then it can also have a diaphyseal or metaphyseal attachment to the long bone, as you see in the deltoid and the insertion to the humerus. This concept is very important. I would like to highlight this couple of slides. So in concepts of enthesitis, so this is what the classical example of a bone is, and this is the area of enthesis where there is attachment of the tendon. There will be bursal space also, and if there is any ligament attachment, that is also can be seen here. So this is ultrasound image. This is the calcaneum, this is the Achilles tendon, and this is quite a better example to show. This area is called as the enthesis, where there is a bony insertion of the Achilles tendon. There is a retrocalcaneal bursa also. Whenever you see inflammation in this region, it is called as the enthesitis. So this is an example radiograph where you see there is some increased soft tissue density and swelling in infrapatellar region. And if you see the MRI, so there is this thickening of the patellar tendon, and there is also inflammation in the bone as well as in the tendon and in the Hoffa's fat pad, which is also seen in the axial images. So this is a classical example of a patellar enthesitis. You also do see multiple enthesitis at multiple places, like around the hip joint, around the shoulder joint, and also in the paraspinal muscles. Moving on to other big group of inflammatory arthritis is a crystalline arthritis, which is constituted majorly by the gout, and the rest group is the pseudo gout and basic calcium phosphate disease, which under which comes as the hydroxyapatite deposition disease, or HAD, which was previously considered to be a disease of the Europeans, but we do see in Indian a lot of times now. There is various types of crystals according to the classification, but we know that MSUD is one of the most common of them. Previously, it was thought that long back the gout only happens in the grade 2, and that's why it was called as the podagra. As you see in this case, there is erosions there is marginal or juxtaarticular erosion in the grade 2. Also, there was erosions in the metatarsophalangeal joints as well. And when you search the air, you will find, when you type podagra, you will find this image where there is a rich man with at least 3 to 4 wives, and still the foot is injured or this gout, but still happy to eat more food. This is a classical example where you see a large juxtaarticular erosion and the overhanging edge, what you call, in the case of gout, and the density of a crystal which is seen here, causing the erosion, which was a tophus. And this is the ultrasound image of the same patient, where you are seeing the erosion, and then there is a large echogenic tophus which is sitting on the erosion. There is also, this is the extensor carpi ulnaris tendon along the ulnar side, and there is also inflammation secondary to the tophus. Other important sign which is not very specific but sensitive is a double contour sign which you see in ultrasound. And double contour is called because this is the normal cortex, and above the cartilage there is the MSCD crystal deposition. So you see another echogenic line over it. But this is also seen sometimes in case of the CPPD, and also in case when there is a good amount of joint effusion, which we call as the cartilage interface sign. But there you have to differentiate it by seeing in 2 different planes, and you will see that echogenic line will be seen in both the planes in case of the gout. And this is an article of the imaging appearance of the gout, which is in 2013 written, nicely written article. You can go through this article. MRI also do help in cases where the ultrasound is not available, or maybe the expertise is not there, where you can see in this case, there is a large tophus sitting on the patellar tendon, and this is the fat suppressed image where you are seeing in the axial image also. There is a large tophus which is causing also destruction or invagination into the patellar tendon. This is the image of a dual energy CT, where you all know that when you see a green crystal, green area, that is a tophus, but not all green are tophus, because there are a lot of artifacts also in dual energy CT. So my time is over for this, but for the next talk I will be taking less time. So in next 20 minutes I will be covering the other topic also. This is another example. What you are seeing here is like a lot of destruction happening in all multiple joints, and if you see the radioscaphoid joint is predominantly spared, but there is involvement of the first carpometacarpal joint and multiple interphalangeal joints. Another interesting thing what we are seeing here is there is soft tissue calcification in the region of the triangular fiber cartilage complex. So this is a case of CPPD. CPPD is many times underestimated in our practice, and we do less call it as a disease of inflammatory crystalline arthropathy rather than it should be called. The pathophysiology of CPPD starts with the cartilage, then there is a cartilage destruction, and the crystals go into the joint, causing inflammation of the joint and then destruction of the bones. There is an overlap between the different stages of CPPD. from the acute crystal deposition to chondrocalcinosis and also to the gradually to the chronic arthritis. This is a very interesting case which I think we did 2-3 months back. The patient came with a backache and we did the MRI where we saw this destruction and inflammation. Initially we thought of a small node which we commonly see, but because of the signal and then in the gradient there was some blooming, we did a CT and you can see there were some crystals which were seeing inside it. And there is also the disc calcification which was seen, and this in the axial images was much seen nicely better, and this is a case of a CPPD. The other last category, I would like to show the image of the HAD which I was talking of. So HAD are like hydroxyapatite deposition disease, a type of calcium deposition, where there are there are too much of inflammation which when there is deposition happens. So this is what you see in the black are all the crystals here. In the gradient image also you are seeing at the attachment to the supraspinatus and infraspinatus tendons. The interesting thing which is happening here is it's also extension into the bone, and there is cicatrization of the bone which is happening. So there is an intraosseous extension of the HAD. In such cases, we as radiologists play a very important role by doing a barbotage procedure, and this I did in my institute where initially there's a large tophus. We did the tophus, there's a large crystal deposition here, and then we did the barbotage where you can see we have aspirated the chalky material, white material, and in later couple of weeks we did the follow-up radiograph, and there was near complete resolution, and the patient was very active, and the pain went after a couple of days only. So this is a procedure which can be done in a daycare and very nicely done. To conclude, the radiography is definitely the primary imaging, and screening ultrasound should be done in all cases of arthritis because it is a very cheap modality and easily available. We only need little expertise, and I would request everyone to try to do ultrasound of the joints to be familiar with the normal anatomy and the structures of the musculoskeletal imaging. The imaging helps in guiding the treatment and also in taking clinical decision making. MRI should be used only in suspected cases of when there is a discrepancy between the basic imaging and the clinical the thought of what the disease is. Also in case of secondary complications, but apart from that, MRI is generally not used much in arthritis, at least in our practice. And in case of doubtful synovitis, never hesitate to put a needle to find out what it is there inside. So this is a chapter from my book, which I was the editor of Sutton recently, and arthritis is very nicely written by this Stephen Jude. He is from Germany, and he wrote very nicely the article of the arthritis. Whatever I've spoken, he has written it in more detail. Thank you. And before I move on to my next talk, the people who are interested for musculoskeletal imaging, and nowadays I would request you that because of the changing dynamics of radiology, everyone should at least know one of the subspecialty, and though they should do general radiology, but they should be interested in one of the subspecialty. People who are interested in musculoskeletal imaging, next year we are having this national conference of musculoskeletal imaging, which is clubbed with AMS in Ahmedabad, and you can try for the early registration. Thank you. So I will topic which is the next topic is similar to inflammation, which is like infection of the bones and the joints. And I will be showing you this, the whole 15 minutes will be more of case presentation on different mimickers of the osteomyelitis and the infective arthritis. I don't have anything to disclose. So this is a nice illustration which talks of what is acute osteomyelitis is. And here what you see is, this is the epiphysis. Sorry. So this is the epiphysis, this is the physeal plate, this is the metaphysis, and these are the transphyseal vessels which generally are seen in the children, and as the child grows there is a fusion of the physeal plate, the transphyseal vessels they stop growing, and then it is either the metaphyseal or epiphyseal vessels. Why this is important? Because the extent of the disease in osteomyelitis depends upon this, because predominantly it is a hematogenous spread of infection. So In case of acute, this part of the side, this side is basically the acute pathophysiology of osteomyelitis, and this side what is explained is the chronic stage. In acute, what you will see, there will be bony destruction, there will be cortical breach, there will be a subperiosteal abscess formation, and then this can gradually lead to a rupture of the subperiosteal abscess leading to a sinus formation, and which can be seen through a cutaneous surface. Along with that, there will be sequestration, which is a dead bone formation. Around the dead bone, there will be involucrum, which is the remodeling of the bone around it, and then there can be a sinus tract, which we see. This is a classical example. What we are seeing is a metaphyseal lytic lesion, well defined. There is definitely a narrow zone of transition to some extent, and proximally the zone of transition is wider because we are not seeing there's a permeative area here. One supportive thing what we are seeing here is the bulge in the cortex, and also there is a thick periosteal reaction which is happening. The rest of the bones is looking absolutely fine. There is some sort of osteopenia which is happening here. In the lateral radiograph, we confirm that there is no bony breach which is happening. So this is a case of acute osteomyelitis. This is a very nice picture of a chronic osteomyelitis, though we don't see nowadays in a tertiary care hospital such type of image, but it came to me last year, where there is classical sequestrum which is seen. You are seeing a cloaca, we are seeing the involucrum, which is the bone formation. And chronic osteomyelitis or features with this radiograph, we should be very cautious to differentiate it from Ewing sarcoma, because it is one extreme of the disease. And the acute versus chronic osteomyelitis clinically depends upon the time of presentation. Radiograph definitely helps in coming to that conclusion, but there may be overlap between the clinical and the radiographic findings. MRI do help in further imaging, like further coming to a conclusion or say helping in the management. As we can see marrow edema, periosteal reaction. Here you can see all diffuse edema in the humerus. There is circumferential periosteal reaction which is seen all around in all the sections. And there can be soft tissue edema as you are seeing around it, and also regional lymphadenopathy can be seen. Now osteomyelitis, we do come to a inference when we see a different patterns in the bone. So based on different patterns, I will show you what the mimics are and what the differentials can be. Very commonly what we see in osteomyelitis is a permeative pattern. Now here what we are seeing, there is permeation of the proximal ulna, maybe also in the radius, as you can see in the other view, and also in the humerus, there is a lytic area. So this can be a multifocal osteomyelitis. And this is the MRI which we did. And here what you can see is there is all diffuse bone involvement, multifocal, but we are not seeing any periosteal reaction. There is no soft tissue component as such. There may be some periosteal edema, but no abscess formation. There is no periosteal reaction. So this was a case of lymphoma. The patient also was screened for other systemic involvement, and this is the ultrasound of the abdomen which showed the bowel involvement in the lymphoma. Next case is a 6-year-old which came to pain in the both lower limb, and there was pallor and fever on presentation. This is the radiograph of the left leg, and what you see is the permeative destruction of the bone, predominantly the tibia. The fibula is also involved. There is linear, smooth periosteal reaction which is uninterrupted. So again, there can be a thought of osteomyelitis. MRI was done, and in MRI you can see there is multiple bone involvement. There is a lot of soft tissue beneath the periosteum, and there are large lymph nodes also. So this was a case of leukemia, which is an acute lymphoblastic leukemia. Coming to the next pattern, which is a marrow edema pattern, which we do see in the osteomyelitis also. This is a same case where there is a fat suppressed and non-fat suppressed image. You are seeing ill-defined marrow edema. There is some periosteal thickening or periosteal reaction which is happening. The inner cortex is not well visualized, and in the non-fat suppressed image you can see nicely there is thick periosteum along the medial cortex. The axial image, if you see, there is this periosteal reaction which is redemonstrated. There is soft tissue edema also, and these are the consecutive sections which shows that edema pattern, and there is also some cortical reaction as well as some signal which we are seeing within the cortex. We did a CT and it gave us the diagnosis of a osteoid osteoma. So intracortical osteoid osteoma with thick periosteal reaction, and initially it was mimicking to be a osteomyelitis. This is a case of 52-year-old female who complained of pain and swelling in the forefoot. The patient was diabetic, and then clinically there was a suspicion of a osteomyelitis. And this is the radiograph, which was not revealing anything. It was absolutely normal in appearance. MRI was done, and then what we see in the coronal image, there is some soft tissue edema around the metacarpal and metatarsal. And as you see the axial images, what you see here is there is a long segment of marrow edema. There is some sort of the cortical thickening and also soft tissue edema. So this was a case of stress fracture. So these are two different cases, and very interestingly, it was done in a couple of days time. And after we saw these images, we have 11 cases of this similar case series, where these are all young people. They come with the pain. They're young active people. Either they are a sports person, or they are actively doing sports in school, and they come with sudden onset pain in the leg. And multiple imaging has been done in other places till the time they come to us. And biopsy has been done. It was thought of Ewing sarcoma. It is sort of osteomyelitis. A lot of things has happened. Treatment has been given. But then we follow it up conservatively without doing anything. And these all come out to be a tibial stress syndromes. So I think next, one of my fellows, they will be presenting this case in RSNA. We have 11 cases of this similar type in a 2.5 years time. So this is very interesting. These patients, they are unnecessarily treated and biopsied and treated for long-term antibiotics for osteomyelitis also. This is a case-like image of the same patient where we did the knee and the ankle imaging, and you can see there is diffuse edema which is seen in the metaphyseal region and quite symmetrical. And this is what we call as CRMO in children and SAPHO syndrome in adults. So though it is named as chronic recurrent multifocal osteomyelitis, but this is an inflammatory condition and doesn't need an antibiotic treatment. It is just anti-inflammatory and symptomatic treatment, and the patient gets the healing. Next pattern of osteomyelitis is the periosteal reaction pattern. And as you see these two different cases, in one case you are seeing this smooth periosteal reaction which is happening in the proximal diaphysis of the tibia. Here what you are seeing in contrast is a osteolysis which is ill-defined. There is a narrow zone of transition. There is some periosteal reaction seen. I am not sure, maybe there is a small breach in the periosteal reaction. Both the patients complained of similar fever, pain, couple of weeks. And this is the MRI of both the patients. In the first one, what you are seeing is smooth periosteal reaction. There is some soft tissue edema also. The other case, there is soft tissue component, not just edema. There is a breach here, which was seen in the radiograph also retrospectively, and there is soft tissue edema. And this is the coronal MRI of the same patient, where you can see a well-defined, in non-fat set sequence, there is a nice, well-defined lesion with a periosteal reaction. So the first case is osteomyelitis versus the second, which is a Ewing sarcoma. This is quite obvious, very aggressive looking lesion with lot of interrupted and lamellated perpendicular periosteal reaction, which is seen. There is also a Codman's triangle may be seen on both sides of it. So this was a case of osteosarcoma. This is another example of osteosarcoma where we are able to see this some permeative pattern of bone destruction here. And in the lateral radiograph, if you can see, there is some osteoid matrix which is also seen. And here there is a Codman's triangle or interrupted periosteal reaction which was seen. So this case was initially treated as osteomyelitis in some place, came to us, we reviewed the radiograph, and then we did an MRI. And in MRI it was quite obvious that is the osteosarcoma, malignant lesion definitely. And MRI helped us to see that there is also involvement of the epiphysis which was not sure in the radiograph. This was an interesting case. A 64-year-old male who came with swelling and intermittent watery discharge in the calf region. This patient came from Himachal Pradesh, and this patient was suffering for long in his hometown, treated with multiple antibiotic, aspirations, whatnot, and this was the radiograph. What we are seeing is here is the central large area of lysis. There is some bone scalloping or maybe destruction, not sure. There is scalloping definitely in the anterior cortex of the tibia. and there is some speculated type of periosteal reaction or heterotopic ossification maybe, which is happening. And then this is the CT and MRI of the same patients, where you're seeing multiple calcification. There is some soft tissue which was seeing lucent in the radiograph, and that is looking quite bright in the MRI on T2 weighted images, and it is showing some peripheral heterogeneous enhancement. The biopsy came out to be a calcific myonecrosis, and we published this in 2022, I think. And this was like imaging wise also it was not very sure, but definitely when we see such type of radiograph and CT retrospectively, it is learning for us that calcific myonecrosis should be considered in such one of the differentials. Coming to the last pattern, which is focal osteolysis pattern, these are two different examples where you are seeing in the epiphysis a lytic area with maybe some sclerotic margin, and another lytic area here without any sclerosis. This is the MRI of the first case where you are seeing heterogeneous signal with diffuse marrow edema in the epiphysis. There is no breach in the physeal plate, and there is some periphyseal edema. So this is a chondroblastoma, and the classic histopathological feature is chicken wire calcification, which we see. The second case where there is this lytic lesion without sclerosis, what is seen here, and there is also breach in the cortex. So this was a case of the osteomyelitis of the epiphysis, which causes Brod's abscess. This is a progressive imaging of the same patient who came with pain in the shoulder. Radiograph was done, and we also did ultrasound where there was a lot of rotator cuff abnormality. There was also some sclerosis in the superior margin of the humeral head. There is some glenodization which is seen in the acromion, and the patient was treated conservatively, and then later on came with what is happening here. We did the MRI. So this is the case of a neuropathic joint. This is the same example which I showed in the last talk, the intraosseous had. This also sometimes can mimic osteomyelitis by the pattern of the bony involvement edema and also the bone formation which is around, but this is actually a crystal arthropathy. So to summarize, when there is a suspected osteomyelitis, plain radiography is definitely the primary modality to exclude the fractures, to use it as a baseline imaging, and also to demonstrate any osseous changes. If MRI is contraindicated, then do go for nuclear medicine gamma camera to see whether there is any bone involvement or not, and accordingly whether there is osteomyelitis or any metabolic bone disease. If there is no MRI contraindication, then you have to detect early osteomyelitis by different features as I showed as example, and also demonstrate the marrow and soft tissue involvement to see for further management, like follow-up on after management. So clinical presentation and laboratory findings are definitely important before we do imaging to narrow down our differential or to think what imaging we want to do. We should be well aware of what imaging features are of different types of osteomyelitis and their mimics. We should definitely try to rule out stress fractures, hematological malignancy, Ewing's and osteosarcoma, as well as CRMO and SAPHO, because the treatment of all these diseases are very different from osteomyelitis. Right? Thank you. I'm open to questions any of the two topics if you want to. Thank you.
Thank you, sir. Both your lectures were brilliantly informative and structured. I would now like to call upon stage Dr. SSG Mahapatra to felicitate Dr. Amit.
Check.
I would now like to proudly welcome I would now like to proudly welcome my senior and former graduate of IMS and Some Hospital, Dr. Sumedha Singh, to the podium. Dr. Sumedha Singh is currently a consultant radiologist at the Institute of Neurosciences, Kolkata, having completed an MSK Imaging Fellowship at Dinanath Mangeshkar Hospital. She is also a visiting fellow at the Hospital for Spinal Surgery in New York. We are glad to have her here today to talk about the shoulder joint, focusing on the rotator cuff and labrum. Yeah. Laser pointer chahiyega. Okay, thank you.
Okay. A very good morning to everyone. I am Dr. Sumedha Singh. I have done my post-graduation from here, so thank you Satya sir and Adya sir for inviting me for this talk. My topic for today is imaging of rotator cuff and glenoid labrum. I'll try to keep it very short and interesting. So discussing the MRI. The role of MRI is to look at the cartilage, ligaments, tendons, muscles, and it is an expensive modality, but it gives you the most detail out of all the imaging modalities which we have for musculoskeletal imaging. So what is the MRI protocol which we should be following to look at the shoulder? At my Musculoskeletal Imaging Training Institute, I did that from Dinanath Mangeshkar Hospital in Pune. We used to follow this protocol in which we did proton density fat-sat images in all these three sequences and sagittal T1 and coronal T2 images. So I'll start with the basic rotator cuff anatomy first. So the first image, the image to your left, is the anterior aspect of how a shoulder joint should look like. So the anterior aspect, you can see this is the subscapularis muscle. From the coracoid process originates the short head of the short head of the biceps. From the supraglenoid tubercle originates the long head of the biceps. Above the coracoid process, you can see part of the anterior part of supraspinatus muscle, and this is the anterior 1/3 of the supraspinatus tendon which is visible. Coming to the posterior aspect, which is the image on your right side, you can see this is the spine of the scapula, and the muscle which is above the spine of the scapula would be the supraspinatus muscle. The muscle which will be below the spine of the scapula will be the infraspinatus, and the muscle below it would be teres minor. So approximately infraspinatus and subscapularis have a similar muscle bulk. Supraspinatus is smaller and teres minor is way smaller. So this is the imaging sequence, how it should be taken. So there is a common question which is asked during our vivas also as to what should be a plane of imaging. So we should be imaging it according to the supraspinatus tendon, as I have drawn here according to the tendon plane. So now I'll straight away jump to the pathologies of rotator cuff and how it looks like. So if you look at the tendon here, this is a PDFS sequence. So on a PDFS sequence, the supraspinatus tendon or any rotator cuff tendon should be looking jet black. But if there is some hyperintensity within it, that is when you should be suspecting tendinosis. So how much hyperintensity is important? So if the hyperintensity is fluid-like, that should be a tear. If it is less than fluid and looking something like this, that would be tendinosis. Okay? So what are the, now I'll just go through the how we should be nomenclature, how should we describe the tears. So the tear is in the supraspinatus. We can actually divide the supraspinatus tendon into three parts. The part which is facing the subacromial subdeltoid bursa are the bursal sided fibers. The part which is facing the glenohumeral joint are the articular sided fibers. And the fibers are, the in between fibers are the intrasubstance fibers. So I'll just show examples of tears of each of the fibers. Coming to the articular sided tear, here you can see I've marked with my red arrow here. There is a defect here, right? Can you see? So this is a partial sided articular surface tear, and the same thing is represented on this graphic illustration. So when you're describing a tear, you should focus on which side the tear is from. Also the thickness of the tear, whether it is partial thickness or full thickness. Coming to bursal sided tears are a little difficult to catch compared to articular sided tears even on MRI because they just look like fraying. They don't look like full thickness defects most of the times. So if you look at this image here, you can see there is some fraying here. So this is how a bursal sided tear would look like. Similarly, on the sagittal image also, it will be very difficult to just catch it on a sagittal image. Coming to intrasubstance tears, more often than not, intrasubstance tears will not happen in isolation. It may be a extension from articular sided to the intrasubstance or from a bursal sided to intrasubstance. Sometimes in tendinosis, there may be multiple interstitial tears going into the tendon. So this is just an example of an articular-sided tear with interstitial extension. What is a rim rent tear? So this is a question which is quite often asked during our vivas also. So in a rim rent tear, it is nothing but just an insertional tear. If you go to Radiopedia, rim rent tear, they will say that rim rent tear is as good as a pasta, but it is not. Rim rent tear is a term which has come out of vogue now, but rim rent tear is an insertional tear in which there is avulsion of the insertion from the greater tuberosity, but there is no retraction. So that is how we differentiate a pasta from a rim rent when it comes to discussing with our surgeons. So in my previous institute also, we used this terminology only if there was no retraction. Coming to full thickness tears. Now full thickness tears are used when none of the fibers are visualized, as in these images. If you can see, I cannot make out any fibers that are attached to the GT here. The fibers are torn and retracted up to the mid-humeral head. Similarly, in the sagittal plane, you can see that there is non-visualization of any fibers lying above it. I hope it's clear. Coming to full thickness tear, the additional finding which we need to mention in full thickness tear is the grade of retraction. We also must mention as to how much the torn fiber has retracted up to, because that also guides our surgeons as to how much they are supposed to pull the tendon back to the insertion site, and their surgical outlook also changes according to the stages given in our reports. So if the retraction of the tendon is up to the lateral 1/3 of the humeral head, that would be stage 1. Up to mid-humeral head, that would be stage 2. Near the glenoid or beyond the glenoid, that would be stage 3. So that is how we grade our tears as well. So you can use the grading for partial thickness and full thickness tears both, depending on how much the tendon fibers have retracted. Coming to fatty replacement. So apart from the tear, it is also important for us to tell what the muscle bulk situation is like of the rotator cuff. The muscle bellies of the rotator cuff are preferably looked at T1 on sagittal views, and we prefer the Y view which we look for in the rotator cuff atrophy. So the Gotelia classification, all of us have read that the grade 1 is fatty streaks, muscle is more than fat in grade 2, grade 3 would be muscle equal to fat, and grade 4 will be fat more than muscle. So based on what the fatty atrophy is of the patient, sometimes surgeons also decide whether they want to prehabilitate the patient or rehabilitate the patient. So if the patient is having a very bad fatty atrophy, they send the patient to rehab first before operating. That is how the norm was at our institute, and that is what they did. So it is also important for us to mention what the status is of the rotator cuff muscle belly, not just describe the tears. Coming to calcific tendinitis. Now there are many causes of calcific tendinitis, that being hydroxyapatite deposition disease, as sir just mentioned in his previous slides. But we need not focus on what the cause is. In our reports, we might just mention what the calcific tendinitis is there or not. On MRI, it is often difficult to pick it up because it is also hypointense as the tendon is. So it is important for radiographs to also assist us during our reporting. So in this case, if you can see that there is a hypointense structure here which is towards the bursal-sided fibers of the supraspinatus. It is also important in calcific tendinitis to mention whether the calcification has bursally extruded, is there any associated bursitis, because that also changes the management. Coming to massive chronic complete tear. Now this is a Geiser sign, this is often a spotter. For Geiser sign, what really happens is that the rotator cuff is completely torn. The glenohumeral joint now starts to communicate with the subacromial subdeltoid bursa. The second thing which has to go wrong here is the acromioclavicular joint also has to be degenerated. So the glenohumeral joint fluid extrudes to the subacromial subdeltoid bursa and goes out through the degenerated AC joint and presents as a palpable subcutaneous mass. So our clinicians are often able to make this diagnosis on their own without any imaging that there must be a complete thickness rotator cuff tear. This is the imaging correlate of the same. So when do we use massive rotator cuff tear and global rotator cuff tear? Massive rotator cuff tear is used when 2 out of 3 are torn. Global is used when all 3 tendon tears are present. We also have to give the types of acromion, whether it is type 1 which is flat, 2 which is curved, 3 is a pointy acromion with a bony spur, and 4 would be a curved acromion. Coming to keel spur is a type of acromion which also causes a lot of impingement and it is concave in shape. Now, due to the lack of time, I'll just try and go to labrum next, because infraspinatus tears are also similar to what supraspinatus tears are going to look like. All tendon tears appear similar. One thing which we have to remember in infraspinatus tear is that there can be an isolated myotendinous junction tear as well, not always an insertional tear. Subscapularis complete tear is often accompanied by biceps subluxation. So I'll straight up go to glenoid labrum. So what is a normal labrum clock position like? For residents, it is also important for us to remember that the anterior aspect, just remember that the anterior aspect would be 3 o'clock, the posterior aspect would be 9 o'clock. 12 and 6 we need not remember because that would come to us naturally anyway. So the 3 o'clock position would be pointing towards the subscapularis, 9 o'clock would be towards the suprainfraspinatus. There are many variants and pathologies of labrum. If I go into the detail of it, it might take much longer. Also, just one tip we can remember is that anterosuperior labral tears are very rare. Anterosuperior labral tears, by that I mean 1 o'clock to 3 o'clock. If you find a linear undisplaced signal hyperintensity at 1 o'clock to 3 o'clock in isolation, and more often than not, it will just be a sublabral foramen or a Buford complex or a sublabral recess at 11 to 1 o'clock position. How will you differentiate a recess from a tear? If you look at the image on your left, this is a sublabral recess. You can see that the linear undisplaced displaced fluid is pointing medially. So this is a sublabral recess, and it is very smooth, very uniform. If it is irregular and if it is pointing laterally, that would be an indication for a slap tear. Okay, so this is how we differentiate on coronal images of how sublabral recess is different from a slap tear. Coming to Buford complex. Now what is Buford complex? Buford complex is when the anterosuperior labrum is absent and compensatory there is a thickening of the middle glenohumeral ligament for biomechanics reasons, and this is a congenital thing. So we should not label this as a tear when we do not see the labrum. Coming to the glenohumeral ligaments, we should remember that we always know that the glenohumeral ligaments are thickening of joint capsules. So superior glenohumeral ligament runs along with the LHB, middle glenohumeral ligament is close to the subscap, and inferior glenohumeral ligament forms the axillary recess. Spiral glenohumeral ligament is inconsistently seen. Coming to the superior glenohumeral ligament, here you can see with the wide arrow here, this is the superior glenohumeral ligament. This is how it will look like on axial images, on sagittal images. These are the ligaments which get thickened during adhesive capsulitis. Middle glenohumeral ligament will go along the undersurface of the subscap, and it is the most variable and notorious of all ligaments because it might have a very different morphology every time in every shoulder you look at. So it does not have a single morphology. It can be as thick as this, it can be as thin as this image here, and it can originate either from the superior glenohumeral ligament itself or from the scapular neck too. So that does not have a consistent anatomy. Coming to inferior glenohumeral ligament, this is the anterior band, the posterior band, and the axillary recess. Spiral glenohumeral ligament originates from the infraglenoid tubercle and inserts onto the lesser tuberosity, but it is very inconsistently seen and is not clinically relevant, but it is a part of the anatomy. Coming to labral tears, I will be discussing about slap tears in general. So slap tears, it is important. Slap tears are causes of micro instability of shoulder. Now there are 4 main types of slap tears, which is superior labral antero-posterior tears. First would be fraying of the superior labrum. Second type of slap would be when there is detachment of the labrum bicipital complex from the superior glenoid. And as you can see here, whereas type 3 would be a bucket handle tear, and type 4 would be when the bucket handle tear has extension into the biceps labor anchor. Now based on these type 4 tears, 4 types of tears, 1 and 3 are the good types. The 1 and 3 are the good types of tears because they are generally debrided. They are not repaired by suturing. Whereas type 2 and 4 are repaired arthroscopically. So I'll just show you how it looks like. This extensive classification need not be remembered by us because ultimately there are only 4 main types which are clinically relevant to the surgeons. So coming to slap type 1, there may be just fraying of the superior labrum as shown in this image. Coming to the slap type 2 tear, here you can see that the tear is extending towards the humerus. The biceps labral anchor is not clearly visible, so this is slab type 2. Slab type 3, you can see a free fragment here, which is the bucket handle fragment, which is formed due to the extension towards the proximal segment, but there is, and when there is complete extension and separation, that is slab type 4. So this is an example from our institute. We had seen a global tear. The entire labral, the slab tear had entirely been extended towards to the entire glenoid labrum. Another sign of labral tears are paralabral cysts. If you see a paralabral cyst and you're not able to make out a labral tear on your MR imaging, that can also be an indication for you to go for a MR arthrogram to further clearly delineate what the tear is really looking like, because paralabral cyst is also a sign of an occult labral tear somewhere. Coming to anterior labral tear, this is also an example where there is an anterior labral tear with paralabral cyst formation. What are the cysts which are important as residents which come for exams are suprascapular glenoid, suprascapular cysts and spinoglenoid notch cyst. Coming to spinoglenoid notch ganglion cysts, these also occur, these are also paralabral cysts which occur post labral injury. And spinoglenoid notch has suprascapular nerve which supplies both the supraspinatus and infraspinatus muscles. So there will be denervation of both these muscles. But when the cyst is only in the suprascapular notch, the only atrophy that the rotator cuff muscles will undergo would be the supraspinatus muscles. So that is how you differentiate between the two. Coming to glenohumeral instability, I'll just show few important anterior, few important labral tears. This is an example of glenolabral articular disruption. Here you can see that the articular cartilage is torn. In this, what happens is that the humeral head dislocates and comes to lie close to the antero-inferior part of the glenoid. And the antero-inferior part of the glenoid has the labrum. So the tear will be in the antero-inferior labrum. But there is an entire spectrum of labrum tear, starting with glenolabral articular cartilage disruption. So here you can see that this is just an articular cartilage injury. The labrum is definitely off the bone, but the bone is not injured per se. The periosteum is also intact. Similarly, this is the graphic illustration of the same. Coming to Perthes lesion, we remember Perthes with a P. In this case, the Perthes, the labrum is just stripped off. It looks like a P, but it is not torn off the periosteum with the bone. So this is an example of a Perthes lesion, and Perthes lesion is best demonstrated on MR arthrogram or in Aber position. Coming to ALPSA, in this what happens is that the labrum is torn off and it is medially displaced as shown in this image. So this is a spectrum, first GLAD, then Perthes, then ALPSA, and then Bankart. So this is the severity of the labral tear. This is a soft Bankart, the first lesion, the first illustration, and this is the bony Bankart. As we know, bony Bankart will take a chip of bone with it along with the labral tear, and the soft Bankart will just be a labral tear without any bony injury. So because of the lack of time, I think this is where I'll stop, and this is just a basic idea of how labral tears and rotator cuff pathologies look like. Thank you, and I'll be happy to take any questions.
Thank you, ma'am. That was a very crisp presentation. We shall now invite Dr. MVK Rao, sir, to felicitate ma'am. We shall now learn about imaging the cruciates, menisci, and ligaments of the knee. I request Dr. Amit Kumar Sahu to please return to the podium and guide us through the same.
Good morning, everyone, again. So this is my last talk on the knee imaging, and I will be predominantly talking of the menisci, cruciates and collaterals. Among this also, I will go a little more detail in meniscus and the intercruciate ligament, and then I will be talking of some biomechanics and mechanism of action which leads to a specific type of injury. So why knee imaging is important? Because that is one of the most common joint which gets injured in active sports person, both in contact and non-contact sports, and in the like day-to-day practice in internal derangement of joint which we see. These are the three common structures which we see which gets injured. I have nothing to disclose apart from that whatever images I will be showing in this presentation will be from my chapter of the knee which I have written in my own certain textbook. So the objectives of this talk will be predominantly I will be reviewing the meniscus, cruciates and the collateral ligaments, their structure, pathophysiology and also the collagen framework which leads to different types of injury. I will be emphasizing on the classic patterns of meniscal and ligament injury, and I'll also provide some of the examples where it has led to misdiagnosis or missed diagnosis of cases. So we as radiologists are just not here to sit and see the images. We also need to interact with the patient. We need to be sure that the imaging is done properly. We are here as a guiding tool to the technologist also, because whenever there is a bad imaging, the reporting will be bad and there will be a final impact on the patient. So how to do a MR or in fact any imaging, that is very important. And it also helps us get ourselves out from the burnout which is happening very frequently in the radiologist in current day practice. In MRI, what we do is the positioning of the knee is very important, where we make the patient supine. There is 15-degree flexion of the knee joint, and the center of the laser beam should be localized at the lower border of the patella. Very, very important is we should use a dedicated knee coil, and nowadays all the machines they are providing the dedicated knee coil. Please avoid using the body coil if you have a dedicated knee coil. The cases where either the patient body habitus is so bulky that you are not able to use the knee coil, then only you use the body coil. These are the various common sequences, and also like the sequences varies from institute to institute. We do a very short protocol of knee and shoulder, and we finish it in 12 to 14 minutes time. Also, like we have one of the machines which is AI enabled, so which talks of like how to shorten the protocol. So we are doing like 2.8 minutes each PDFS sequences. So we do all 3 plane PDFS, which is proton density fat suppress image. We do one non-fat set coronal and one non-fat set sagittal, which is an optional. And based upon different types of pathology what we want to see, we will be able to see in those sequences. So this is an illustration of a knee joint which we know that predominantly formed by 3 bones, which is the patella, femur and the tibia, and in 10% of the cases fibula also contribute to the knee joint formation. So from initially I will start with the meniscus, which is a very important stabilizer of the knee. Though it is not a primary stabilizer, it comes into action when the primary stabilizers such as the cruciates and collateral ligaments, they stop functioning or they are being reinforced not to function. So this is the illustration again taken from my chapter, and this is a normal axial MRI which is taken at the level of the meniscus. If you can see, this is the lateral side, this is the popliteus tendon, this is the lateral, this is the medial, so this is the medial side. The lateral meniscus is quite uniform C-shaped. The anterior and the posterior horns or the roots are very close to each other. That increases the stability of the lateral meniscus, whereas the medial meniscus is a broader C-shaped, where the anterior and the posterior horns and the roots, they are far away from each other, and that's why the medial meniscus is less stable than the lateral meniscus. In order to talk of the pathology of the meniscus, we need to know what the normal meniscus looks like. So this is a sagittal image of the medial meniscus, and this is the lateral meniscus. If you can see, in the medial meniscus, the anterior horn is smaller than the posterior horn, whereas the lateral meniscus is a very boring looking meniscus. Both the anterior and the posterior horns are quite equal. The information of or the knowledge of the meniscal vascularity is important for us to describe where the meniscus tear is, and also for the orthopedicians to decide the management whether they want to go for a surgical or a non-surgical management. During childhood, the whole of the meniscus is completely vascular, which is actually a red meniscus, but as we grow, the peripheral zone is vascular, whereas the central zone is non-vascular. And that is where we want to describe the tear based on what location of the meniscal tear it is. We see in MRI, this looks like a very nice black looking triangle structure is a meniscus, but actually meniscus is not that simple if we go into the collagen framework. This is the image which is taken from the anatomy embryology image, and this is one of the basic image which many of the textbooks they have used. The meniscus, they have two different types of bundle. One, what you see is a longitudinal collagen bundle, like the wood stalks, they are like parallelly arranged, and this longitudinal collagen bundle is being tied up by something called as the radial tie collagen, which holds the individual longitudinal collagen into its place. So this gives the strength to the meniscus, and this is the illustration which I have drawn. So this is the radial tie, whereas this is the longitudinal collagen bundle. And all my pathophysiology and biomechanics of different types of meniscal injury I will be showing on this image. Other important thing which we need to know about the anatomy of the meniscus is the contour and the signal. As I showed in the previous images, the contour of the meniscus should be well preserved, that should be the margins should be quite smooth, and then the triangular shape should be well maintained. Coming to the signal, here I have something different to talk of from the textbooks which talk of different grades of meniscal tears or different grades of signal of the meniscus. So no one is bothered whether there is a grade 1 signal, grade 2 signal, or a grade 3 signal. The clinician will ask you whether this is a tear or this is no tear. If it is a tear, what type of tear it is. So there is no like significance if you are talking of this grade 1, grade 2 or grade 3 signal. And this is what the different type of signal actually looks like. Here what we are seeing is little hydrated meniscus which is looking brighter, and as we grow it become little more mucoid, and we call it as a mucoid change, but it is not a tear. There is this linear signal which is again as the hydration of the meniscus decreases, you see a linear signal which is not touching the articular surface, still it is not a tear. And here what you see is a fluid signal which is reaching the articular surface, either a single articular surface or multiple articular surfaces, which is a actual tear. So I would tell everyone not to use a tear signal like grade 1, grade 2, grade 3 signal. Rather you should talk whether it is a tear or not a tear. Based upon the classification, and this classification is all about how the biomechanics of the meniscus works and what is the mechanism of injury. It can be either longitudinal or radial tears. In longitudinal again it can be horizontal or vertical tears. If there is a combination of the longitudinal and radial tear, it can be a complex tear, it can be a bucket handle, displaced or flipped or flap tear, and the parrot beak tear. I will be showing all those examples now. When we talk of a longitudinal vertical tear, actually the mechanism of injury is a compression. So there is a direct compression, which is a vertical compression which happens on the meniscus on the longitudinal bundle, which will lead to a tear, or the force tries to go through a pathway of minimal resistance in between the two longitudinal bundles, and that's what causes the longitudinal vertical tear as we see in a MRI, as it extends from anterior to posterior vertically. And this is how we see a longitudinal vertical tear, and this is the consecutive sequence sections which I have taken from more lateral or the more periphery to the inner margin, and you are seeing that it is dividing the meniscus into two unequal parts, and it is extending from the anterior to the posterior as we move along. People have also described this as marching cleft sign. In case of longitudinal horizontal tear, the mechanism of force is along as a shear injury, that it goes over along the parallel to the surface of the meniscus, and it is in between. Again, it tries to take the pathway of minimal resistance in between the collagen fibers and along the radial tie. So you will get a tear which is a orientation of the tear is a horizontal as compared to the previous image which was a vertical one. Here you will see again in the sagittal image there will be horizontal orientation of the meniscus tear, and this generally we do more commonly see in the posterior horn of the medial meniscus, and this is actually more commonly tear in the degenerative knee or elderly knee, and whereas in case of vertical tear they are more of a traumatic tears. The longitudinal horizontal tears will be seen like this in different planes, and these are the tears which are commonly associated with parameniscal cyst, whereas vertical tears are less associated with parameniscal cyst formation. So if you are seeing any parameniscal cyst formation, try to see the orientation of the tear. You may get a most commonly a radial horizontal tear, but you may also get complex tears with that. In case of radial tear, again here there is a stress mechanism of injury which is happening, but in this case what happens, it involves both the radial as well as the longitudinal fibers. The shear strain has gone through the meniscus, it is not at the surface of the meniscus. So in that case you will get a radial tear, and radial tear looks like, again it looks like a very boring type of tear because it divides the meniscus into two equal halves anteriorly and posteriorly, and as you move from periphery to center you will get the same tear which is again marching cleft sign for same also. If you get a perfect axial image through the meniscus, you can get a nice radial tear view as you are seeing here. There is another mechanism of injury which is called as the distraction, where there is a rotational injury and the force on the meniscus is both proximally and distal, both two ends, and that causes the meniscocapsular separation and also the corner meniscal tears which we call, and is associated with medial collateral ligament injury also. So here what happens, the force of the injury, it traverses through the longitudinal in between and also involving the radial tie fibers. So that and the force reaches the periphery. That's why what happens, there is a separation of the meniscus from the capsule, and it is called as the meniscocapsular separation, and I will show you a good example here. This is a type of that meniscus separation where this is a popliteus tendon, and the popliteus tendon, this here what we see is the popliteomeniscal ligaments that gets torn, and that is also a part of the capsule. The lateral capsule is also torn here with tear of the lateral meniscus. So this is an example of a meniscocapsular separation. Another example of a meniscocapsular separation is a ramp lesion which we call, and this is usually associated with a high grade ACL tear. Isolated ramp lesion is not seen, though you may get some literature where they have talked of one or two cases of ramp lesion without ACL tear, but actually if you go into the mechanism of action, it doesn't happen like that. So this is a case, same case where you see the high grade tear of the ACL, as I will be talking next, and then there is some edema in the posterior aspect of the posterior horn of the medial meniscus, and this is the region of the capsule. So there is a separation or injury which has happened to the meniscus capsule. Why this is important to the ramp lesion for us to discuss, because this is the area which is blind for the arthroscopists. So if we don't talk of a ramp lesion, then they won't go to that region and then won't repair it. Further, it will lead to again failure of the knee even if they have done a ACL repair. So it is very important to search for ramp lesion when you are seeing a ACL tear. Another type of tear is a bucket handle tear, which is very nicely or easily you can find it out. So in a coronal image, when you are seeing something extra structure apart from the cruciate ligaments, then you try to think whether if it is a bucket handle tear. In the sagittal image, you will get what is classically called as the double PCL sign. This is the parent actual posterior cruciate ligament, and this is the structure which is seen parallel to it. This is a posterior parallel bucket handle tear. There is another type of horizontal tear which is called as a fish mouth tear. What happens, there is a horizontal tear and there is a cyst formation. So this cyst doesn't allow the two faces of the tear to come closer to each other. So that's why in this case either you have to do a arthroscopy or ultrasound guided you have to aspirate it so that the two faces of the tear come too close to each other, and then you can go for a follow-up imaging to decide whether to need a arthroscopic surgery or not. Another type of tear is the radial root tear, which you see in the posterior horn of medial meniscus, as well as the radial inner free margin tear of the medial or the lateral meniscus. There can be displaced or flipped tears, which can be a complex tear, and you can see various fragments which are displaced from the parent position in different sequences. Degenerative tear are usually horizontal, but they also lead to a complex tears as you are seeing here, and this is osteoarthritic knee where you are seeing the laceration or maceration of the meniscus, and there is loss of volume of the meniscus also. The meniscal tear should be classified according to the ISACO's classification, because this is based on this they need to plan whether the surgery needs to be done or not. So as I was showing you the vascular zone of vascularity, if it is a peripheral zone within 3 mm of the capsule, so they generally go for a repair. If it is more than 3 mm, it is beyond the 5 mm of the capsule, so there is a zone of no regeneration. So in that case, repair may not be done. So that's why you have to very specifically talk of the rim width, whether it is less than 5 or less than 3 or more than 5 mm. And accordingly, as I have told you, you have to talk of different patterns of the tear and dimensions. There are few mimics, like in this case, what you are seeing anteriorly is a transverse intermeniscal ligament, which may be confused with a tear of the anterior horn. There can be, here what you are seeing is the posterior meniscofemoral ligament, which is called as the Risberg ligament, and you may think this is a tear, but actually it is not. There are few variations, like this is a meniscal flounce which is seen at the center of the meniscus. There can be calcified meniscus, and then can be discoid meniscus. So these may all mimic different pathologies of the meniscus. Talking of the cruciate ligaments, so we should always make a practice. Okay, this is very good to see the cruciate ligament in the sagittal, but we should make a practice of seeing it in the coronal image also, as well as in this axial image, because the actual attachment of the bony insertions may not be well seen in the sagittal image. But here, if you go to the extremes of the attachments, you can see the attachments very nicely. So make it as a practice to see different planes, not only just the sagittal. Also make a practice of seeing the non-fat setup image to see whether there is tear or not. Here there is a high grade tear of the anterocruciate ligament, there is disruption of fiber, and you can also see same in the non-fat set images. Sometimes what happens, if there is just a edema and you call it as a high grade tear, but actually that the continuity can be seen in the non-fat set suppressed image. This is the coronal image where is showing the same example. You are not seeing the attachment of the anterocruciate ligament to the femur in both the non-fat set and fat suppressed images. So, there is a high grade tear of the ACL. There are some contusion patterns also which talk of what type of injury it has happened. If there is a buckling or this concavity of the anterior surface of the femoral condyle along with contusion in the femur and the posterior aspect of the lateral tibial plateau, this is what is called as the pivot shift injury, and this causes both ACL as well as the medial meniscus tear. This is another example where there is high grade partial tear of the anterocruciate ligament, where there is a complete tear of the anterocruciate ligament. There can be mucoid change which can happen in both the with an anterior as well as the posterior cruciate ligaments, and in mucoid change you will see some cyst changes also. This is also when the clinicians examine, in such cases there can be the anterior drawer test positive and they may think of a ACL tear, but actually it is not a tear if a mucoid change, because mucoid also weakens the ACL, and then there can be anterior drawer test positive, and this is also sometimes an indication for a surgery if there is a instability of the knee joint. The posterior cruciate ligament is less commonly injured. Isolated injury of posterior cruciate ligament is less than 4% in literature. And here what you see is the avulsion of the posterior cruciate ligament attachment to the tibia. You can confirm it on the non-fat suppressed sagittal image where there is bony avulsion as well as the attachment which is seen in the non-fat fat suppressed images. Coming quickly to the medial and the lateral supporting structures. So the medial knee, actually the main medial supporting structure is the medial collateral ligament, which is formed by 3 different layers, the anterior, middle and the inferior or the deeper layer. And this is how the medial collateral ligament attaches from the proximal attachments to the deeper, which is approximately 3 cm distal to the tibial articular surface of the tibia. This is how we look as a normal meniscus, medial collateral ligament in the coronal image. Also we should try to see in the axial images also. The lateral collateral ligament, I would need to highlight here, apart from the lateral collateral ligament proper, which is called as the fibular collateral ligament, there is one more component which is called as the anterolateral ligament. This came into picture 20 years back when the arthroscopist tried to see a different structure which was separate from the lateral collateral ligament, and then everyone forgot about it. Again, in last 5 to 10 years, it has come up in practice because this is one of the major cause of instability of the lateral knee. I'll just take 1.5 minutes more. This is how the lateral collateral ligament looks like in a coronal image, well stretched and continuous, whereas in the axial images it is seen here, and there is a separation by fat between the anterolateral ligament, which is this, versus the fibular collateral ligament or proper lateral collateral ligament. The injury to the medial or the lateral knee is not a straightforward. It can either happen because of by straight valgus injury, as in this case where there is a valgus injury happening, and then there will be either tear of the medial collateral ligament or the medial meniscus, and other is a rotational injury which can happen, which is called as the anteromedial rotational instability, which happens in a fixed hip and the ankle, and there is a valgus injury at the knee joint. So these two mechanisms of injury is very important to talk of what type of injury has happened to the knee structures. There are various grades of MCL injury, and in grading either you have to talk of whether there is a partial or a complete tear. And as we see 3 different examples, one, this is a partial tear along with meniscal injury, and there is inferior migration of the meniscus into the gutter. But we are seeing some continuous fibers. The peripheral ones are continuous, the deeper ones are torn. This is a high grade partial tear because the orientation of the MCL is preserved, but the attachment at the femoral attachment is not seen at all. This is a complete tear where you are seeing the proximal wavy fibers of the medial collateral ligament, and the attachment, distal attachment 3 centimeters distal to the articular margin of the tibia is not seen. So this is the different types of MCL injury. This is a case of complete tear of the lateral collateral ligament. The orientation of the fibers is also disturbed. There is a lot of edema here happening. Also in the axial images, you are seeing the disruption of the lateral collateral ligament and also the posterior lateral corner. I am not going to the posterior lateral corner because that is not in this talk. I have to talk. And just to summarize quickly, the very, very important thing is, like, we need to know the anatomy of all the structures which I have talked of. Apart from that, we should be very informative about the biomechanics and mechanism of injury, because based on that we need to see what structure should be injured, and we should be diligent enough to talk what tear or what type of injury has happened. The meniscal tears are very important in the knee because they are, though not the primary stabilizers, but they can talk. The clinician needs to decide whether they need to go for arthroscopy or not, depending upon what type of meniscal injury has happened. So in this case, we have to talk of the meniscal attachments, the displaced fragments, and always try to see the roots, because they are the places where the arthroscopist won't be able to reach. You have to guide them and tell them that this is the place where they have to go and see and talk, manage the tears. Thank you very much. And I would like to thank Satyabhai and whole of the IREP and the Odisha Radiology Imaging Association for calling me, because coming back to the state, home state, and talking is very fruitful and very you feel very nice when you come back and talk. I am looking forward to talking in front of this audience again. Thank you.
Thank you, Dr. Amit, for another wonderful lecture. Next, we would like to welcome back Dr. Sumedha for her session on imaging approach to metabolic bone disorders.
So the next topic is imaging of metabolic bone disorders. This is a very extensive topic, but I'll try to keep it short. The topics, the diseases which I'll be discussing are osteoporosis, rickets, malacia, hypophosphatasia, and so on and so forth. I'll start with disorders of bone remodeling, that is osteoporosis. Coming to osteoporosis, how is an imager supposed to approach osteoporosis? So generally, whenever we will be starting with osteoporosis in our practice, the first thing which we'll be seeing are fractures. Any patient who comes with a trivial trauma, aged patient, female patient comes with a trivial trauma but multiple fractures. Most commonly what we see are these, just a minute, are these fractures like, shown here. These are the distal radius fracture, ulnar styloid process fracture with dorsal angulation, neck of femur fractures. Like any other fracture morphology, it will be following the same patterns. But what are we supposed to be looking for? We are supposed to be looking at the background of these fractures for osteoporosis detection. For osteoporosis detection, it has been defined as bone mineral density less than minus 2.5 as a T-score. And the question which are generally asked is, in any exams, in any diploma exams which you'll be giving, is why the T-score is used versus the Z-score. So the T-score is generally used because it compares osteoporosis bone loss when you are comparing it to young healthy adults. Whereas Z-score is when the comparison in the cohort is among the peers. That is, for example, if a 70-year-old woman is compared with a 70-year-old woman for her Z-score, it will be similar. But that does not mean that it is better. The T-score should always be compared with a lower age, a younger healthy adult bone cohort. So osteoporosis is defined when T-score is less than minus 2.5. Coming to pathophysiology of bone loss, so this slide is something which I would want you to take away from because this is an important slide. The first image is the example of a normal vertebra. So the vertebra is made up of trabeculae which are vertical and horizontal. And as we age, there is loss of the horizontal trabeculae and the vertical trabeculae. But there is a preferential loss of the horizontal trabeculae which results in weakening of the bone. So if you look at the second image, you see the graphic illustration and then you look at the X-ray. See, you can see the vertical striations very clearly, but the horizontal bone trabeculations are lost. So that is what happens as we progressively age. And when you look at an MRI of maybe a 80-year-old female, you will be thinking, oh my God, this patient has so many hemangiomas. But that will not be hemangiomas. That happens because of rarefaction of the bone due to preferential loss of horizontal trabeculae. So that is one imaging feature of osteoporosis which is different from what we generally read. Next thing which you have to look at, this is just an example of, is the first A, C and E are normal X-rays comparing with B, D and F which are the abnormal X-rays. So you have to look at the cortex. The cortex on the A X-ray which you can see is so thick, it becomes pencil thin in osteoporosis. Coming to C and D, you can see that the vertebra has become very rarefied. There is loss of horizontal trabeculae. There is presence of a wedge compression fracture which is also one of the presenting features. Coming to hand X-rays, often on the hand X-rays we are confused as residents as to how are we supposed to pick up osteoporosis. When you look at the metacarpal bones, the metacarpal has a cortical thickness of, as shown here in red lines, the cortical thickness in summation should be approximately more than 25% thickness of the entire metacarpal. So if it is anything which is less than 25% on a hand X-ray, you can question it to be an osteoporotic osteoporotic patient. You can see for comparison in F, you can see that the pencil thin cortex and it is very thin compared to the diameter of the metacarpal. So that is how we can pick on this. Coming to MRI versus CT, I would want you to have a very close look on this CT and try and find the fracture. As we know that CT is the best modality for fractures. We should be doing CT because CT is for bones, MRI is for soft tissues, but there has been a change. This is the first image I want you to look closely at, and then this image. So this is the image of the same patient. In this study, it was concluded that MRI was substantially better in picking up picking up fractures. For example, here all of us, this is the fracture line, and we could have very easily missed it on a busy day. Coming to MRI, this would have been very difficult to miss. So this study concluded that MRI was substantially better than CT in detecting insufficiency fractures, and there was a protocol change in many institutes when it comes to detecting insufficiency fractures. Generally, MRI was the advice, was the go-to modality than CT. So that was one key takeaway for osteoporosis. Coming to osteopetrosis, here there is increased bone deposition, but that does not make it a good disease to have. Rigider the bone, brittler it is. So that is the pathophysiology of this disease. In this disease, there is carbonic anhydrase deficiency, due to which the osteoclasts fail to resorb the bone from, fail to do bone resorption at all, due to which there is excessive bone deposition resulting in such a picture. So in this picture, you can see the classical Ruger jersey spine, which we always remember with CKD. This also should be one of your differentials in your exams and in daily practice also as osteopetrosis. But this is also a differential. This can never be a definitive diagnosis without a proper history. So bone in bone appearance can not only be seen in the vertebra, it can also be seen in this pelvic CT which I have shown here. The Erlenmeyer flask deformity is also seen in osteopetrosis, not just the Gaucher's disease which we read daily on. So this is an example of the same. The bone is very dense. If you do a bone mineral density scan, the bone mineral density will be in the range of plus 6.5 to plus 5.5, still does not make it a good disease to have. Coming to disorders of bone mineralization, rickets and osteomalacia, it is a deficiency of vitamin D, and rickets is the younger child with vitamin D deficiency, and osteomalacia is the terminology which is the adult counterpart. Rickets occurs before epiphyseal closure, and it leads to impaired growth plate mineralization. So this is just an example. Sometimes when we are trying to pick up rickets in a child, we should also be looking at the skull X-ray where there will be delayed closure of the sutures. So we should be knowing the chronological age as well when we are reporting any pediatric X-ray for rickets. So coming to the chest X-ray, there may be presence of rachitic rosary, that is widening of the rib ends. There may be presence of fraying and cupping, which are better visualized in these images labeled C. So fraying and cupping is very specific for rickets. So there is always a question during our vivas also as to how are we supposed to differentiate rickets from scurvy without any history. So fraying and cupping is rather specific for rickets than for scurvy. For scurvy, there are other findings which we will get to in the next few slides. Coming to active rickets and healing rickets. So more often than not, if you are working in a setup where there is a pediatric follow-up X-ray protocol as well, so the healing rickets looks like this, in which what happens is when there is, you will see on chronological X-rays that the fraying has reduced, the cupping has reduced, and the most importantly, there will be sclerosis along the metaphyseal side of growth plate. If you look at this X-ray independently, you might think, without any history of healing rickets, you might think about, okay, this might be scurvy, this might be one of those Frankel lines which I am seeing. But that is what makes it important. History is important to think of healing rickets as well. So coming to scurvy now. Scurvy on imaging, it is important that this is also a disease which causes osteopenia like rickets does, but there are few specific signs along with biochemical markers and history that there has to be like a Frankel line, which is a provisional zone of calcification, which we see here. When the provisional zone of calcification outgrows and overgrows its cortical ends, it results in Pelton spurs. There is presence of lucency adjacent to the provisional zone of calcification, which is the Trummerfeld zone, which is a zone of hemorrhage. So that zone is also very likely to fracture. Another sign which we see is the Wimberger's ring sign. Wimberger's ring sign is there will be diffuse sclerosis along the epiphyseal margins. The second image is an image of an MRI. Here you can see that there is a lot of periosteal edema and subperiosteal edema as well. So these patients, scurvy, although it is very rare now to find a patient with scurvy, but that patient may also present with pseudo-paralysis. The child is not wanting to move its hand at all. That is because of subperiosteal hemorrhage. It is a rather painful condition to have. So this can be the MRI imaging of the same. To summarize how to differentiate rickets from scurvy, if there is a question, this is the summary of the two. Cupping and fraying, wide and growth plate are rather specific for rickets, whereas scurvy, we are supposed to look at white line of Frankel, the Trummerfeld zone where there is presence of hemorrhage. Pelton spurs are outgrown white line of Frankel's, and Wimberger's ring sign as I described earlier. Subperiosteal hemorrhage, more so for scurvy, is specific than rickets. Coming to the adult counterpart of osteomalacia, of rickets. So osteomalacia, one thing which we can remember is loser zones. If anyone as radiologists asks us what are we supposed to remember about osteomalacia, it would be loser zones. So what are loser zones? We always think that loser zones are fractures, but no, they are pseudo fractures. They are the healing response of our body to stress. So the bones are already weak in osteomalacia, and even with minimal trauma and chronic weight bearing stress, there occurs presence of symmetric lucencies along the stress sites, which results in these things called as pseudo fractures. For example, as shown in these images here, you can see this lucency here, and there is a line of sclerotic response around this loser zone. So these are pseudo fractures which are very commonly seen in these patients, osteomalacia. The question which is generally asked is, where is it seen? Superior inferior pubic rami, the neck of the subtrochanteric region of the femur, both on the compressive and on the tensile side, the iliac wings, vertebra. So these are the regions which are commonly involved. This is nothing but an adult counterpart of rickets. The treatment remains the same. Coming to hypophosphatasia, which is a disorder of bone mineralization. The name is very misleading. We might think, okay, hypophosphatasia, maybe there is a phosphate deficiency or something like that. But no, hypophosphatasia is different from hypophosphatemia. Hypophosphatasia is deficient alkaline phosphatase, the enzyme itself. So it is a congenital disorder in which ALP is deficient. So in this, the treatment becomes a recombinant therapy where we give aspartase alpha, and the patient responds very beautifully as well. So the imaging spectrum ranges from perinatal to childhood to adult. In adult, as I just showed, pseudo fractures are common. So I'm not going to show the adult counterpart. Coming to the perinatal, whenever we are doing anomaly scan or ultrasound also, we often forget to look at the bones very carefully. So we also should be focusing on the bones when we are trying to look for metabolic bone diseases in children as well, because that is the time where we might catch one of these things. That is, in this perinatal part of alkaline phosphatase deficiency, the membranous ossification of the skull will be very deficient. The bones are going to be very thin, very fragile. Here you can see that the facial bones are not formed, clavicle is almost absent on both sides, scapula is not ossified. So this is the perinatal picture of hypophosphatasia. Whereas when a picture of like this comes to us and the treatment is given, if you enzyme alphalase as the enzyme recombinant therapy for the same, the second image is of the treated patient of an hypophosphatasia. So we often follow these patients up also post treatment. For the chronological age, the radiological bone age is also matched. So that is the spectrum of hypophosphatasia. Coming to disorders of bone turnover, hyperparathyroidism and renal osteodystrophy is what I'll be discussing. Hyperparathyroidism is a state of excess parathormone. It increases osteoclastic activity. It can either be primary or secondary. Now, primary hyperparathyroid state is when the parathormone is formed by a tumor of the parathyroid itself, that being adenoma, and secondary is chronic renal failure. What I would want you to take away from this slide are the resorption sites. The resorption sites can be anything. We always remember during our training that subperiosteal resorption is something which is specific for hyperparathyroidism. But it's not so. Just subperiosteal is not the way to go forward. Subperiosteal, trabecular, intracortical, endosteal, subchondral, subligamentous and subtendinous are also present. I'll show examples of each. So here, this is what we remember. This is the subperiosteal resorption, the scalloping of the radial aspect of these phalanges, the salt and pepper skull with multiple lucencies and sclerosis. I would like you to focus on the third image. You can see this is a fairly specific sign of a hyperparathyroid state, which is known as cortical tunneling. Here there is intracortical resorption. If you follow, this is an intracortical resorption pattern of an hyperparathyroid state. Also, if you look at the first image here, you will be looking at this and you'll be thinking, okay, there is subarticular sclerosis, iliac aspect, bilateral sacroiliitis, chronic. No, but we also have to know the clinical picture and look at the subchondral aspect. There are cortical irregularities. With the appropriate clinical history, this is subchondral resorption of a hyperparathyroid state. Coming to the second image, this is the subtendinous resorption at the ischial tuberosity of the attachment of hamstring and at the attachment of adductor site. Similarly, at the attachment of coracoclavicular ligament, this is subligamentous resorption, and this is the subchondral resorption of the AC joint. Coming to renal osteodystrophy, renal osteodystrophy is a cause of secondary hyperparathyroidism, and osteomalacia accompanies it as well. Here we see osteosclerosis, all the resorption that I mentioned earlier. periarticular calcification and brown tumors. These are the two things which we should also remember in these cases. Coming to renal osteodystrophy, rugged jersey spine, we will be finding, we can look at soft tissue calcifications, pinna calcifications. This is a rather more common cause of chondrocalcinosis than other causes of chondrocalcinosis which we generally read. We had published a paper during my residency. We had seen a brown tumor in the mandible which had a very characteristic pattern of resorption. Here the characteristic pattern of resorption, as you can see, is very trabecular. The pattern of resorption was different. The brown tumor which we saw in this case did not have the characteristic pattern like this. It was not expansile, it was not lytic, but we found a trabecular resorptive pattern which was not published in literature earlier, and we could pick it up because of good clinical history, and we also had the lab supporting our diagnosis. The skull also had this appearance. So this appearance, we should be also thinking of renal osteodystrophy. Coming to disorders of bone turnover. Now hypoparathyroidism. Hypoparathyroidism is a state of hypercalcemia. Normally parathormone has this ability of taking calcium away from the bone, bringing it to the blood, which results in a high serum calcium level. Whereas it also causes excretion of phosphate. So it causes low serum phosphate levels. So that is what I would want you to remember for parathormone. So if there is a hypoparathyroid state, it will be a rather hypercalcemic state resulting in osteosclerosis, thick calvaria, basal ganglia calcification. Then comes this picture. More often than not during a residency we will see this and we will be like, okay, so this is Farr's disease. But no, Farr's disease is a separate entity. Farr's syndrome is a completely separate entity. So Farr's disease is a primary condition in which the calcium homeostasis is completely normal. It is a familial progressive movement disorder. So we cannot label it as Farr's disease. Rather, we should use the term Farr's syndrome. It is a secondary metabolic cause. In this, there is abnormal calcium phosphate homeostasis, and this is the most common cause which we generally see. So Farr syndrome is the term which we should be using. Another question which is asked is, what is hypoparathyroidism, what is pseudo-hypoparathyroidism, and what is pseudo-hypoparathyroidism. So coming to hypoparathyroidism, as I described earlier, hypoparathyroidism is a state of reduced PTH. So if the PTH is reduced, calcium will be low in our serum, phosphate will be high, and if we give an exogenous parathormone, the response will be very good. Whereas pseudo-hypoparathyroidism is a state where there is end organ resistance to parathormone. That means parathormone is in an appropriate amount, but the organs are not responding to it. So parathormone levels are going to be high, calcium will be low, phosphate will be high, and the response to exogenous parathormone will be not good because we are resistant to it in this case. The only thing which we need to pick up in this is, as clinicians too, is this phenotype. This is the Albright hereditary osteodystrophy phenotype. This phenotype with short metacarpals, that is short stature, round faces, short fingers, this is the Albright hereditary osteodystrophy phenotype. When we see this kind of a patient, we should think of pseudo-hypoparathyroidism and pseudo-hypoparathyroidism. Next thing we should be looking at is, okay, are the metacarpals short? Yes, they are short in both these situations. The next thing which we should be looking at is the calcium levels. The calcium levels, the phosphate levels, everything is going to be normal in PPHP, that is the pseudo-hypoparathyroid state, whereas the calcium homeostasis will be lost in the pseudo-hypoparathyroid state. So that is the clinical differentiation points. Apart from that, radiologically, how can we lead our clinicians on is that hypoparathyroid state, the secondary Farr syndrome which I was talking about, the intracranial calcifications are going to be more in that, whereas in a pseudo and a pseudo-hypoparathyroid state, the intracranial calcifications are not going to be there. Rather, there are going to be subcutaneous and dermal calcifications. Next thing, the phenotype, both are same. These are the soft tissue calcifications. I agree, it is very subtle to pick these up. So these are the yellow arrows trying to show the same, and these are the shortened metacarpals. To summarize, basal ganglia calcification, you should think of hypoparathyroid. Short 4th, 5th metacarpal, subcutaneous ossification, either it can be PHP or PPHP. Then we look at the parathormone. If the parathormone is fine, then it is rather a PPHP situation. If the parathormone is elevated, it is a situation of pseudo-hypoparathyroidism. Coming to disorders of bone turnover, hypoparathyroidism, it can either be congenital or acquired. Congenital will resemble epiphyseal dysplasias. There is no way to differentiate unless you have the biochemical markers proving the same. Coming to these examples here, there will be delayed ossification of the carpals, there will be fragmented epiphysis, shallow acetabular, beaking of the vertebral bodies. Beaking of the vertebral bodies is also not specific for mucopolysaccharidosis. It can be seen in many disorders, including congenital hypothyroidism. DNF, this is a treated case of hypothyroidism. After exogenous thyroid was given, this was the pre-treatment and the post-treatment. So we also have to bone age whenever we are getting a hypothyroid state. Hyperthyroidism, generally imaging shows what is thyroid acropathy. Generally imaging shows osteoporosis, and thyroid acropathy is often in our minds, we think that hyperthyroid is equal to acropathy. No, thyroid acropathy is very rare and it is usually a post-treatment response. It is not a cause and causal association with hyperthyroid state. Post-treatment, the patient has a very painful hand, very painful swollen fingers, periostitis with this kind of a picture. As you can see, there is a periosteal reaction, increased bone formation, bone proliferation along the bones. This is thyroid acropathy. So thyroid acropathy is a post-treatment change. Next thing which we see is, as we know, enlargement of the extraocular muscles, proliferation of the intraorbital fat, and it follows a particular order. The mnemonic here is I am slow. So inferior rectus is the first muscle to get swollen up, followed by medial, superior rectus, levator, and next by obliques. So this is the picture of a hyperthyroid state. Coming to acromegaly, acromegaly is a state of excessive growth hormone, and it is not a congenital cause. Usually after acromegaly is suspected in a phenotypical individual, next thing which is done is a brain MRI to look for a pituitary adenoma. So pituitary adenoma, there will be enlargement of sella. Plus, when there is a skeletal survey done, there may be presence of a spade-like distal phalanges, and the heel pad thickness is increased. So heel pad thickness increased by how much? So more than 25 mm for males and more than 23 mm for females. So the key takeaway is that not just the imaging findings, but history, physical examination, investigations, and imaging all are required for our final diagnosis. So I'm hoping I was able to convey what I was trying to say. Thank you.
Thank you, Doctor, for that very systemic approach and also for all those tips and tricks to diagnosis. Before we break for lunch, we are ready for the film reading session that was rescheduled to today. It will be conducted by none other than our long anticipated guest, Dr. Sikandar Sheikh Sir, the chairman of ICRI, who is also heading the Department of Radiology at Shadan Institute of Medical Sciences, Hyderabad. We are grateful to have you with us today, sir. The stage is all yours. I shall call the names of the team members. As I call your names, please arrange yourselves in the front rows from left to right. All right? Dr. Jayalakshmi, Dr. Dhaval, you are team 1. Dr. Amrit, Dr. Prakhar, Dr. Saurav, you are team number 2. You can leave the, yes. Team 1, could you please raise your hands? Team 1, yes. So team 1, 2. 2. Yes. Dr. Harsh, Dr. Adarsh, and Dr. Suman, team 3. Just ask. Dr. Mitali, Dr. Vanila, Dr. Anirudh, you are team number 4. Please come forward. Dr. Shivadatta, Dr. Fagun, Dr. Abhijit. Please raise your hands. Dr. Shivadatta, Dr. Fagun, Dr. Abhijit. Team number 5. Dr. Daksh, Dr. Mayank, and Dr. Rashi. You are team number 6. Dr. Shabani, Dr. Jayanarayan, Dr. Pankaj. You are team number 7. Please remember your team numbers. Dr. Parth, Dr. Aditi, and Dr. Shubham. You are team number 8. Please come forward. Dr. Pranav, Dr. Hunesh, Dr. Sneha. You are team number 9. Dr. Keshav, Dr. Ojas, Dr. Raksha. You are team number 10. Dr. Ruben, Dr. Aditya, Dr. Ananya, you are team number 11. Team number 11 is Dr. Ruben, Dr. Aditya, Dr. Ananya. Dr. Swaleha, Dr. Prasun, and Dr. Divya are team number 12. Dr. Swaleha, Dr. Prasun, and Dr. Divya are team number 12. Dr. Manasi and Dr. Sheilajit are team number 13. Manasi and Sheilajit. Dr. Kushagra, Dr. Shagnik, Dr. Suchi, you are team number 14. Team number 14, please come forward. Dr. Kushagra, Dr. Shagnik, Dr. Suchi, you are team number 14. Dr. Ankita, Dr. Hemant, Dr. Sushant. Dr. Ankita, Dr. Hemant, Dr. Sushant, you are team number 15. Dr. Ananya, Dr. Muskan, Dr. Kanhaiya, you are team number 16. Dr. Ananya, Dr. Muskan, Dr. Kanhaiya, you are team number 16. Dr. Priyal, Dr. Ritesh, and Dr. Simran, am I saying your name right? Yes. Dr. Priyal, Dr. Ritesh, and Dr. Simran, you are team 17. Dr. Piyush, Dr. Gaurav, and your third member is, sir? Atharv. Dr. Atharv, Dr. Gaurav, and Dr. Piyush, you are team number 18. And team number team number 19 is? 19. Team number 19 is Dr. Ishani, Dr. Shivani, and Dr. Aishwarya. 19. Dr. Ishani, Dr. Shivani, Dr. Aishwarya, you are team number 19. So just to check once, we will have you raising your hands as I call out your team. Team number 2, team number 3, team number 4, 5, team number 6, team number 7. Team number 7 is Dr. Subani, Dr. Jayanarayan, Dr. Pankaj. Yes. Team number 8 is Dr. Parth, Dr. Aditi, and Dr. Shubham. You are team number 8. Team number 9, number 10, Dr. Keshav, Dr. Ojas, and Dr. Raksha. Team number 11, team number 12, team 13, team number 14, please raise your hands. Team number 15, team number 16, Dr. Ananya, Dr. Muskan, Dr. Kanhaiya. Oh. Okay.
The next team.
Sorry for delay, there was some technical thing, non-compatibility of the software. So there are how many? 18 teams. 18 teams. So the first round is for open for all, and this will be some sort of an elimination round where we will choose top 5 teams. Okay. So these are physics-based questions, FRCR-based questions. Oh my God. So, I know that physics is most dangerous, most volatile. It looks, everything looks similar. So, I will see. Let me finish this one round. If possible, I will try to include cases in second round. Okay. Then we will see. If host permit me some more time in between. I don't know, like, I'm sorry, I should not ask. But the way they reacted, I'm feeling scared now. Okay, who is team 1? See, this is purely FRCR based questions. One question will have 4 options. Each option is true, false, true, like that you need to answer. Okay, and it will be some sort of a rehearse for you if you are appearing for FRCR exam, and even our MICR exam of ICRI is based on similar pattern. And I don't want any prompting, I don't want anybody to misguide, because they may misguide, you should lose marks, don't listen to them. Okay, hopefully these are little very simple questions, but looks all similar options. So try to focus, and 1 minute for one question. So we'll quickly 18 minutes we have to spend on this, right? Any doubts other than pattern? Okay, team 1, we need a mic and scorer and timer. Who is timer? No, but you are far away. How will I know? 1 minute only. 1 minute, that will be great. Ready? Timer is ready? Not now, just. Ready? Yeah.
Hello.
Your first question. So everything has true, false, true, false. You have to note down their answers also. Answers also. Timer. Every option is either true or false. There is no negative marking. Focus on.
The false,
Huh.
true, false, false.
Okay. So you told false. Number 1 is true. Okay, 1 mark. Number 2 is true. Yeah, 1 mark. First is wrong, second is correct, third and fourth are wrong. So you get 1 mark out of 4. Okay, thank you. Team 2, ready? No prompting, please. Time.
Sir, A is true, B is false, C is true, D is false.
Okay, thank you. So these are the answers. You told true, that is correct. Second is true, but you told false. Third is true and fourth is false. So you get 3 marks. 3. Next team. Ready?
A true, B true, C true, D false.
So you told A is true, correct. B is true, that is wrong, it is false. C is true, correct. Then fourth is false, correct. So 3 options are correct, you get 3 marks. Next, ready? Next team. Yes.
A true, B false, C true, D true.
Okay. So you told true, that is correct. Second is true, you told false, wrong. C is again wrong. And D is true, that is correct. So 2 correct answers, 2 marks. Next team. So this is something which you are aware. Yes. Next team. 30 seconds.
A, B, D, true, C, false.
A, B, D.
D, true, C, false.
A is true, B is false, you told true, then C is true answer but you told false, then D is true. So you get 2 marks out of 4, 2 out of 4. So this is something with dual energy. Next team.
Team 6. Team 6.
Mike. Already have mic. I think looks short. 40 seconds for this. Only 40 seconds. Last 10 seconds remaining.
A, A true, B true, A true, B true, C true, D false.
D is?
False.
Okay. So A true correct, B true correct, C is wrong answer, D is wrong answer. So you get 2 marks. Okay. So next team. Ready? Total 1 minute.
A is true, B true, C false, D true.
Perfect. 4 score. Next team. You flicked it or like? Nahi. Luck.
Team 8.
Next. Ready? 30 seconds for this. Very short. Right? One is correct, rest are all false. So you need to tell T, T, F, F, whatever. No whisper, no please, please. Please. Your time is getting over. Yes. Option D is true. How many marks? 0. Next team ready? Ready? Which is team?
Team 9.
Yes. 60 seconds. You have to tell T, T, F, F, whatever it is. Every
True,
option.
true, false, true.
True, true.
False, true.
So true, true. So two correct, two options are correct, right? So he is very famous MR because there is a oration and guest lecture which is being allotted in ISMRM. If you are aware, ISMRM is a society. It is the International Society of Magnetic Resonance in Medicine. It is a high profile society of MR related guys which comprises of 50% of radiologists and 50% of engineers, scientists, researchers who are involved in MR. So it is like something very interesting society. And every year it is a combination. For example, one year the president will be from radiologist, another year will be non-radiologist. So it is something very high, and you can go through the website also, ISMRM, and we have India chapter in that. So next team, are you ready?
Team 10. Team 10.
Ready? 60 seconds.
A false, B true, C true, D true.
One is correct. Second, third is correct. So fourth is wrong. You got 3 correct answers. Next.
Sir.
Next team. Ready? MRI, PET, nuclear, X-rays. What is your choice? What do you think you will get?
Up to you.
Huh?
Up to you. Up to you.
Up to you. Okay, good. Quick time.
So, true, 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 false.
So only one correct. Next team. Ready?
Sir, true, true, false, false.
Why did you tell?
Sir, true, true, false, false.
All four. Next team,
Team 13.
you are only two, no? 30 seconds. 30 seconds, not 60 seconds. Okay? Very short question.
True, false, false, false.
True, false, false, false. Two correct. Two correct. Thank you. Next team. Next team.
Team 14.
You are there? Ready? Again 30 seconds. 30 seconds. Please make a note. Very short question. Yes. Time. It's not
True,
6.
true, false, and true.
True, true.
True, false, true.
Only one correct. Thank you. Next team. Next. Oh, you are there. Ready? 60 seconds. Okay? Normal 60 seconds. Yes.
True, true, false, true.
True, true, false, true. So true is correct, false is correct. No, second you told true, that is wrong. Third is false, that is wrong. Then last true, that is correct. So 2 out of 4. Next team.
Team 16.
Okay. SUV Max in Pet City.
True, true.
Sorry, can you repeat?
Loudly, repeat.
True, true, false, true.
True, true, false, true.
False, false. Sorry.
What is this?
True, true, false, false.
No, repeat, please. Repeat. No more option now.
True, true, false, false.
True, true, false, false. Okay. So it is true, true, correct. Third is wrong. Then fourth is correct. So you get 3 out of 4. Okay. So how many teams are remaining?
Two more. Team 17.
2 are there. I think I need a help of technical guy. The 2 slides are not saved because I removed my laptop. Come. Physics. Means yes, it is. This is related with the breast imaging. Okay. Are you ready? Yeah. So focal architectural distortion on DBT without central mass. This is pertaining to the breast mass. Most likely pathology is TT, FF, whatever the options are there, you need to tell. Quick.
True, false, true, true.
True, false, true, true. So one is true, false, that is true. Then third and fourth are wrong. Okay, so you get 2 out of 4. Now, next team. So again, this is pertaining to the breast imaging. Okay. So I think we can give you 40 seconds. Again, very short question. Yes.
C, T2 signal.
Which is true, which is false? A, B, C, D. Quick.
False, false, true, false.
False, false. True, false. Okay. So 2 out of 4. Okay. Any next team? Over, no? Scoring, we have 2 teams. Team 7. Who is team 7? 4 out of 4 you got. Then team 12. So you got 4 out of 4. So sitting adjacent, some clue, inspiration. So you are qualifying for the next round. That is, that will be the final round. So now there are 1, 2, 3, 4 teams who have scored 3 marks. So team 2, then team 3, team 10 and team 16. Okay, so I request all these teams to come on the front row. So they are team 2, team 3, team 7, team 10, team 12 and team 16. चेयर्स लगाएं क्या इधर एक टीम 1 2 3 so ready team 1 now we have to reassign the teams no? Team 1 2 3 4 5 and 6 so This is proper film reading session. Okay, after this we will have rapid fire of 1 minute each, which will have negative marking. So this I feel we can keep 20 marks for correct. It is like a film reading. Based on your answers, the marks can be given. Like it can be 5, it can be 10, 15 or 20. Okay. So hopefully we will give 6 teams, no? 4 into 6. How much time, sir? 3 minutes. 3 minutes for one case. Huh? 3 minutes. Little longer cases. Okay. No, conversation too much. This proper film reading. So ready? 3 minutes. You have mic? Mic de do. Pass on the mic. Okay. Start. 3 minutes. Time is set, no? Okay. Yes. This is your case 1. You have 3 minutes. You need to start speaking. No problem. Yes. Twenty marks. 20 marks. Exam case. Long case. It's less than 1 minute. After this time, not allowed to answer.
Sir, on ultrasound, there seems to be some irregular wall thickness of the UB, of the urinary bladder. Then on CT also there is some sort of discontinuous irregular wall thickening. सर को पूछो कौन सा है? Some sort of exophytic lesion is also seen arising from the right lateral UB wall.
I think sir is requesting I can give 30 seconds more to everyone, not to him, so that the time is little less. Yes. Next wala, abhi next wala. There are prizes 1, 2, 3 winners. Remember that. Time is over. Yes, time is over. See, this is ultrasound image. You
Is
have
it PCC, sir?
irregular wall thickening, okay, more predominantly on the right lateral and posterior wall. That is what you can tell in ultrasound, right? But CT is giving more precise information. How is a wall? How is the wall thickening? Irregular. There is some sort of lobulation, inhomogeneous or heterogeneous enhancement, loss of completely perivesical fat planes at this level, infiltration into adjacent structures, even though bladder volume is not completely filled, okay, it's like some sort of a reduced caliber. So, and this is something related with the MR, okay, that is distended, but still there is wall thickening, perivesical infiltration and involvement. So this is what you need to describe, and based on the history, you are having clear-cut history, pain is there, dysuria is there, frequency is there. So you need to correlate with this, and again, chronic renal failure is there. Chronic renal failure, what will happen in the urinary bladder? Hypertension, then hypercholesterolemia may or may not be relevant, but they have put in the history. And simple microscopic pyuria. The best, and for at least differentials you could have told, is cystitis. There are different types of cystitis. Okay, it can be infective, it can be tuberculosis, or it can be something else. And another less likely possibility, you could have still 89 years, it can be again a transitional cell carcinoma. Irregular wall thickening, it is there, more commonly seen. So this is what you need to tell. Okay. So you have, I don't think you get any sort of marks, 3 marks or something, 3 marks out of 20. So I request you speak. This is long case, exam, you need to speak, right? So this was very unusual case, but for differentiation and all that, it was a eosinophilic cystitis. Don't go with the histopathological, but the way you analyze in exam, that is more important, right? Team 2, are you ready? No, not time. This is within that 3.5 minutes now. Please set it 3.5 minutes. So this is something where you don't get 3.5 minutes in exam, but this is a film reading session. So you should be faster, right? Ready? Team 2? Yes.
Sir, I've been provided with a PA view
Okay.
chest X-ray on
Yes,
which
yes.
there is a radio opacity on the right, in the right hemithorax, which is likely of extra of pleural origin because it is making a convex border with the lung. There is no relevant mass effect. On contrast enhanced CECT image, there is an irregular nodular thickening of the pleura, as well as on contrast enhanced MR as well as T2 weighted MR images, we can see irregularly thickened pleura over the costal as well as the mediastinal pleura, and which shows uptake on PET images. With the relevant history suggesting, provisional could be, sir, mesothelioma, but since the patient is a young girl, some inflammatory thickening could also be possible. Could be metastasis as well.
Okay. What is the finding in this chest radiograph? Don't use the word radio opaque. This is not
It's a
radio opaque.
homogeneous
It's a
opacity.
opacity. At least we can tell
It's a homogeneous
opacification.
opacification
Okay.
of the
What are differentials on this? Only on this chest radiograph.
pleural effusion, sir, empyema.
Huh. Okay. What are differentials on this other than mesothelioma?
Metastasis, young patient. Empyema,
Empyema.
but there is no enhancement of the pleura. Thoda sa mild enhancing pleura. Sir.
Okay. Anything else?
So there is associated right-sided mild to moderate pleural effusion as well.
Okay. Differentials.
So mesothelioma,
Yes.
metastasis,
Hmm.
in likely inflammatory pathology.
What? Any other? Any other? Did you see this? This chest wall, muscle involvement is there, right? And this is a plane where you don't know whether it is arising from the pleura or it is arising from the muscle, right? Effusion, pleural lesion, pleural masses, nodularities, everything is correct. But this is not what we expect in long case. I am telling very clearly. You should give differentials based on this. You have come to CT. CT, you see what are all the things, what is it doing? Lesion is not what you are supposed to describe. After that, infiltration, displacement, abutting, all these things you need to mention. These are very, you didn't mention anything about this. What is happening to the liver adjacent? Is there any peritoneal involvement? And what is infiltrating into the adjacent structures? Everything you have to tell. Anterior, posterior, superior, inferior, medial, lateral. That makes sense because that is where you miss the findings. Okay. So, mesothelioma metastasis is one of the differential, agreed. But what about this? Now you don't have option to answer, but anything you want to add, because I will not give marks for that. Anything you want to add? With this addition, it is a chest wall lesion which is infiltrating pleura, causing effusion. What are differentials? And is there any section which I have not given to you? Amit sir is there, no? Yes. Quick. So this was a tumor arising from the chest wall muscle. So histopathology I am not expecting, but at least you should have picked up the chest wall lesion. And one of the most common thing is Askins tumor also. Okay, 16 years, round cell tumor, Ewing sarcoma arising from the rib. Right? So that is how you should try to analyze all that things. So your description was okay, not complete. Differentials were partial. But the main focus was the origin of the lesion. That is very, very important. If you can't identify the origin of lesion, that makes, and it's not possible in 100% cases, but at least in 80-90% of cases, radiology, we can identify the origin of the lesion. Hopefully, I think I will give you around 8 marks. Okay, out of 20. Next. See, I am training you, don't mistake me. Probably I am trying to make stress on the important points. Yesterday also I finished exam in my own medical college, so I know my students. The approach is very important. Somebody came and told this was multicentric osteosarcoma, उसने बोल दिया osteosarcoma, तो examiner started postmortem. तो बोलते हैं findings बोलो. See, diagnosis is not important. Nobody bothers about that. The moment you are uttering a diagnosis, it means somebody has told you. So analysis, approach, very important in long case, and long case decides your future, whether you will pass or not, because it carries huge chunk of marks, right? Next team ready? Yeah. Yes.
So we have been provided with first image is of a 55-year-old man who is a non-smoker and who was presented with the history of 4 months of dyspnea and wheezing. The first image is a frontal radiograph. Frontal radiograph. It the bony structures appear normal. The soft tissue appears normal. The cardiac cylindroid also appears normal. The CP angles are
Okay, agreed. You tell me what are positive findings. We don't have time. Any positive finding on chest radiograph?
As such, sir, we are not able to appreciate any findings.
Okay.
But
Next.
retrospectively, sir, then we have been provided with coronal sections, coronal high-resolution computed tomography of thorax sections and axials also. It shows, sir, multiple nodules, randomly distributed nodules, which can be seen in both right and left lung parenchyma. Apart from that, sir, there is no history of any cyst. There is no history of um, the, there can be subtle ground glass opacities also which can be appreciated. Sir, keeping the history in mind and long duration of exposure, I would like to give the first DD could be either a acute hypersensitivity pneumonitis, and the second one I would like to give, considering the age, it could be metastasis, sir, in case if there's
Is there anything on chest radiograph? That is something where you need to be very careful. And one
so
clear...
actually, yes, sir.
Yes.
So it's
Quick.
female, so the breast actually looks a little bit, but for a male patient,
I'm asking about lungs.
Okay, sir. Right. That's fine.
One clear suggestion to all residents. You cannot pass exam, you cannot practice radiology without conventional. That is very clear. Remember that. And you told it is retrospective. So retrospective is after MR, anybody can tell what is finding on chest radiograph. Right? So try to learn, try to read that. It's a basic thing, commonly advised thing, and it will prevent unwarranted investigations, unwarranted radiation to the future by advising CT or whatever, mostly CT, right?
So the
So your
medial
time
end
is
of
up.
the
Your
right
time is up.
clavicle.
Your time is up. So what do you think? What is obvious in this actually? You saw the coronal,
Yes.
you saw this, you saw this. Anything you missed actually? Because the first and foremost thing what you have to say, is it a normal inspiration, expiration or emphysematous? How are the diaphragms actually? Is the diaphragm little more contour, loss its contour, more flattened? The moment it comes and see the amount of the hyperinflation, like it is first thing is emphysematous, lungs, right? Not so obvious on the chest, but still you need to figure it out with the diaphragm. Make a habit of seeing all these things. And second, you have multiple
Nodules.
nodules are
Yes.
there. So your diagnosis differential, one of the differential was something metastasis.
Sir, first was any infective
Infective.
cause, allergic cause like hypersensitivity
Okay,
pneumonitis.
pneumonitis, correct. Anything else?
So second could
in
be an
this?
infection and third was a metastasis, sir, considering
Third,
the old.
infection, what infection you would like to give?
Sir, viral,
Viral.
but it'll have GGOs and it'll be very scattered.
Okay. And this is something related with dyspnea and wheezing. Can you just tell me out of what do you mean by dyspnea and what do you mean by wheezing?
So dyspnea is breathlessness, wheezing is like there'll be sound associated with that is related to airway actually, sir, wheezing. Because of the narrowing of the airway, sir, there'll be audible like when the patient breathes, we'll have
Any other differential? You thought? Anybody else? Any differential? Audience? Yes, louder. एक माइक देना उधर. ठीक है. Just little loud. Okay, bronchial asthma. Okay, hyperinflated. But what about nodules? Anything? He told about pneumonitis. So it was something related with the idiopathic. This is something very unusual diagnosis. But what you told is like one of the possibilities pneumonitis. That is also true.
Yeah.
But your approach with the conventional radiograph is not up to mark. You should have told. You started with bones, then soft tissues, something. So don't go.
Okay.
Just try to follow one pattern.
yes.
Okay, chest radiograph is not for bones actually. You should at least start with the center to periphery is the ideal way which you should
Okay, sir.
go.
Yes.
Okay.
Yes. Sir.
So hopefully you have done okay, but like some sort of, if I can give you some sort of passing marks in that out of 20. So
Yes, sir.
we'll give 10 marks.
Okay. Thank you, sir.
Yes, next team, ready? Yes.
First image is the orthopantogram showing bilateral unerupted third molars, upper third molars with narrowing of maxillary sinus, and in the CT coronal sections in the bone window, we can again see the bilateral unerupted third molars impinging on the maxillary sinus. There is also a small cystic lesion seen on the right side associated with the crown of the unerupted right molar. Temporal mandibular joint appears to be normal in alignment, and so the cyst associated with the unerupted tooth could be a odontogenic cyst or a radicular cyst.
What is that first, this thing? What do you call this?
Orthopantogram.
Okay. Have you seen till now how many? Have you seen or not? Is it a part of radiology or dental? Or we don't own one by one? Okay. You told about temporomandibular joint. And what is the history actually? Have you thought about this actually? What is trismus?
Trismus is like stiffness of the jaw and unable to mouth.
Where? Which joint?
Temporomandibular joint.
Clinical history itself is telling there is some issue with the joint. You told it is normal. Number one. Then there is maximum opening of the mouth. There is a limit, and it is clearly mentioned more than 40. It is very much restricted. So what do you think?
Something associated with the temporomandibular joint.
That is one clue. This is second clue. And third is, what is lateral excursion of the mandible?
Due to the masticator muscles, this pulls the mandible laterally.
What? It is like lateral movement. You are doing excursion like this. So during that also she is having a problem. So the basic focus is temporomandibular joint, right? So probably agreed, you might not have seen this radiographs till date. What about this? You see this? Is it normal? Is it normal? It is too much widened. It is hypertrophied. Okay. And how is the bone actually? Is it normal? Is it normal? It looks some sort of deformity is there. Right? And there is some sort of associated, this bone also at this part looks abnormal. It's not completely normal. Okay. Some sort of ground glass opacification is there at this level. But most important concern is TM joint. TM joint is absolutely abnormal. So this was hyperplasia of this, hypertrophy, enlarged. Okay. That is where the problem is. And there is some sort of osseous dysplasia. If you see this, it is not normal. It looks deformed. So try to make a habit, because I feel ENT part of radiology is where we usually neglect most of the things. We are good in neuro, MSK, chest and abdomen, but when it comes to normal anatomy of the head and neck, that is where the problem starts. So please try to read this, okay? And not good approach, so I don't think, probably 3 marks. I'm also not here, everywhere people know me, not because of this. See, for me basic concepts are very important, anatomy, principle, techniques. If you know this automatically, and clinical, if you know this, then radiology automatically will be good. You only thing is you need to pick up. Ready? This is something very abnormal case, but hopefully I expect. One more team is there, then quickly we'll do rapid fire for 6 minutes and we can disperse. Yeah, delay on time. We are on time.
We have been provided the history of a long 10 years and mass is a soft palpation and superficial cutaneous ulceration in labia. The first image is axial Q1 in through labia, which showing multiple well-defined lobulated iso-intense lesions. And the second image is the T2 section, coronal, showing multiple T2 hyperintense, same lobulated, well-defined lesion, and the lesion with no loss of fat plane with adjacent structures, which is suggestive of there is no such invasion to adjacent structure. And the upper third image is mostly the post-contrast image and showing intense enhancement. And the last image is showing the color Doppler study in which the venous flow is coming. So considering the history and all the findings, my differential diagnosis are some low flow malformation like some venous malformation, venous or venolymphatic malformation with so that's it.
Differentials.
Sir, differentials are low, all differentials including the low flow malformations are the differentials because it is a highly vascular mass.
Okay, so coming to this
can be also can be AV malformation, but in Doppler we have not provided with the atrial.
Okay, that is true, but if it is AV malformation, see the pattern.
Pattern, yes, sir. It is not
It is uniform.
uniform. Yes,
A,
sir.
B means somewhere there has to be A and V.
Yes,
Or
sir.
it will be communication, but the amount of the intensity, density will not be similar. Okay,
Yes.
and it is a chronic 10 years
Chronic.
cutaneous ulcerations.
Yes, sir.
Okay.
It is
And what do you
mostly-
think actually it is?
It's
What you
mostly
told is
low flow lymphatic malformation. the
lymphatic.
first
Anything else?
differential.
Anything else? If it is lymphatic,
Varicocele, it can be varicocele. Va-
if it is
varicose-
lymphatic, does it have a relevance here?
Venous, the flow is coming in venous. Varicocele.
Good findings, good pickup, good description.
Thank
So
you, sir.
fully, I think I can give you 16 marks.
Thank you so much.
See, I will give you a clue in exam. When you are talking, talk precisely, talk systematically, and don't give chance to examiner to intrude in between. The moment you give a chance for examiner, he will lead you to go right, left and all that. When you are following a correct direction with correct approach, correct findings, correct clinical presentation, you will land up correctly at a correct destination. Remember that. Okay. And it should be continuous. No gap, thinking, blinking. Then probably your facial expression will be doubtful. Next. Ready?
Yes, sir. We have been provided with a history of a pediatric age male patient. So, first coming to the chest imaging, abdominal erect X-ray imaging shows a few normal bowel loops along with a well-defined uh, opacity noted in the pelvis on the left side, and coming to CT axial section, so soft tissue section showed well-defined lesion with peripheral rim calcification and scattered areas of calcification in the pelvis,
Yes, you
which is
carry on.
abutting superior aspect of urinary bladder wall and adjacent bowel loops. The fat planes are maintained with the lesion, with the adjacent structures also. All the visualized organs appear normal. So possible differentials can be possible differentials will dermoid can be included, or else
What did you see in this?
sir, opacity, well-defined opacity in the pelvis.
Opacity, where?
In the pelvis, sir, pelvic cavity.
So when this is there, first and foremost, at least some differentials should have come in your mind. See, one more dictum I am telling you, whether it is exam or you are reporting, you have different modalities. So once it comes with a lower modality, at least you should have some, this thing, this radiograph or this ultrasound will have probably this thing. Then go to higher thing. Because don't neglect that. It doesn't mean they are useless. They give very good information, sometimes better than CT and MR. Okay? That is one. Second, location. It is very clearly, this image shows it is superior to the bladder. There is loss of plane with the bladder. Anterior abdominal wall, lower anterior abdominal wall, calcification, lobulated, cystic lesion. Cystic component is there. It's some fluid component, right? So what can be the differential? And it is abdominal pain. Significant weight loss. Weight loss means first and foremost, you should either think it is tuberculosis or malignancy or something, because that has to be in your mind. So what do you think? Audience? Yes, any guess, any clue? Yes? Urachal cyst. Good. It's a urachal carcinoma with a calcification. Okay, always remember the communication with the bladder, communication with the anterior abdominal wall, cystic lesion. Okay, that always you should keep in mind. This was unusual, but connection wise, other than calcification, it is a chronic thing which would have led to the calcification. But at least that should be one of the differential, right? So with this we close, and I am not happy with your presentation. I am sorry. Okay, 7 marks. So we have team 3 with 10, team 5 with 16, and team 2 8. Okay. So next round will be rapid fire round, 1 minute for one team. Negative plus, how many plus? Plus 2, minus 2. Okay. 1 minute. This blank. Huh? I think I can come. These are some cases actually. Just leave it. We come back. I can ask anything. There will be 4 teams in this round, because team 1 and team 4, they are eliminated. So now renumbering will be there, team 1 and team 4. So you can come move this side, 1, 2, 3, 4. So you will be team 1. Okay. So it is a rapid fire round, 1 minute. I will be asking randomly questions. You need to answer immediately. Plus 2, minus 1. Judge's decision. And if you don't know the answer, tell pass. Okay. You don't waste time. 1 minute. I need timer of 1 minute. Right? So ready? Mike. Where is Mike? Just please hand over to them now. Time is ready?
Hello.
It is individual, no pass is there. You answer correctly, you will get 2 marks. You answer wrong, minus 1. If you don't want to answer, tell pass immediately so that you can go and you can cover as many questions as possible in that 1 minute. If you try to go on answering or without wasting time, right? And you have to note down plus minus. Please make a note. Team 1, 2, 3, 4 now, right? So ready? Yeah. What is the modality?
Gallium scan, sir.
Gallium scan. What is the abnormal finding?
Ectopic thyroid.
Ectopic thyroid. What is the radio tracer used? 2 plus 2 plus.
Gallium 68.
Huh?
Gallium 68.
Gallium 68. Okay. What is the clinical thing which this patient will present?
Pass.
Pass. So, what is the common age of presentation?
Pass.
How much sensitivity is there for that particular thyroid evaluation?
Above 90, sir.
Huh?
Above 90.
Minus 1. 1. So you answered 3 correctly and 1 wrong. So it is 6 minus 1, 5. No. Let it be. I'm just skipping the case. Don't worry. No, I'm choosing a case for them. Yes. What is the abnormality?
Yes, ma'am. Yes, sir.
Team 2. Rapid fire, don't waste time. Plus 2.
Prominent
Huh.
aortic arch.
Minus 1.
Pass.
What are the, is it acquired or congenital?
Pass.
Differential diagnosis?
Increased density of
Differential diagnosis.
pass.
Okay. What is the radiograph? AP or PA? Huh?
AP.
AP. Sure. Why? Time is out. Why? Yes, audience, AP or PA? Minus 2. You didn't score anything. In fact, minus 2 from your previous score. Okay. Time starts now. Lateral radiograph. What is the obvious finding?
Collapse lung segment. Radio density in the upper lung zone.
Minus 1. What is the positive finding in the chest? PA?
Pass.
What is the positive finding in CT axial section?
Tracheal narrowing or deviation, mediastinal deviation.
Any other abnormality in this?
Left pulmonary artery is not visualized clearly.
Minus. What conditions associated with this abnormality?
Pass.
Yes, audience. If it is not identified, I will kill somebody. I'm telling you. Yeah? What is this? एटलीस्ट इधर तो देखना चाहिए था आपने. What is this here? This is a graveyard now. This nobody can. This generation doesn't know what is lateral chest radiograph. Please try to read at least for exam. Very simple case. Right sided. This is spotter aunt mini. और आप तो somebody told correlate reverse. It is seen on the right side. You lost -2 marks from your previous score. You didn't score anything. So, ready? Next. Yes. What is abnormality?
Tracheal narrowing.
What are causes of that?
Thumb sign, epiglottitis
Hmm.
in pediatric patients. Can also be tracheal stenosis.
Common in what age group?
Pediatrics are less than 7 years.
What is common clinical presentation?
Child will cry stridor.
Is it associated with any viral pneumonia?
Larynx, mumps, influenza.
Okay. Any other abnormality? How you take this radiograph?
Pass.
Okay. So 3, no? 3 plus and 2 minus. 3 answered correctly and 2 answered wrong. So 6 minus 2, 4 plus 2 minus 1. No, minus 1. So what is the score? This?
This with team 3 is 14 and team 4 is 11.
Okay. Close or one more round you want? Close. 4 minutes. I will just see if I have stuff or not. Boss? I need 4 minutes because there is somewhere close by, so let me try one more luck. Not much of a difference between 1, 2, 3. 4 minutes चाहिए. इसको बंद करो, इसको बंद करो. 30 seconds. Plus 2, minus 1, pass. Okay. Because 3 teams are very close to each other. So anything can happen here. That's what I am telling you. 30 seconds. Ready? So this is something like a dummy question. Don't take this. Yes. What is the study? Yes, team 1.
Bones cancer.
What is the radio tracer used? Common radio tracer.
Pass.
Is it better for osteolytic or osteosclerotic lesions?
Osteosclerotic lesions.
Okay. 1 correct, 2 wrong. Okay. So 1 correct, 2 wrong. So you nullified it. Plus 2 minus 2. Score is 0 in this round. Okay. Next, ready? See, I'm just skipping this. I will you. Yes. Ready? What is the study?
HIDA scan.
What is full form of HIDA? No prompting. HIDA.
hydroxyindoloacetic acid, diacid.
What is abnormality in this?
Pass.
What is common indication for this? That's 4, no? You got 4 marks added to your previous score. Okay? Yeah. Next team, ready? Ready? Yes. What is the study?
PET scan.
Huh?
PET CT.
What is the abnormality?
Increased iodine uptake in.
What is abnormality?
Sir, any malignant tumor in the head, greater trochanter and lesser trochanter of the femur.
Okay. So, is it what physiological uptake you are seeing here?
The gonads, the bladder, urinary bladder, iliac crest.
Okay. So, you answered 2 correct, 1 was wrong. Can't you see the fracture here? CT नहीं दिखा आपको? Directly you want to jump. Try to make a habit of seeing each and every corner. Okay. Add किया? Yeah. You added 3 marks to your previous score. Very close. You can change the entire scenario of other 3 teams. Last 30 seconds can change, or you can change your position if you don't answer. Yes. What is the study?
PET scan.
What is the abnormality?
Increased uptake in talus bone and the calcaneum, and talus and calcaneum. Left calcaneum.
What is the principle of this study?
Sir, malignant cells.
Principle of this study?
Sir, FDG uptake by the malignant cells.
Okay.
Active metabolic, high metabolic cells.
So you answered 1 correct and 2 wrong answers. So 0. It is a SPECT CT. It is not PET CT. There is a difference actually. It is a SPECT CT. Okay, remember, try to see. SPECT CT is different, PET CT is different. So, this is one, no? This one. Who is the winner? Guess. Team? 3. You are counting marks? Everyone. So this is one, no? So team 3, then team 4, team 2 and team. What is this team?
Team 1.
Okay.
First prize, second prize, and third prize.
There is only 1 mark difference between team 2 and team 4. You are team 4, no? That's what I told you. So, third position is team 4. Yes, please come. With 15 marks. So you really came back.
winner with 17 points. From Some Ultimate in Kalinga. Runner-up from Kim's.
And I think all of you have done exceptionally good, because it is a matter of some questions, some diagnosis, some differential where you will be differentiated. So doesn't mean those who are not qualified were bad actually. So it was like something, and radiology is vast. Similar thing happens in exam also. I am very good in some neuro, and luckily I get bad luck, I get MSK gone. So somewhere this happens, and our system is like that. So here also don't feel bad. Thank you all, and hopefully everyone enjoyed this thing. So thank you. And congratulations all winners. You can come and have a group photo, all of you. I don't want only winners, all participants. Please.
The rest of the participants, please join sir on stage so that we can have a group photo. Please come forward. Please try to return to the hall by 2:45 p.m. Colleagues as well, so that they may return by 2:45 p.m. as our speakers for the second half have flights. Welcome back, everyone. Hope the lunch has restored your energy for the second half of today's sessions. I am pleased to invite on stage now Dr. Sandeep Velichetti, who is the Professor of Radiology at Dr. P. Sims and RF, Vijayawada. Sir is a senior radiologist and a passionate educator who has himself traveled across continents collecting experience and titles with Aga Khan University in East Africa, Harvard Medical School, and several European imaging societies, to name a few. He has innumerable publications and citations to his credit and is involved in formulation and editing of chapters in several prestigious journals. Sir will be delivering a lecture on spinal infections and their mimics, focusing on discitis, spondylodiscitis, and degenerative pathologies. Please, sir.
Welcome back. Hear me now? Yeah. I'm just recovering from cold, so if I sneeze in between, just excuse me. So next 30 minutes I'm going to cover about spinal infection and its mimics. So you can sit and relax. There will be a lot of pictures, tables, differentiating features which are very good to take screenshot, but you don't need to take for this particular lecture. The same lecture is converted by Indian Musculoskeletal Society as an article which is going to come in January 2026. So everything with some more added points you will get in the journal, some 15 to 20 pages. So sit and relax. I will share with your boss or everyone in the group that particular link which is freely downloadable. So I kept in the frequently asked question manner, as if some resident, some junior resident of second year is asking questions and doubts about the particular topic. So that's a frequently asked question format. So I'm going to cover technique, contrast issues, various locations and patterns of the spinal infection, biopsy and investigations and response to the treatment assessment, mimics and its differential diagnosis. So what is the best imaging modality for spinal infection? You can always interact. Shout please. MRI. MRI is the best imaging modality. So you can always start with X-ray. Don't skip the X-ray. Even if the clinician skipped the X-ray, you can always ask for the X-ray even after the seeing MRI to make a documentation. You cannot repeat MRI frequently, but you can repeat the X-ray frequently. So it is very useful to have a baseline documentation for the bone density and bone height, vertebral height. So never skip the X-ray. CT scan is not routinely used for the spinal infections. It has some indications which I am going to show in the next slide. MRI is the modality of choice. So whole body screening sometimes is required, such as radionuclide scanning, PET CT scanning, case by cases basis when diagnosis is in dilemma, when you are looking for better next site of biopsy. So what are the advantages of CT in some cases? Why do you take CT scan? To see the bone pattern. Whether pattern is lytic or sclerotic gives very good clue. It's an active phase or healing phase can be determined by lytic pattern or sclerotic pattern. To see the soft tissue calcification, which is very pathognomonic of TB. So if you see infection, suspecting infection, the soft tissues have calcifications, that is very high chances to be TB. So focal bony lesions can be better characterized by limited section CT scan than contrast MRI. So after taking the MRI, still sometimes you better take some limited sections of CT scan to characterize the bony lesion. And the biopsies are almost always done in CT setup, not in the MRI setup. So these are the 5-6 indications for the CT scan in case of spinal infection. What is the best technique in MRI? What are the sequences you need to do? You have to do T1, you have to do T2, you have to take T2 fat sat or star. T1, in addition to the T1, most of the times you might get benefited by giving contrast. This is a post-contrast T1 without fat sat. But always do take with fat sat. So the ideal plan is take 2 planes with fat sat, at least 1 plane without fat sat. Coronals are always needed for the spinal infections because the paraspinal abscess can be demonstrated very well in the psoas muscles by coronal only. Axials give good idea, but sagitals might miss. So coronal is the best for the paraspinal soft tissues. And axial, so you have to see a little bit broad field of view, not only the conical view of the spine alone. Is there any role of diffusion weighted imaging? So you can advise technician to keep some cases of tumors and infections, this particular diffusion. So answer is yes, you can do it routinely for some time and before you titrate to the particular indications. So this is B0 with background fat. So diffusion anywhere comes with the background fat suppression. That's why it looks dark. This is B400. It depends upon the mission to mission and you can take based on that. You have different options of diffusion. 3 options. Whether advanced techniques I am just insisting more than the routine ones. You have to take first spine dedicated protocol diffusion is there in most of the new missions. Otherwise you can take abdominal diffusion weighted, which you are doing for the liver and pelvis, take in a sagittal plane with anterior suppression. Third, you can take as a part of the DWIBS or whole body diffusion. One of these techniques should work for you. This is ADC maps. Unless you have 2 diffusion weighted, you cannot get. This is beautifully showing the abscesses with the similar principle like a brain with reduced ADC values. So DWIPS, I am especially passionate about DWIPS. 10 years back I did some research, and now newly the fresh joined first year person I have given the same research. So this is one of our old student. We have detected some lesion in the vertebral body. Then we got interest a decade ago. We have taken the whole body DWIPS. You can see multiple mediastinal lymphadenopathy and neck lymph nodes, and there is a large chunk of the abdominal lymphadenopathy. He has later undergone PET CT scan, everything, biopsy, and the biggest focus is not in the vertebral body, it is there in the abdominal tuberculosis involving the lymph nodes. So try to take whole body whenever you feel necessary, case by case basis. His contrast is necessary. It's always better to go for contrast to demonstrate abscess as well. Here you can see there is intense enhancement of the vertebral body compared with the posterior elements. There is epidural soft tissue which is showing enhancement. There is a psoas abscess which is beautifully shown in this, and there is a retroperitoneal lymphadenopathy. All this can be detected reasonably well by FATSAT T2 also, but contrast is definitely additional. Decreasing in the contrast enhancement is also one of the criteria for the healing status. So if the patient is not affordable and financial issues and kidney issues are there, you can always skip, and you can always take T1 FATSAT, which is not contrast, but it gives very good resolution, anatomical resolution. So coming to the, we finished the technique. Now we are starting with the straightforward infection. First let me start with spinal tuberculosis, which is very common in our place, probably more common than the pyogenic infection. So what are the common locations for the TB? Where does it, actually it starts? It's usually dorsolumbar region. It is the most favorite area. The first commonest is, this is like a metaphysis for the vertebral body, discovertebral joint, that is the maximum vascularity, maximum inflammation place. So most common location is, it starts like a small nodule or paradiscal lesion. Central vertebral body, anterior subperiosteally it can start in any of the posterior elements like lamina, spinous process, even in the facet joint itself. So this is drawn by one of our resident for the journal purpose, upcoming journal purpose. So what is the classical imaging pattern of the spinal tuberculosis? When do you call immediately? This could be infection or especially spinal tuberculosis. Two vertebral bodies involvement within, in between there is a discopathy. If you see compare the disc height, this one to this one, there is a disc involvement and vertebral body involvement with osteophytosis. This is a classical pattern of tuberculosis, though it can be seen in the degenerative disease. So you cannot assess the disease further. This is the main limitation. This is pretty much established case of tuberculosis, but hardly you can make any final diagnosis because a degenerative disc can look very similar to that. This is how you can diagnose. Same patient, two vertebral body involvement, in between discitis. So two adjacent vertebral bodies involvement with the disc involvement is the classical pattern for tuberculosis. This is another patient. Here you can see discitis with the end plate changes without much paraspinal component. This is next patient with little bit paraspinal soft tissue component, epidural, anterior epidural or posterior vertebral component. This is frank discitis and abscess, paraspinal abscess into the psoas. These are four different patients just to show different format. There is another format also which I skipped because of too many slides, disc sparing tuberculosis. Once disc is spared, immediately you will get the idea we are not dealing with tuberculosis, which is not common. Which is not uncommon to have that pattern in tuberculosis. So disc sparing tuberculosis I have seen 2, 3, even 5 contiguous vertebra without involving in between disc I have seen. So that can spread like that. Not always disc need to be involved to have. If the disc is involved, your primary diagnosis is infection or inflammation, but disc sparing is known. These four are classical pattern. Posterior element involvement is pretty much rare, absent in 80% of the individuals. These are two tuberculosis patients which are showing posterior involvement. If you see, this lesion is almost like a pedicle epicenter, like metastasis. So you can get all the patterns including posterior elements. So can TB have skip lesions? This is pretty much known. So when do you call a skip lesion? Any definition? You need to have in between two normal vertebra. This is the primary focus with collapsed vertebra. This is normal, this is normal. You see two more lesions here and one more lesion here. So this is a classical pattern of skip lesion. So to write in the report, to define it, you need to have two normal vertebrae in between. So you should not deal only with the orthopedic component. You need to see the card. Card status is very important that differentiates surgical from non-surgical patients. It's not uncommon to have decompressive surgery, which is increasingly getting it done nowadays based on the neurosurgical indications. So card status has to be mentioned in the impression and degree of card involvement. Card directly getting involved by the myelitis by tuberculosis is pretty much rare, but it is known. This is a case where you can see posterior paraspinal component, soft tissue component is significantly causing card compression. This is a case of spinal cord tuberculoma, surface tuberculomas. This is a proven case. This patient has disseminated choroidal tuberculoma. We worked for almost 15 days. This we already published a couple of months back. This is 1, 2, 3 are nothing but isolated spinal cord tuberculomas without involvement of any vertebral bodies anywhere in the body except choroidal tuberculosis. His vision has got the diagnosis. Finally, we got diagnosis from the eye, causing diffuse myelitis or longitudinal extensive myelitis type of pattern, which is responded to the treatment. Can tuberculosis spread subligamentously and subperiosteally? That is pretty much the feature of tuberculosis infection, not common in the pyogenic infection. You can see one vertebra involved, above 2 levels it has gone, and below 1 level. Here also you can see this is posterior subligamentous spread. Use the word in the description of the report also. Subligamentous spread itself is one of the clue towards diagnosis of tuberculosis. Can patients worsen clinically after TB treatment? Yes, that is very important point. Don't get panic. You should be panic if the patient is developing neurological symptoms. If you have a diagnosis already biopsy proven or chest proven tuberculosis, be patient for some more weeks to get the results. So always it is not immediately works out. So some percentage like 15 to 20%, there won't be initial improvement. But you should be cautious. If he is already not proven case, if you are already started the treatment based on the empirical, then you should advise for the biopsy if he is worsening. So even the positive patients will get worsened, some of the patients. Mechanical complication, he is responding for tuberculosis just like this case. The abscess component is slightly reduced, no new involvement, the vertebral component is also reduced, but he developed collapse of one of vertebral body. Then suddenly they deteriorate, the card compression is increased. So drug-resistant tuberculosis also they won't respond. Inflammatory syndromes like immune reconstitution inflammatory syndrome, all these can happen just like in the brain, in the spine also. You need to always check whether patient has actually taking or stopped by himself or because of any eye or liver problems, complications of tuberculosis treatment. So when he is not responding, always keep that open. Don't keep arguing that TB. It could be another infection. Why don't you go for biopsy, which I advised in the initial step itself. So if he is not responding after 2 months, they have to go for a biopsy. So follow-ups, one of the common question is when to do follow-up. He is responding to treatment, do first follow-up at 3 months. And next follow-up is 6 or 9 months based on the patient response and organ involved. So that is one of the indications now to stop the tuberculosis, because minimum of 6 months they kept, now maximum they did not define for any part now. It has to go by case-by-case basis. One of the criteria is imaging to see the response at the end of 6 months to 9 months. So it's not always TB. We are so much trained for the TB. When you have hammer in hand, everything looks nile. So you should not jump to the TB. Always right diagnosis. This is likely spondylodiscitis, highly likely, or diagnostic of spondylodiscitis. Don't like directly tuberculosis. Most likely we are dealing with TB, but we cannot rule out other infections. You keep always like that. Don't keep alone TB unless he has a proven case of chest tuberculosis or other places. One of our resident in fellowship, he has done some research of these cases, blindly, empirically treatmented. Later they have taken follow-up. 56% is only proven TB, remaining 48% something else. Various other etiologies have been found. So this is a renal transplant African patient where I did teleradiology. There is a classical, this is very classical picture of tuberculosis. I kept tuberculosis as a first possibilities, but since the patient is immunocompromised, his kidneys are small, this is transplant kidney, he is on immunosuppressive treatment. I told, don't go for a harsh treatment, go for a biopsy now. After 15 days, they have taken biopsy, that is classical pseudomonas, culture positive, gram test is also came positive, and So you need to be cautious. Don't go alone by imaging appearance. This is another case. This patient has nephritis, pyelonephritis. They put a DJ stent for some stone. There is septicemia, and he developed spondylodiscitis, classical two vertebral body involvement with disc with subligamentous fluid or pus collection, which is peripherally enhancing. So in these cases, don't go aggressively for the biopsy. What you can do when septicemia is developed, go for a liquid biopsy. Whatever comes positive in the other parts and septicemia blood culture is most likely the organism which is involved in the spinal infection. This is E. coli. So you don't need to take biopsy every time for the pyogenic infections. So can we really differentiate spinal TB from pyogenic infection? So tuberculosis, pulmonary focus might be there, whereas blood cultures or urine cultures might be positive for the pyogenic. Late onset of paraplegia, it takes almost 2 to 3 months to get involved. The paraplegia, everything spread, everything comes within 3 to 5 days in the pyogenic spondylodiscitis. Late destruction of the disc, and disc rapidly get destructed in pyogenic. Large paraspinal masses will be there, and they can reach up to the groin. But it is small and irregular abscess only in case of pyogenic. Calcification in the soft tissue is feature of tuberculosis, as I mentioned earlier, not in pyogenic. There won't be any bony sclerosis for few months in tuberculosis. If you find bony sclerosis at least within 2-3 weeks, you are dealing with mostly pyogenic. So thoracolumbar junction is common in tuberculosis, lower lumbar junction is common in pyogenic. Pyogenic has special predilection in some age groups and patients, diabetics. IV drug abuser, you have to highly suspect this pyogenic spondylitis when compared to the tuberculosis. Immunocompromised patient, HIV patients, they may not get in them also tuberculosis is much more incidence, but you are more prone to get pyogenic than tuberculosis. So this is a proven case shared by one person from Delhi, which is also coming into publication, this one. What is your diagnosis? Straightforward looking like a TB, two vertebral body in between disc involvement, pus, small snode-like appearance. So can you guess what is the diagnosis? Sometimes you have to use immunology. IgG, IgM both are positive, spinal brucellosis. So the histopathologist has told that it's looking like complex inflammatory infectious etiology, but doesn't have any classical nature of caseating tuberculomas. So they extensively investigated and they found this one. So tuberculosis brucellosis, this I am reading since my college days, not that helpful for the sake of reading. Dorsal-lumbar spine location, brucellosis more of lumbar. It's very, very rare to get dorsal involvement. Vertebral body collapse, which is seen in tuberculosis, brucellosis usually doesn't collapse. Posterior elements are almost always spared in brucellosis, sometimes maybe in tuberculosis. Disc space is always present. I told that some 20% you may not see the discal involvement in tuberculosis, but brucellosis is almost always present. Discal gas is usually against tuberculosis. It is more of degenerative feature, but brucellosis you can see. If you see gas, usually you are not dealing with infection. It is mostly degenerative modic changes. Paraspinal involvement is very small abscess in brucellosis, marked in tuberculosis. Multi-level involvement is common, usually one site only in brucellosis. Gibbous, since collapse is not there, gibbous is very rare in brucellosis. So as neurological symptoms. This is a student who I don't have his MRI, so it's X-rays and CT scan. This patient went to US for studies. He is staying in some endemic areas. He returned, backache, gradually worsening. Initially, empirical anti-TB started, further collapse of the vertebral body. Then they take biopsy, AFB negative, fungal structures positive, foreign body Langerhans type of cells, and final diagnosis, culture, and everything has been done. This is disseminated coccidiomycosis. Later, he developed in other organs also. So this is you need to keep that. Rarely you can get fungal infection also. So how do, because I told that 6 months later you need to go for a scan. So then clinician always asks whether the lesion is completely healed, partially healed. Shall I continue the treatment or stop based on your report? How to differentiate? Abscess, if you see significant soft tissue component, still disease is active. Healing stage, there will be significant decrease in the soft tissue component or no soft tissue component in the healing phase, decrease in the size. Marrow edema, if it is still there, then it is still active. Usually you would see a fatty marrow conversion, which is a sign of healing. Intense enhancement, still active. Decrease in the enhancement compared to the old scan, sign of good improvement. Lytic lesion in the active phase, no sclerosis. Sclerosis is a rule in the healing phase. Bony ankylosis also, you will see new bone formation in all directions you would see. This is a classical example. This is FATS at T2 or star images. This is a T1 weighted image which is showing complete marrow conversion of the pre-existing lesion. So this is completely healed. This is the time to stop the treatment. Is biopsy necessary for the diagnosis of TB or any other infection? 20 years back in India, it's almost like, it's an extremely unnecessary or cruel idea to do a biopsy in a classically imaging wise seen tuberculosis, which is rapidly changed because of the alternative infections, wrong diagnosis, and also you can get rifampicin sensitive or not by biopsy sample by doing the genetic test. So it's now mandatory in many of the places, including in India. If the patient refuses for that one, for the biopsy, then always you can go for empirical, but not as a straightforward. So most of the times it is done by a radiologist. So you have to take in all the atypical imaging cases when you are not very sure, immunocompromised and special conditions, special medical conditions. If you see the disease is increasing in the follow-up, you have to do biopsy. It's of course costly. It might cost from 3,000 to 15,000 based on the institution. Patient choice also matters. You can give choice to the patient versus empirical versus biopsy. So FNAC is not a good idea. You won't get adequate sample. The non-specific inflammatory tissue you will get. Biopsy is the good idea. So this is again drawn by one of our resident. So different approaches, transpedicular, anterolateral, costotransverse, and two place biopsy, one in the soft tissues, one in the vertebral body. I am not doing actively these biopsies. This is based on Dr. D.K. Singh, who is doing vigorous amount of spinal biopsies, who has done 500, 600 cases. He has given this idea to draw. So what test do you send for biopsy? This is another important thing. If you are doing biopsy, you are responsible for the sample sending, and you need to do all these things. Gram staining, Jaden staining for AFB, KOH staining for the fungus, pus aspirate, whatever you got, culture that one, and gene expert or CBNAT, both are same. You need to do, which test the DNA of the tuberculosis, which is got variable sensitivity in various body parts. So make sure that you send, because once if you send half of this, and again you need to take the sample because the previous sample may not be useful, keep everything ready for this before taking the biopsy. So earlier break I told everything looks TB, but it is not TB. Now then we have seen some pyogenic brucellosis, fungal infection. Now everything is not infection, which looks like an inflammation in the spine. So it's not always infection. It is not always TB. So pitfalls, these are the pitfalls. What could be this one? TB or not? Just shout what is your initial impression. This is post-contrast. Pardon? Modic changes. Why modic? Why not TB? This is classical TB. So perfect. Your modic change and tuberculosis. How to differentiate modic changes from tuberculosis? So modic changes, how bad it is, it's never associated with soft tissue. They are always associated with degenerative changes in the adjacent disc, but not discitis. Discitis will be reverse signal to the degenerative usually. Class sign, which I am going to show, shape, they always take the shape of the end plates. If you see something in the center of the vertebral body starting, you are not dealing with the end plate because it has to take the end plate. Whereas tuberculosis, it can start anywhere in the vertebral body, though paradiscal is more common. Discitis, 80% of the times you are dealing with discitis type of tuberculosis. It can go beyond the end plate. It can go to the opposite side of the vertebral body completely. So these are the clues. Soft tissue component is one of the biggest clue. Because 80% of the patients will have soft tissue component in tuberculosis, and modic never will have soft tissue component at any phase, 1, 2, 3, anything. So I have 2, 3 class in my collection. Those are not so impressive for teaching. Probably this is the only slide I have taken from the internet. So here I think Radiopedia, this is looking like a worrisome. Not only end plate change, there is also some discitis feature. But if you apply diffusion weighted images, and if you see this classical sign, at the end of the end plate, you will pick up the diffusion signals on either side. It looks like a claw. If you see claw, that is not infection, it is degenerative. Claw sign is not positive in infection. Tumor or infection? T2 fat sat image. So vertebra, so many vertebra involved, entire marrow is involved, no disc is involved, elements at least looking like involved in the upper lumbar spine. So this is most likely we are not dealing with any infection. This is tumor. So sometimes tumor versus infection is also confusing. So tumor is more pedicular, tumor doesn't destroy, tumor has a mixed of lytic lesion and sclerotic lesion, tumor has some known primary, PET CT scan can bring out the primary, and tumor markers can help. So sometimes only biopsy is the only way to prove. So small node is another confusing thing. You will see when very large small nodule with surrounding edema in the area of the pain when patient presents to the imaging. So different types of small nodule are collected. The first one is degenerative, which has been subsided just like Modiak in the follow-ups without any treatment. The second case is one of my friend from Delhi has done biopsy, Dr. Kushbu. Then it is showing a classical type of painful small node. So then she took biopsy from this, which came as a pseudomonas. The clue here is it is not only involving the one vertebral end plate, the edema is spreading the most of the vertebral body even to the opposite side. If it is just painful degenerative small nodule, the edema cannot go to the opposite direction. So this is a known case of proven case of biopsy, proven case of tuberculosis. Patient has multiple paradiscal lesion which looks like a small node. So this is a proven case of ankylosing spondylitis. Ankylosing spondylitis, one of the presentations is small node. You can have painful small node in the young adult. Just always think Schurman's disease or ankylosing spondylitis, especially multiple level, especially if he is not a sports person. So how to differentiate infection from the ankylosing spondylitis? It's very, very, very common to have ankylosing spondylitis. So probably in a month I'm diagnosing 3 to 4. I don't do very high volume, still that is good number. So in the society 1 to 2% people will be there seronegatives, they won't know. So you have to suspect that. At least 10 patients I remember in the last 10 years that please stop TB, please stop TB. This is not TB, this is classical ankylosing spondylitis. By then you won't see any X-ray findings. You have to pick up a MRI pattern of ankylosing spondylitis with confidence, and you have to wait for the particular test rather than jumping to the tuberculosis. This is just I kept for the comparison. Disc gets destroyed, intense enhancement. This is a post-operative case compared to this end plate changes. So infection, you will have hyperintense enhancing disc, profound T1 hypointensity, soft tissue component, systemic symptoms, and biopsy also helps in the rare cases. Blood culture helps in acute phase. Whereas in ankylosing spondylitis, you will see this Romanas type of triangular half hemispheric type of edema. I wanted to call that pizza slice shaped edema. This is very classical. If you just remember in your mind, this is a pattern. Not one involvement, contiguous involvement of 2-3 with this pizza shaped edema, when there is no evidence of any discitis to call infection, when there is no evidence to say that there is a degeneration. This is young patient, so there is no point of calling degeneration. This picture usually starts between 18 years to 30 years, so that is not age of degeneration. So corner of the end plates without degeneration, multi-level shape. Look for Anderson's lesions also in the vertebral bodies. Check for the SI joint status. SI joint is one of the biggest clue. But remember that you can have, without sacroiliitis, you can have seronegative still. Don't go back, but slightly go back and put as a second differential diagnosis. Facial is one of the favorite area for the ankylosing spondylitis. You will have good number of the patients, even in the first present, some facial inflammation or costovertebral joint inflammation. This I have taken from one of my friend. This is what, can you guess that diagnosis? T2 hypointense arthritis. Bilateral symmetrical, no enhancement in the center. T2 hypointense. Only 6-7 are there, T2 hypointense. Gout. And this came as infection versus non-infection. Medicine professor's wife, so we need to be careful what we are talking. This is a rheumatoid arthritis related spinal changes. So it's not so common, but by the time you know the spine is involved, you know that patient is rheumatoid arthritis by examining their hand. So this is a case of multiple discitis features. This patient is also a doctor. So then we don't know what we are dealing with. So this is also shared by one of my friend. and this is showing extensive degeneration with bony sclerosis. So it's not infection. What it is? This is the answer. His eyes are little bit black, that's why they asked for urine test. 24 hours. Perfect, alkaptonuria, achronosis. So this is one of the published case. SAPHO, multi-level vertebral inflammation. SAPHO stands for synovitis, acne, pustulosis, hyperostosis and osteitis. So these are the mimics of the spine as requested by the organizers. The heading justifies. Tumor we have covered, seronegative, modic changes, other inflammatory, even metabolic like alkaptonuria can mimic infection. So this is grossly covered in the upcoming journal. So this is my acknowledgement, my students and others. This is you try, this is Bhubaneswar picture only, Trident Hotel, which is themed with the Orissa style. So you can ask me anything pertaining to radiology, exams, career, anything. If you want, you can write to me. Take this as a photo. So the QR code works. Just now I checked again. Thank you very much. So I'll be coming back after one talk.
Thank you, sir, for the emphatic discussion. I would like to request Dr. Sikandar Sheikh, Chairman of ICRI, to felicitate sir. Our next speaker is from Guwahati and represents the perfect amalgamation of diagnostic and interventional radiology. Dr. Kalyan Horma is an associate professor at AIIMS Guwahati and will explain the indications and protocols of vessel wall imaging.
Good afternoon. Good afternoon, respected seniors, my juniors and my colleagues. First of all, on the very onset, I would like to thank the organizers for this opportunity. In the next 20 minutes or so, I shall be discussing on vessel wall imaging, mainly its indications and protocols, and we'll be going ahead with some clinical cases. Now, as we all know, we have available luminal imaging modalities such as CT angiography, MR angiography, then we have DSA. But this only gives us information about the lumen. Most of the time, whatever information we get are non-specific, such as luminal narrowing or sometimes beaded appearance or stenosis. Most of the disease pathologies in the early stage lies within the vessel wall. So with the advancement of MR imaging technology, the vessel wall imaging has come up with high resolution imaging, with contrast spatial resolution, that is the MR vessel wall imaging, which is mainly used to evaluate the arterial wall. Now, as we need a very high contrast and spatial resolution, so a high SNR is required. So 7 Tesla MRI is the best, but 3 Tesla MRI is always preferred over a 1.5 Tesla MRI. Now, specific sequences are used. I will not go much into the physics of this, but we should understand that these are usually multiplanar 3D acquisitions, and multiple vendors have been providing these sequences. The most commonly, we use the space, which is provided by the Siemens. And basically, they suppress the signals from the blood as well as the CSF and the surrounding tissue. Now, coming to the indication of high-resolution vessel wall imaging. Now, with the advancement of vessel wall imaging, it has been indicated in the evaluation of acute ischemic strokes, in the evaluation of multiple vasculopathies such as CNS vasculitis, both primary as well as secondary, and also in evaluation of ischemic strokes, and to differentiate other ICAT mimics, that is the intracranial atherosclerotic disease such as Moyamoya disease, arterial dissection, intracranial aneurysm or RCVS, which we shall be understanding in the later slides. So coming first to the pre-assessment. Most importantly, we should have a clear-cut clinical status of the patient. Now, one thing we need to remember that facial wall imaging is a time-consuming imaging. So we will be additional 30 to 40 minutes will be required in and ahead the conventional imaging. So the patient should be fit enough to lie still during this period, because motion artifact will cause artifacts in this imaging. Secondly, we need to preview all previous imaging, such as the conventional MRI imaging. That will help us in assessment of the brain parenchyma and also to select the region of our interest. And as we know the region of the interest, we need to know where we are going to focus, that is the anterior or the posterior circulation. Now, treatment status is very important because most of the time in case of CNS vasculitis, if the patient is getting steroid, then we are expecting that whatever enhancement we are supposed to get in post-contrast facial wall sequences, it will be either low or it will be minimal. Secondly, any contrast administration prior at least less than 12 hours before facial wall imaging can cause pre-contrast residual enhancement, which can give a false positive result. Now, what is the protocol that we need to tailor type as per our needs? So in our institute, we use the 3 Tesla VIDA as per the conventional imaging, which is basically to target the area of interest, to know the site of the parenchymal envelopment of the vessel. Second, the most important sequence for as a localizer is the 3D TOF MR angiogram. This will help as a localizer to understand whether we are dealing with the posterior circulation or the anterior circulation, as well as to survey for the intracranial lesions. Mainly the facial wall sequence, it is the 3D multiplanar imaging, that is the space. We will be using most importantly the pre-contrast 3D space T1, as well as the post-contrast 3D space T2, which will detect the facial wall thickening for presence of any intraparenchymal, that is IPH, as well as the intramural hematoma. The second is the 3D space T2 sequence is required to detect the juxtaluminal T2 hyperintensity, and additional sequence such as the, the 3D spaces can be taken for the plaque localization. Now what to see for a facial wall imaging? This is a systematic approach. First of all, we need to review the MR angiogram. Here we will be looking for the site of involvement of the arterial stenosis. If we get an arterial stenosis in facial wall imaging, we need to see for wall thickening, whether it's an eccentric involvement or an circumferential involvement. Then comes the wall enhancement, which has to be graded as per the signal intensity of the pituitary stalk as grade 0, which is normally seen in case of grade 1, where the enhancement will be less than that of the pituitary stalk, or sometimes grade 2, where the enhancement is greater than the pituitary stalk. Then the plaque localization once done, then the signal intensity, we will be discussing all this in our clinical cases. Most importantly, remodeling pattern, whether we are going ahead with a positive remodeling or a negative remodeling. Now, positive remodeling where the vessel expands to accommodate the plaque are high risk plaque. Then the intraplaque hemorrhage are also vulnerable plaques which can cause a distal emboli. The most important indication, as we have already discussed, is the detection of intracranial atherosclerotic disease. This is an entity which is usually underscored and is underreported in Asian countries, including India. We need to remember the prevalence is quite high in Indian scenario and is one of the most common causes of ischemic stroke. So the distribution is, it can affect both the anterior circulation as well as the posterior circulation. So what are the vessel imaging characteristics of a intracranial atherosclerotic disease? As already told, the wall thickening will be most commonly eccentric pattern. As we can see, there is eccentric luminal thickening that is involving less than 360 degree of the vessel wall. Secondly, it can also present a circumferential thickening in some 10% of cases. Wall enhancement, post-contrast wall enhancement will be there. It will be grade 1 enhancement. That will be just less than that of the pituitary stalk. Now, most importantly, we need to look in T2 weighted images, that is the juxtaluminal T2 hyperintensity, which suggests the presence of fibrous cap. That is 100% specific for intracranial atherosclerotic disease. Once we get the fibrous cap, that means our diagnosis is confirms an intracranial atherosclerotic disease. Now let's go ahead with our clinical cases. First, a 68-year-old male presented with recurrent episodes of left hemiparesis. As we can see the parenchymal imaging of the axial flare, we can see there are chronic infarcts in the right MCA territory. This was the DSA images, and the DSA images we can see multiple areas of narrowing involving the supraclinoid as well as the M1 MCA. the patient underwent the high resolution facial wall imaging. So what we can see, this is the first image, that is the 3D space T2. As we can see, this is the lumen. Here we can see juxtaluminal T2 hyperintensity. Juxtaluminal T2 hyperintensity, that means there is a fibrous cap. Most likely the patient is having an ICAT. And this was the pre as well as the post contrast images, which shows eccentric wall thickening, showing post contrast enhancement. Also, as we can see, there is involvement both in supraclinoid ICA as well as the basilar, involving a mixed vessel involvement of ICAT. Another case of a 68-year-old male presenting with left hemiparesis. As we can see, scattered areas of diffusion restrictions suggestive of M1 MCA territory infarct. In the MR angiography, it shows the region of our interest, which shows multiple areas of narrowing involving the M1 MCA in the MR angiogram. We know where we have to see for the vessel wall imaging. So these are the high resolution vessel wall imaging. As we can see, there is eccentric wall thickening, suggestive of an ICAT with juxtaluminal T2 hyperintensity, showing post-contrast enhancement, which again suggests a fibrous cap. Most likely it's an intracranial atherosclerotic disease. Another case of a 52-year-old presenting with left hemiparesis, scattered areas of diffusion restriction in the right hemisphere. In the region of MR angiogram, we can see again areas of narrowing with irregularities. On vessel wall imaging, we can see this was a pre-contrast T1 weighted images. There is hyperintensity, which suggests a intra-plug hemorrhage, which suggests that the plug is unstable, which is causing distal emboli. We need to really understand the vessel wall imaging, as these are very high resolution images and our image will be zoomed in to get a better view. Another case of a 78-year-old male presenting with left-sided visual disturbances. As we can see, there is axial flare as well as the diffusion weighted images. There is a PCA territory infarct. So our region of interest is the PCA. So when we see the MR angiogram, we can see the P1 PCA is not visualized, as well as there is narrowing in the M1 MCA on the right side. On high resolution vessel wall imaging, we can see there is eccentric narrowing with post-contrast enhancement suggestive of an ICAT, which is the culprit. Because of this, there is a stroke. Now another case of ICAT with MCA territory infarct. As we can see on the source images, there is narrowing in the M1 MCA with post-contrast enhancement on the T1 space sequences. Also the enhancement of the subacute infarct, we can see in the subacute infarct, which is also enhancing. As we can see, this is the pituitary stalk. This enhancement will be either equal to or it will be less than the pituitary stalk. This is also important in grading of the ICAT lesions, which we'll again see how to differentiate it from other conditions. These are the multiplanar imaging of the same patient. As you can see, there is narrowing with eccentric enhancement involving the M1 MCA. Another case of posterior circulation stroke. We know where is our region of interest. As we can see, there is basilar artery which showing significant narrowing. And on high resolution vessel wall imaging, there is eccentric wall thickening with showing post-contrast enhancements. So other mimics which needs to be differentiated with the help of vessel wall imaging is CNS vasculitis, which can also present with ischemic stroke-like pattern. Now, in case of CNS vasculitis, we will be encountering concentric wall thickening, and most importantly, the juxtaluminal T2 hyperintensity, which was specific for ICAT, will be absent, and the enhancement will be higher, provided the patient is not getting any steroid. And this higher enhancement will be grade 2 enhancement as compared to the pituitary stalk. So here is a case of a 35-year-old female presenting with headache with right-sided weakness. There is a scattered diffusion restriction in the left MCA territory. So we know our region of interest. In the left M1 MCA, there is focal narrowing. As we can see, high resolution vessel wall imaging was done. As you can see, this was the base images. And as compared to the normal side, right M1 MCA, as we can see, there is hardly any enhancement or thickening. But here is enhancement which is much more than that of the pituitary stalk, and this enhancement is concentric and is along the entire wall of the vessel. These were the magnified images, concentric, and it is along the wall of the vessels of the M1 MCA. Also the enhancement is extending beyond the periadventitial layer of the vessel. Periadventitial layer of the vessel, these are the multiplanar imaging of the vessel wall. It was a case of vasculitis. As we can see, the enhancement is extending beyond the facial wall, which is suggestive secondary to a vasculitis. The patient had an infarct. The Moyamoya disease is an idiopathic condition that can also mimic. It needs to be differentiated with the help of high resolution facial wall imaging. Usually they have a bimodal distribution. Whenever it is in young patient, we doesn't have any risk factor of ICAD, but whenever this condition presents in the later stage, such as in 4th decade of life, then facial wall imaging really plays an important role to differentiate it from atherosclerotic risk factors, because the management is different. In Moyamoya disease, there will be again concentric wall thickening, there will be absence of juxtaluminal T2 hyperintensity, and typically will involve the, as we know, progressive supraclinoid ICA or sometimes the proximal MCA. Here was a case of a 17-year-old female patient with history of TIA. As we can see in the Moyamoya flare, in axial flare, these are the typical findings in Moyamoya, that is the sulcal hyperintensity on flare, without any significant diffusion restriction on suggestive of an infarct. IV sign can be seen. And this was the angiogram which is seen typically for Moyamoya. There is supraclinoid ICA narrowing at multiple Moyamoya collaterals. Now this was the high resolution facial wall of the patient. As we can see, there is concentric minimal wall thickening of the supraclinoid ICA without significant enhancement. As we can see, this was the pituitary stalk which we need to compare with the pituitary stalk. The enhancement is much more less than that of the pituitary stalk. Sometimes it may be minimal or absent. Another case of a 53-year-old male who presented with chronic parenchymal bleed. As we can see, this was the old bleed in the temporal lobe. On blooming, it is showing blooming on SWI images. This was the image on the MR angiogram. As you can see, there is significant narrowing of the M1 MCA on the right side with multiple collateral formation on the MR angiogram. There is also presence of arterial transit artifact on the ASL images, suggestive of slow flow along the right cerebral hemisphere. Now this was the facial wall imaging. As you can see, there is significant narrowing of the M1 MCA with, now this is concentric pattern is not there, there is eccentric pattern of enhancement. It was secondary to an ICAD disease which is causing Moyamoya-like collaterals, which we need to differentiate. Arterial dissection can present with eccentric wall thickening and usually involves the P4 segment and sometimes the supraclinoid ICA. Here most importantly, we need to recognize the intramural hematoma showing T1 hyperintensity. There are multiple cases of images of a 40-year-old female. It was a spontaneous ICA dissection. As we can see, this was the eccentric thickening with intraluminal, intramural hyperintensity, suggesting of intramural thrombus on the T1 as well as T2 images. And this was the MR angiogram showing significant narrowing at the dissection site. And on high resolution vessel wall imaging, the intramural hematoma showing high signal intensity on the T1 weighted images. Here on high resolution facial wall imaging on the coronal section, we can see the false lumen as well as the flap quite significantly seen in the high resolution facial wall imaging. Another case of a 40-year-old male patient presenting with left-sided hemiplegia with posterior circulation infarct. As we can see, the region of interest will be our posterior circulation. On MR angiogram, the V4 segment of the right vertebral artery is not visualized. And on facial wall imaging, there is eccentric enhanced hyperintensity on the T1 weighted images, suggestive of a vertebral V4 segment dissection with intramural hematoma. And this hematoma extension with the false lumen can be seen on the P4 segment on facial wall imaging. Now another important condition is the reversible cerebral vasoconstriction syndrome, which can present in case of young females, they can present with thunderclap headache, one of the differential for an aneurysmal SH. And sometimes they may also present with, because of vasospasm, as cortical infarcts can also present. Now this condition, sometimes because secondary to vasospasm, they can present with scattered infarcts, with presenting with thunderclap headache. The typical appearance is multiple areas of beading will be present in that of the MR angiogram, and both in the anterior circulation in the M1 MCA as well as the P1 PCA. Now the facial wall imaging will show smooth circumferential thickening without any significant enhancement. There is no significant enhancement, only smooth circumferential thickening. Now this condition, we need a follow-up. If we are suspecting a reversible vasoconstriction syndrome, then follow-up imaging should be done, preferably at 3 months. Usually they resolve. And so this was the follow-up MR angiogram, which shows complete resolution of the narrowing of all the vessels. Now, facial wall imaging has also been used in case of unruptured intracranial aneurysm to see the activity of the facial wall. Whenever there is unruptured intracranial aneurysm, if there is enhancement, studies have shown that these are unstable and needs urgent treatment. This here was taken from the textbook. As we can see, there is a supraclinoid aneurysm. The imaging was done with a 7 Tesla MRI with circumferential wall thickening along the facial wall, suggesting of an unstable and inflammation going on within the facial wall, and this can have high risks of rupture and needs urgent treatment. So to summarize, this was a table taken from a journal, quite properly given in ICAT. In the high resolution facial wall imaging, most important is the wall thickening pattern. As we can see, eccentric wall thickening most commonly seen in ICAT. And once we are able to identify the juxtaluminal T2 hyperintensity, that means we are sure that it's an ICAT disease that is only present because of the fibrous cap. Other conditions such as vasculitis, RCVS or moya always have concentric wall thickening. And definitely dissection will have eccentric or the semulunar sign, and there may be presence of intramural hematoma showing high intensity on T1 weighted images. Secondly is the enhancement. The most important enhancement will be seen in case of vasculitis, and the enhancement will extend beyond the facial wall in the periadventitial space, and these have very high effect with steroids. If the patient is getting steroid, we are not going to get any enhancement. That is important and needs to be taken into history. And once the juxtaluminal T2 hyperintensity is seen, wall enhancement pattern, eccentric, most likely it's an ICAT, concentric pattern, vasculitis, and this will show grade 2 enhancement, that is above that of the signal intensity of the pituitary. And most importantly, follow-up needs to be done. In case of RCVS, these symptoms will be resolving within 3 months of time, and repeat MR angiograph will show that the narrowings has all disappeared. So there are some limitations which we all should be very careful while interpretation of the high resolution facial wall imaging. That is the normal enhancement of the veins running along the arteries. And most importantly, the artifacts can be caused because of slow flow and motion, and normal enhancement of the vasophasorum in the large arteries, which can also cause abnormal arterial wall enhancement. So I'd like to conclude that facial wall imaging is becoming an important role in the differentiating different intracranial vasculitis. Most importantly, the ICAT, which is an undetected and underscored as compared to the extracranial atherosclerotic disease, and can differentiate it from other mimics such as vasculitis, RCVS, or intracranial dissection. And disease activity can be definitely assessed to know the vulnerability of the plaque, as well as which needs treatment, and to also know the progression of the disease. Venous enhancement should be kept in mind. Also, the presence of normal vasophasorum and slow flow can mimic normal and abnormal arterial artifacts should be kept in mind while interpreting facial wall imaging. Thank you. Any queries we can ask otherwise? Thank you.
Thank you, sir. That was a very well assembled presentation. I would now like to request Dr. Sandeep Feliceti to felicitate, sir. We would like to request Dr. Feliceti to return to the podium for his second discourse on imaging and classification of bone tumors.
Yeah, I'm very more complicated than so this is because of the particular topic, I have requested our organizer to rearrange 10 more minutes in the last minute accommodated. So you can take any number of screenshots if you want, because I'm not going to publish this soon. So in the next 30 minutes, maybe 1 or 2 minutes more, I'm going to talk about bone tumors, imaging approach, how to approach when you see like it's like a second year standard I kept. And this is pretty much useful for you will get in the exam. Either it is short case or long case, At least 2, 1, 2, maximum 2 among the 40 spotters, you will get bone tumors or tumor mimics. So the scope of the talk is classification of the bone tumors, modalities, which modality is for what, approach to the diagnosis, benign tumor, malignant tumor, and tumor mimics. This is the side headings which I am going to cover. Unlike brain tumor, they don't revise so fast. They revised last time is 2020 before COVID, I think. This is 5th edition of WHO classification of bone tumor. That is based on the cell of origin. The main method of classification is based on the cell of origin. Some genetic features here and there are added, but mainly for the cell of origin. And each cell of origin, they have tried to differentiate, to put different categories of benign, intermediate or unknown malignancy or frank malignant lesion. 3 categories they tried to keep. So chondrogenic tumors are benign, enchondroma, chondromyxoid fibroma, osteochondroma, including parosteal, periosteal osteochondroma, chondroblastoma in the pediatric age group. Intermediate is chondromatosis, atypical cartilaginous tumor, and malignant. Even your pathologist has the same, because it's not radiology, it's mainly pathology. He gives like the atypical cartilaginous tumor. Then you need to understand and reinterpret what you have interpreted before the diagnosis. Malignant chondrosarcoma. So osteogenic tumor, benign osteoma, the one which you get in the skull. Osteoid osteoma, the one which is painful bone lesion. Intermediate is osteoblastoma, which are larger than the osteoid osteoma, and malignant is osteosarcoma. Various types of 5-6 types of osteosarcoma are included in this. Third category is fibrogenic tumor, that is intermediate, desmoplastic fibroma, and fibrosarcoma, malignant variety. Vascular tumors, benign hemangioma, intermediate is epithelioid hemangioma, which has some aggressive features. Malignant is angiosarcoma and epithelioid hemangioendothelioma. So osteoclastic giant cell tumor, most of the common exam benign spotters belong to this category. So aneurysmal bone cyst, non-ossifying fibroma. Intermediate is giant cell tumor of the bone. Malignant tumor is GCT has a malignant potential of 15 to 20% frank malignant. So giant cell tumor of the bone, malignant. Other notochordal tumor, which is central hyperintense lesions. BNCT is very common. If you see 100 spines, especially S2, S3 level, you will see bright spots. Homogeneous ones, those are nothing but BNCT or benign notochordal tumor. Malignant is chordoma, various type of chordoma. Other mesenchymal tumor, simple bone cyst, which you see in the pediatric age group, which migrates down. Fibrous dysplasia, lipoma. Intermediate mesenchymal is osteofibrous dysplasia like adenoadenoma, which is benign or intermediate, or frankly malignant one, that is adenoadenoma of the long bones and leiomyosarcoma. Hemopoietic neoplasms of the bone are very important. Lymphoma of various types. Plasmacytoma of the bone before multiple myeloma. Longer cell histiocytosis and dead in chest disease also comes under hemopoietic neoplasms of the bone. Undifferentiated small round cell, these are just like a small blue round cell tumors, just like what you see in the retinoblastoma, pinealoblastoma. Same category, it belongs genetically also very close, having sarcoma, round cell sarcoma. So how do you approach? You see a particular bone lesion. So your approach is your description is your diagnosis. So if you can describe very well, you made a diagnosis. Based on your own description, you derive to some conclusion. Examiner or even the clinical practice, nobody can say no to that. So the histopathology may come differently, but nobody will interpret it as a mistake or wrong, because your approach is correct and you have drawn whatever you could draw in that particular case. So if you follow all the rules, 80% of the times you will be correct in the histopathology wise. Always you will get miracles in the different surprises in the histopathology which are not expected by you. So when I started practice, I started collecting what are the things which I could not diagnose, but there are too many now. That's why I stopped that series, because you cannot diagnose everything well. But classical case you should not miss. So zone of transition, wide zone of transition, when you can you have to try to mark the margin. If it is very sharp, benign, whether you cannot mark any border, then you are dealing with infection or malignancy. Age is important. Age is first, second, third thing in the order. So age, half of the tumors you can remove by age. The same thing also stands in the brain. Location and age, two important parameters. makes 50% of the diagnosis either in the bone tumor or in the brain tumor. So you don't need to struggle the entire list of the differential diagnosis of that particular imaging appearance. So by age, suppose if somebody gets GCT at the age of 60, if you missed it, then it is fine, because it's very odd at that age group. So in that way, you need to approach that particular cases. Periosteal reaction, which I am going to cover in detail, cortex involvement or medullary involvement, combined cortex or medullary involvement, you have to describe central, eccentric, location, epiphysis, longitudinal location, epiphysis or metaphysis or epimetaphysis if it is occupying both metaphysis or diaphysis. Location is centrally located, eccentrically located, cortically located, juxtacortically located, just immediately outside the bone. So this location gives, if you have to diagnose Nora lesion, it is location only. If you have to diagnose surface osteosarcoma, purely location. So matrix, you need to get used to this matrix if you see 3-4 classical cases. Otherwise, just Google in the images osteoid matrix or mineralization of the matrix, different matrix, chondroid matrix, how the matrix will be in case of Paget's, how the matrix will be in case of FD. You will, once 3-4 cases, if you see classical ones, you got the approach. Polyostotic or one lesion. If you see second lesion, that changes everything. So if you see one lesion, that is a different pool. So half of the diagnosis can be eliminated in the multiple diseases or single bone involvement. So this, there are 4 graphics I kept, all I have taken from radiology assistant, which has given reasonable description for all the tumors. Below 30 years, these are the list of the tumors which you can get. I don't need to read all of them. Location wise, central, eccentric, cortical, epiphyseal, metaphyseal, diaphyseal. Same thing, above 30 years, age is important, as I told. This is central, this is diaphyseal, metaphyseal, epiphyseal lesions. Just keep them in mind. So tumor distribution in the skeleton. Again, whether it is involving which part, long bone or short bone, whether it is flat bone, whether it is longitudinal bone, axial skeleton, appendicular skeleton, there is no discrimination of that involving both. These are all matters in the narrowing the differential diagnosis before even imaging features. So age matters, as I told. So simple bone cyst never comes after 10 years. So fibrous dysplasia never comes after 30 years, starting wise. It can be persistent, but doesn't start that later. So age is very important. So what is the diagnosis? Be interactive. No diagnosis comes first in the coming slides. Everything will be blanked. You just keep on guessing, so that it boosts your brain more than the tea. Trust me. What is the diagnosis? Very straightforward, simple. 10 seconds. Yes, GCT. Why? Yeah, fused epiphysis, mature skeleton, eccentric, lytic, subarticular, expanding the cortex, destroying the cortex, extending outside, in no internal septations. Period. So GCT. So that is not by just imaging features. Imaging features are important, but age and location is very big clues to diagnose GCT. Location specific tumor. This tumor comes only at this. I did not get histopathology from any other part. I think one case I got from the skull, but not from the jaw. What is the diagnosis? Young patient. Very good. Can you describe? Predominantly cortical, with cortical swelling, with site medullary extension, sclerosis, multiple cluster of bubble-like appearance, adamantinoma. So this is not ameloblastoma. The previous 2 decades back, it was like a synonym, but they are different. That is locally aggressive. This is malignant lesion. This is never comes in the jaw, vice versa. So this is adamantinoma. This is very common spotter in the exams because of unique location. You cannot write any other diagnosis. Though the fibro-osseous dysplasia comes very close, and you have tables in the book, you just read what are the differences detailedly between fibro-osseous dysplasia and adamantinoma. Zone of transition is big clue. What is the diagnosis in the first case? Narrow zone of transition. This is the best example I can give. Very well defined lesion with sclerotic border, very narrow zone of transition. So you never get malignant diagnosis out of this. What is the diagnosis? Very good. The other one is wide zone of transition. You cannot mark where is the lesion starting, where is the end. Both ends you cannot see. And there is also periosteal reactions. So what could be? Pardon? Wings. When you have hammer, everything looks nice. So purposefully I kept, because even when you are thinking completely malignancy, based on this pattern, you have to think another thing, which is, yes, that is the diagnosis. Acute osteomyelitis, biopsy proven, pus has been drained in that case. So all the malignant pattern in the plain radiographs are not malignancy. It can be infection, especially in the pediatric age group. What is the diagnosis? Multiple bubbly like T2 hyperintensity lesions with internal septations, whose septations are enhancing. Central part is not showing any enhancement. The adjacent bone is not showing much changes. Pardon? This you keep in the bone, what you will get if it is within the bone. Pardon? Chondrosarcoma, very good. This is soft tissue chondrosarcoma. You can make eccentric diagnosis and you can get confidence by checking the calcification, arc-like calcification, comma-like calcifications. If you see, that is very characteristic of the chondroid matrix. This is a chondrosarcoma. So calcification is one of the big limitation in the MRI. You will practically miss these small calcifications. You can take always limited section CT scan, plain CT scan. T2 signal is the key. This I believe in the brain. This I believe in every other tissue, including bone tumors. Very bright, very fluidy, like it could be cyst. It's almost fluid in the soft tissues around the joint. You might be dealing with synovial sarcoma. If it is close to the cyst, near the joint, into the joint, it is ganglion cyst. It is bubbly and very bright, very bright. I am coming high to low order. Very bright, bubbly appearance, multiple lobulated, lymphangioma or hemangioma. Slightly dark, fibrous tumor, GCT. More dark is frank fibrogenic tumors. Even more dark, almost no signal. Maybe you have to check whether you are dealing with any vessel, or it could be ossification. So T2 signal is key. 5 to 6 grades I just divided. In a detailed lecture of that soft tissue tumors, I kept multiple slides for that example. So this is, what is the nature of tumor? Can you diagnose this? Pardon? Fibrous lesion. Okay. Any other things? Surrounding knee joint, not non-ossifying fibroma. Fibrous like tumor. 40-50% of the tumor will be hypointense on T2. So imagine if it is down 1 centimeter, 2 centimeters maybe, subarticular, eccentric one. GCT. So this we kept GCT in the DD based on the signals. That's slightly above than the usual. This is one of the journal. I usually quote the journal. I just by mistake I forgot to quote the journal. You can Google it. Modified in our school days, college days, they used to teach Ludwig classification. Now they modified it with this long name. So the pattern of in the plain radiographs is a big clue. Never miss. I told that you always insist for the spinal radiograph for tuberculosis. You won't be so surprised if you don't get in the spine, but you will get frequently surprised if you are reporting an MRI of the bone tumor without seeing the radiographs. So the pathologist, it is also a mistake on his behalf if he is reporting anything bone tumor without seeing radiographs. To insist a point, I went to US. There is in the clinical radiological meet, there is a guy is reading completely any radiograph you keep, he is reading to the perfect. Then next day he is reading pathology. I said, how do you know pathology so well? He said, I am pathologist basically. So he need to be thorough. So it is a combination. Unless you can read, if you miss, it can go terribly wrong if you directly interpret MRI. So this is very well defined with sclerotic border. No sclerotic border. So that's 1A, 1B. So I don't need to remember this one. You can remember like old classification. Very well defined, intermediate one with the large areas. And this is multiple lytic lesions, big lytic lesions, sparse to distant. Then it is borderline or intermediate. This micro bubbly type of destruction, just like how you have seen is called permeative type of destruction. Then it is 3B or mouth eaten type of pattern. Earlier they used to teach mouth eaten is borderline, even still benign. Permeative is definitely malignant or it can be infection. That is the rapidity of the change. So infection also can produce permeative pattern. So this is what pattern you call this? 1, 2, 3, permeative, geographic, mouth eaten, no zone of transition. That is the lesion. And the diagnosis, MRI, extensive soft tissue, much more involvement than what it is seen in the radiograph. This is metastasis from the carcinoma breast. So this is the last image graphic I've taken from assistant. Solid periosteal reaction, thick periosteal reaction. We have developed indigenously with our residents with that Apple and other softwares. It's there in the YouTube. So our resident is drawing nearly all the images just like this quality, almost like this quality. So I gave them offer that if you don't participate anything in the article writing, if you can draw these 4 pictures, you will be one of the others. So now every batch 2 people are drawing now. So solid and benign periosteal reaction. This is lamellated. Lamellated can be benign, lamellated can be malignant. This is onion peel type of this one. It can be seen in the wing sarcoma like that. So it has in both ends. Spiculated or aggressive. Here the bone deposition will come along the fibrovascular channels. Here it is too aggressive, Codman triangle. As soon as it forms, it gets disrupted and destroyed partially by the new cells rapid replacement. So this is definitely malignant one. Very rarely benign things will appear like that. Till then there is a benign overlap. So you need to mug up all this for the exam. It can be a short notes. Don't depend completely on the periosteal reaction. The older the examiner, the more he will ask about periosteal reaction. So a pattern in which radiographs, all the radiographic patterns give some clue. So spend 2-3 minutes analyzing the radiograph with or without MRI, before or after MRI. What is the diagnosis? I'll show MRI again for this patient in the second half. No zone of transition, some permeative type of pattern, saucerization, periosteal reaction might be there, which might have broken, cortex is become piece-like, and there is a large soft tissue component. Young adult. Perfect. So what now? I finished approach. Second subheading is modalities. What are the modality? X-ray is the key. So always take the X-rays. All these 4 diagnoses either directly diagnosed by X-ray, or we felt that we should have taken X-ray for this after taking a MRI. So some of the X-rays are, this is ordered by me, this X-ray is ordered by me. Can you see arrow, right? Yeah, this they have taken. This is actually a case of multifocal osteomyelitis. They were working up for this unnecessary tumor. So this is diaphyseal achalasia. So X-ray is the mainstay. So CT has some advantages, finding a chondroid and osteoid matrix, lytic versus sclerotic lesion. Biopsy planning is usually done on CT scan. So MRI compatibility, if it is not there any claustrophobia, you can take a CT scan and see whether you can settle the issue. This is one of case which I found CT is very helpful. This is how it presented to me. Marrow edema, intense enhancement and post-contrast, pedicle centered in a child. So I felt it is some sort of metastasis despite child. I never thought that would be a benign diagnosis. So then I have taken X-ray. Then I got one place doubt. You should be able to diagnose here itself. Scoliosis. Pardon? Very good, very good. That is the good pickup. Then I picked up that one. Then I need to confirm that. Then I have taken a CT scan. This is the osteoid osteoma. 3 zones. Nidus in the central part, calcified partially, fibrovascular rim which is hypodense, surrounding reactive sclerosis secondary to the osteoid osteoma. So in the recent advances you may get radio frequency ablation by CT scan, which is very commonly done nowadays by radiologists. So MRI has advantage. You need to have 40% of the bone or bony marrow destruction to appear in the X-ray. 10 to 20% destruction is enough in CT scan. Radionuclide scan in blood full phase or other phase, it detects even at 10%. MRI can pick up even 5% of marrow change. That's why MRI has got some advantages. So along with all the routine T1, T2, PD which you are taking, try to take DWIBs, especially when you are ambiguous, or if it is localized lesion, add diffusion weighted. Everything is now sarcomas, everything now diffusion based. So take one section of diffusion, and you can do 4D tracks or 4D tricks angiography also while giving contrast with your 10 ml dose itself. So MRI is very useful because it can characterize tissue very well. This is hemorrhages, multiple hemorrhages within the tumor. Diagnosis would be anything which gives fluid. There are 6 diagnoses. So it can be osteosarcoma, GCT or ABC with GCT. fibrous tissue signals. Juvenile fibromatosis, straightforward diagnosis we have given for that case. Cartilage signals are very easy to identify, get used to that. And this is fat signals are very useful for all lipogenic tumor. What could be this T1 brightness in the post-contrast? Plain study. T1 post-contrast plain study, no hemorrhages in the CSF. That's melanin deposits over the meninges. I just showed this to have idea that how nicely MRI can characterize the tissue characterization. So why we do MRI is to detect tumor involvement. Sometimes it gives very diagnostic clues, just like fluid hemorrhagic levels after plain radiograph. To see the joint involvement, neurovascular involvement which is required for the surgery, tissue characterization, soft tissue component assessment, detection of multiple lesions if there are any, because X-ray you will see one, suddenly after MRI you will see 2, 3. So suggesting correct site for the biopsy. Follow-up imaging also MRI is necessary. This you can read any book, TNM classification for the bone tumor just like any other parts. Soft tissue involvement is best seen in the MRI. You can see direct extension into the tumor. So joint involvement, here the joint is directly invaded. So vascular involvement, you can do an angiographic study and see the vessel involvement. Role of contrast is in debate now. Many expert centers, they are telling that they are not requiring any contrast to get the diagnosis, and you can get in the plane itself. So it's a case by case and your distinction. They are publishing papers also that contrast is not required. So DVIPS is commonly increasingly getting used. Lymphoma, I believe lymphoma it is very useful. This is metastasis case, and it is very standardized and recommended by their committees to use DVIPS as a standard staging modality in replacement of the whole body CT scan for the multiple myeloma, because it doesn't greatly pick it up in PET CT scan. So radionuclide scan, our president is there, he is expert. A case by case basis you might require this one. So spotters like thing. Benign tumors, I have 7 minutes as per the computer. Yeah. Yeah, thank you. So diagnosis, benign looking lesion, well defined border, internally some matrix or sclerosis, God knows. Diagnosis, anterior tibial, young adult. The lesion contains predominantly T1 fat with 2 cysts, cyst 1, cyst 2. The fat is completely suppressed. Diagnosis, fatty tissue with cysts plus sclerosis you have seen. You don't need anything for diagnosis, but CT have given. Sclerosis, patchy sclerosis, 3 is cyst, minus 72 is fat. Fat cyst sclerosis. Intraosseous hemangioma, such a macroscopic fats, big chunks, 90% is fat. Why hemangioma will have cyst inside? Nothing else fits into this. This 3 combination. Stage 3, there is a scientist also for that. Eccentric lytic lesion, young adult, 13 years, history of trauma. Nothing to do with the trauma, it's just misleading. Don't jump to epidermoid inclusion, which I kept differential diagnosis, because child we cannot rely. Apple bite like, eccentric lytic lesion. T1 and T2 again. Homogeneous, matrix, hyperintense. It's looking like this, right? Big bite, but not small bite like this apple form. So chondromyxoid fibroma or enchondroma. So it's a cartilaginous tumor. That is how enchondroma looks. That is how chondromyxoid fibroma involves in any bone. Eccentric lytic lesion like apple bite. It commonly comes at anterior part of the tibia in the metaphyseal diaphyseal junction. Straightforward, simple, multiple lesions, fatty lesions, mixed with non-fatty elements, central prominent trabeculations, classical hemangioma. metaphyseal lesions, growing away from the joint space, irregular calcification in the outer surface, direct continuity of cortex as well as medulla to the parent lesion. Pardon? Yeah, straightforward osteochondroma. You need MRI for the purpose of assessing cartilaginous cap, which is now settled at 2 centimeter, 1.5 before 1.5 after growth plate closes, 2 centimeters before. So it's arbitrary, don't worry about that one. Sudden increase in the cartilage thickness is important. This is how the cartilage cap looks. You take the maximum diameter in the anteroposterior oblique diameters. There can be adjacent pseudo-bursa formation. Don't include that pseudo-bursa in that. So this is classical cartilaginous cap. What is the diagnosis? One lesion, second lesion, third lesion. Pardon? Previous name is diaphyseal achalasia. Now they are asking us to call multiple hereditary exostosis. MHE they are calling. Yeah, not uncommon. They have more malignant potential, they have more complication rate, they have more tendency to form pseudobursa, vascular compression, neural compression. So 10% almost malignant potential compared to the 1% in non-hereditary individuals. Irregular lobulated T1 hypointense lesion showing multiple T2 hyperintensities with sclerosis with some calcifications in the center. Very good. Enchondroma, not so classical, but you will see very classical ones. Every 100 MRI knee joints you report, you will see one beautifully rounded hyperintense lesion with sclerotic border with or without central calcification. Enchondroma. Just read how to differentiate benign cartilaginous tumor from chondrosarcoma. There are 5-6 differences tables, everything you can get in the Google images nowadays. Diagnosis 25 years old. All covered, only one is left. MRI. Multiple fluid levels, expansion lytic lesion, epimetaphyseal involvement, relatively young. So after the fusion, 10 to 15% of the ABCs will come. Before fusion, 5 to 10% of the GCTs will come. So it's not hard and fast rule. There is a percentage difference. So 10 to 15% of the adults will get ABC. Below children will get 5% of the GCT. So multiple fluid levels. What are the 5 to 6 differential diagnoses of multiple fluid levels in the bone and soft tissue? You need to mug up that table. Osteosarcoma, telangiectatic, periarticular milk of calcium calcifications also can have, tumorous calcinosis, chondromyxoid fibroma, some cartilaginous tumor. Sometimes GCT can have. GCT shows fluid level, call always that GCT with ABC. You are not wrong because 15%, 20% will have inherent secondary ABCs, right? I diagnosed once in the back soft tissue alone lesion based on the fluid levels. I called ABC it as soft tissue ABC. So malignant tumors. Diagnosis, middle-aged guy, 2 vertebral focus, pedicle center, soft tissue component, expanding the bone, lytic type of lesion in CT scan. Multiplicity pedicle center always should prompt us to call metastasis as a first possibility. This is a classical pattern of metastasis. Multiple lucent lesion in the skull, few lucencies in the humerus, difficult to appreciate. Multiple compression fractures in the spine prematurely, and femur also shows some lytic lesions. Diagnosis? Yes, very good differential diagnosis. Always you need to include that. Anything other than that? Multiple myeloma, this is a case. So this case, they diagnosed a compression fracture. But compression fracture of osteoporosis doesn't start at L5, right? And they ignored this pepper-like appearance, variegated pepper-like appearance. I will show one more case. So this is after 6 months, it became completely infiltrated T1 black. So what is the diagnosis and how it is progressed? This is completely hyperintense, like a diffuse bright marrow, super scan type. So this is super scan. Diagnosis is multiple myeloma. Okay, monoclonal gammopathy of unknown significance, it might be there. Slowly within 6 months it converted to smoldering multiple myeloma and frank multiple myeloma. If you don't recognize that, it will be spilled into the blood, and everywhere you will see in the blood test also. Diagnosis, you have already seen this case. Soft tissue component has been added. Ewing sarcoma, usually you will get case either in the long bone or you will get in the pelvis. Pelvic, if they show large soft tissue, it is always Ewing's. Maybe leukemia you need to keep in the differential diagnosis. So these are the pattern which you need to remember. This is normal marrow and this is abnormal marrow. You can call pepper like appearance, salt and pepper appearance, variegated marrow, heterogeneous marrow. So all the time you need to keep this leukemia in mind in the younger individuals, especially metastasis, myelofibrosis, multiple myeloma. Last but 2-3 cases. Extensive marrow involvement. This case, I participated in Asian Musculoskeletal Society in Singapore in the August last week. So I presented this case there, a 2 times shortlisted case, and I got prize for this. This is the best case in the musculoskeletal category by AMS Society. Lytic lesion, sclerotic lesion, diaphyseal involvement, disproportionate marrow infiltration in the STIR images, young individual. The reason they gave prize is this has been clearly given as a osteosarcoma on the biopsy and suspected as osteosarcoma. I kept as a osteosarcoma. Confidently, the previous day somebody kept in the group chondroblastic. I immediately made diagnosis. Everybody appreciated very well. Then I was very happy. Next day morning I saw this case. I kept chondroblastic osteosarcoma as a first possibility. But also I got some doubt and I kept small round cell tumor. Histopathology relieved everybody. Osteosarcoma it proved. They are planning limb saving surgery sort of thing. They went to another town. They consulted many. But I was warning that go further, immunocytohistochemistry. 6 sets of immunocytochemistry has showed finally one diagnosis, primary bone lymphoma. He has given only one drug for 3 months. It's melted out. You cannot identify where is the lesion now, even in MRI. It's like a normal marrow compared to the opposite side. Limb saved. He is back. He came from US. He is back to US. Joined the same job. 3 follow-ups he did. Completely normal marrow. Now I need to see which side was a abnormal earlier case. Classical teaching film, this is next case. You will get 100% in the exam, a short case, long case. Malignant pattern, this is the Codman triangle. I have to zoom to show it. This is soft tissue which is ossified. This is classical osteoid matrix mineralization. This is osteoid formation, lytic appearance, scalloping, cortical destruction, soft tissue component, everything metaphyseal, young adults. So only one diagnosis, conventional osteosarcoma. Another patient with osteosarcoma with multiple fluid level, hemorrhages level. Perfect, telangiectatic osteosarcoma. So there are so many tumor mimics you need to keep in mind because you practice so well the tumors. So all these can mimic tumor. The brown tumor, I already showed one brown tumor case. Chronic osteomyelitis. FD is a great mimicker. FCD, hemophilic pseudotumor, especially surrounding knee joint, bodies. Abscess is relatively easy to diagnose. Fast. What is the diagnosis? Anterior tibial cortex, no classical rounded bubbles. Osteofibrous dysplasia. Sometimes it is confusing with adamantinoma. Multiple lytic lesions, severe diffuse bone pain. I did DWIBS, super scan, everything is bright. I told I will give report only if you do calcium. So they did calcium, then we picked up the tumor and resected also. Sclerotic lesion, perfect, osteomyelitis, sequestrum, everything is seen. Yeah, morning Dr. Amit has already covered. So he came out of the coma after 2 months, then he complaining shoulder is not moving. Pardon? Charcot, no. Coma usually doesn't produce Charcot. And I told I need X-ray for the diagnosis. Then they took X-ray. Pardon? Perfect, myositis ossifications, those are the ossifications. So these can be juxtacortical osteosarcoma can mimic like that. There are some helpful signs. Just to take a screenshot this one, I know you are all tired. So this is written based on the experience rather than book. Chondrogenic tumor, you will identify that as a high signal T2 intensity, multiple internal small septations which enhances, arc-like calcification. Osteogenic tumors, you will pick them by sclerotic signals. You need to identify osteoid pattern. Fibrogenic tumors by signal T2 hypointensity, having sarcoma by malignant pattern in the radiographs, age, location. Lymphoma can be anything. It can be a lytic lesion, it can be sclerotic lesion, it can be part of the systemic lymphoma, it can be isolated bone lymphoma. Yeah, anything can be lymphoma, so there is no characteristic, it is varied presentation. Chondroblastoma, epiphyseal location before skeleton matures, and MRI wise you will see very impressive edema, just like what we call disproportionately large amount of edema, what we call for mets in the brain, is very characteristic feature. Giant cell tumors have mixed signal intensity, good amount of the signal will be T2 hypointense. Epiphyseal location is giant cell tumor. If you see very impressive sclerosis in the border, it is not GCT, but there are 20% exception for every rule. Common in adults, fibrous signals. Notochordal signals will be as bright as synovial tumors, which I was telling on the list in the second after the cyst. Too bright, always central, end of the skull, base of the skull versus sacrococcygeal region. Rarely you will get chordoma in the vertebral bodies. Vascular tumors will have phleboliths, hemangioma will have polka dot appearance, and flowoids, serpiginous flowoids, plain or contrast, dynamic contrast, you will get clue. All the vascular tumors will be T2 bright signal, including sarcomas. Lipogenic tumors, there are few which we discussed. Fat is the greatest clue. ABC, age, location, fluid level is the greatest clue for ABC. Simple cyst won't have fluid levels, it might have fracture, it will move down with the growth of the bone age. Fibrous dysplasia can have ground glassing appearance. If you see impressively enhancing homogeneously skull lesion, most times you are dealing with fibrous dysplasia. Take our 2 sections of CT scan, it shows ground glass appearance. Homogeneous enhancement, characteristic X-ray appearance, and the like ground glass you can pick up. So my resident and this Ramakrishna has helped me in preparing this one. Dr. Ramakrishna, whenever I need any missing slide, immediately supplies the slide. We have written 2 chapters which are yet to be published. This is my college campus. No competition with your college campus is very good. So you can ask any questions and answer. My sincere thanks to IMS institution, Dr. Adya, Dr. Satya, and Dr. Amit from Delhi has actually given call to come to this conference. My sincere thanks to the residents, senior, junior, faculty, and all the people who worked for this conference. It's fantastically organized. Everything is very well taken care. So I am active in ICRI, then IRIA. So this is also part of ICRI program. Thank you very much.
Thank you, sir. It was a captivating experience learning from you. Joining us again today after a delightful neuro case discussion last evening is Dr. T. Seetham Kumar from Manipal Hospitals, Bhubaneswar. I request sir to please take the stage and walk us through the important basics of neurovascular anatomy.
Good evening, everybody. So again for the second day. So after a long discussion about various cases of bone tumors and also my senior who discussed about vessel wall imaging, my topics will be very simple in the sense, if a radiology, anything you want to know, that is anatomy. And anatomy is the heart of radiology. And so we'll slowly and simply a discussion between both of the audience side and me will go through the anatomy. So why neuroanatomy of vessels are very much important? So because that says there are 2 things like cerebral arterial system and venous system. And as we discussed last day, few cases regarding vessels problems like stroke as well as ruptured IC bleed and all. So we have to know whether the stroke is in which territory, whether it's an arterial territory, whether it's a venous territory, because the management are quite different. So you have to very conscious about what is the anatomy of blood vessels inside the brain. And also in various clinical scenario, we discussed about focal cerebral arteriopathy yesterday and MELAS also. So we have to recognize those things when we are looking into blood vessels of brain. And further, any aneurysms like AVMs or aneurysms, vascular malformation, we have to look into various angioarchitectures, surgical and endovascular anatomy, so that we can do from your part for the surgeons, and we like an IR, we are very looking into the various anatomical differences, whether we prepare for the case for endovascular interventions. And the final, very grave, when you say how many people, if you see an emergency, there will be IC bleed somewhere in the parenchyma, lobar bleed, okay. To say there are a lot of differential come into play with respect to age of the patient, like child to adult. So we have to look into whether is it a venous infarct. So that we be very cautious about. So we will go through those things. So first important thing about anatomy of cerebral brain vessels, artery, even if the vein, is how the embryology happens during the childhood, and I mean say infant. So inside the mother womb, embryo and all, which helps further. There will be lot of environmental factors during that time which changes various anatomy. That's why the circulation between internal cerebral artery and the vertebrobacillar system varies from each person to each, even in the families also, because there are no doubt there is an embryological things which is behind, but there is also the surrounding thing. So the topic will be discussed about blood vessels. So what modality we are having? So first is like UA ultrasound, Doppler, B scan, which we usually do for neck vessels, and another modality is called transcranial Doppler. I might not people are aware of. That is on a handy bedside tool for looking into intracranial vessels. That is TCD. When you put it the cardiac sectoral probe, you can do that. Even out of that, there will be a separate TCD machine, which we can see to look out the like how there is a stenosis, there is thrombosis. This is happening inside the brain vessels. And the further which we are usually do in our emergencies and our routine practice, it's CT angiography, MR angiography, and the final one is DSA, digital subtraction angiography, which is for diagnostic as well as therapeutic interventions. So what is unique about neurovascular anatomy in the artery of the brain is there is lot of like there is auto-regulation. There is variation in the blood vessels like blood pressure. Within that auto-regulation, the blood within the blood pressure, then like your cerebral perfusion pressure which happen between the like CSF pressure and this which coordinates in between that. So that depend on that the arterial things is very different from other part of the like organs like liver, GI and all. And also in histopathologically there is no external elastic lamina, and that there is thinner middle and outer layers and a few elastic fiber compared to the limb vessels. So cerebral vessels are very unique. So we'll first in the clinical scenario, that is stroke. So stroke, we discussed about ACA territory, MCA territory, PCA territory, and the brainstem. And yesterday I was discussing about how the symptoms we think of when the patient comes to you like this giddiness, vertigo, where you should think of a stroke comes in. So that is a posterior fossa. So this is the classical symptoms of stroke. Then further we are very much important is aneurysms, like the most commons are ECOM, PCOM, MCA, and bifurcation and basilar top. So in this we have to look into the anatomy. So coming to first modalities which we are using, because of time concern I am not going to the TCD and ultrasound. We will look into what it is. Can anybody say? What is the modality? CT angio. So CT angio it's a SAG and it's a MIP image where we can see anybody can say any variations happening. This is normal. This is any variation? This is coming from where? This is what? So for the slides we will discuss why these variations are very much important. So if you see in this image, what is this? CT angio? Anybody? It's a routine practice. MR angio, right? So we have to look at it. These are like, I'm not showing about any anatomy. This is the images. So this is CT angio, MIP images and MPR images. And these are the MR angiography images. And this is DSA, digital subtraction angiography. So this is which vessel? These two, this one and this one. This is what? आर्टरी का नाम तो बता दो. ICA, internal cerebral artery angiogram. Okay, and this is vertebral and vertebrobasilar system. So this comes to the modality which we are using for where our angiography images of anatomy of the brain. So another key fundamental of brain arterial like anatomy is circle of Willis. There is co-systems, like there is the vertebrobasilar system and bilateral ICs are connected with PCOM and ACOM to form a circle of Willis. And there will be codominance. For example, one of the arteries is hypoplastic, the other one will take over in that. So that the circle of Willis will maintain the blood vessel, like the perfusion inside the brain. So this is where we can usually very well seen. This is like ICA, which bifurcates into MCA and ACA. This is ACA and MCA, and similar on the left side, and these are the two PCAs. And if you say this side is a PCOM, this side maybe we are not able to see, but this is how the circle of Willis is forming. The similar, if you see looking at what is the variation here, there is some form of codominance of PCOM from the ICA to PCA, like this is. In this case, you say the vertebrobasilar system which supply the PCA, that is hypoplastic. I mean to say the PCA is directly arising from ICA. So what we say it is fetal PCA. So if we fundamentally go through various anatomical things, which we have to in the brain, we have to start from the arch. So there will be lot of variation in the arch, and the embryological there will be differences. But I am not going on to that. But we'll grossly, there is like type A, type B, and type C and type D arches. Can anybody say what is this anatomy? This is what? Something is coming from left side and going to right side, supplying the limb. Arsa, right? So if depending upon the origin of the great vessels, there is various classification A, B, C, D. So the first one which I was asking, the left CCA is arising from the, that is a Bruhine arch. Okay, a common arch can be. In another variation which see in the arch, like some artery is coming from directly from arch and supplying going inside the vertebral foramina. What is that? It can be anything comes into the vertebral foramina and supplying the brain. What is the artery? Vertebral artery, and that is arising from directly to arch. So it's like vertebral arch, like vertebral artery directly coming from the arch instead of subclavian artery, left subclavian artery. So in after like arch, we go into bilateral common carotid bifurcation. So there will be when we are looking into bifurcations, there will be we are normally see what plaque burden, there is stenosis or present or not. And in another case, like if you look into the classic case which involves the carotid bifurcation, what is that tumor? Yeah, so glomus tumor, where we know we have to very much cautious about, like in your reporting, is there any vascular supply from external carotid artery, ascending pharyngeal artery, because that is very much important in angioembolization. Is there any chances we can do an angioembolization or not? This is what pathology we can see in bifurcation, a routine practice in a stroke patient. This is carotid stenosis. So this is and we have put in a stent at the bifurcation. So that is a method of treatment. Then finally we are looking further into internal cerebral artery. Internal cerebral artery having a various classification depending upon the like angiographic embryological, surgical, but mostly we are using, like if you say the Bothelor is one of the most commonly used, where we have classified like further in the form of like cervical, petrous, cavernous, then it comes to ophthalmic, parophthalmic, supra clinoidal segments, which can be communicating segment, anterior choroidal segment, and terminal segment. And depending upon that, there is lot of smaller arteries which comes from each part of the segment, which have very much significant in the embryological point of view. But we are not going through multiple things, but there are few things which as a resident we should know, that is agenesis and hypoplasia of the ICS. How you can say it's an hypoplasia or agenesis? Somebody can guess? If for example in this case, I have given like something arrow here. This is what? Bony landmark? Carotid canal, right? If it is totally carotid canal is not there at all. That is a agenesis, where you cannot see any bony carotid canal. Okay. So next there will be like, it's a very rare case, like it can be a fenestration. And further there is aberrant ICS. There is a embryological significance. So whenever we do ICA and angiography, we should look into bony landmarks as well. This is aberrant also, which can be presented with pulsatile mass. Okay, in the like there will be tinnitus and all. And another very much important embryological variation is in between the ICA and vertebral circulations. Can anybody say, persistent trigeminal artery? So there are multiple communications between the ICA and vertebral artery. That is the normal, which is PCOM, which is persists. This is the first one which persists. After that, these all are the which regress further in the life, like trigeminal, persistent trigeminal artery, aortic artery, hypoglossal artery, and pro-atlantic arteries. So these all are the, like what I'll say, they should regress, but if not, then what is happening in this case, for example? The persistent trigeminal artery which supplied the basilar system, right? So for example, in the embryology, whenever there is a hypoplastic vertebral arteries, bilateral vertebral arteries, because of some problem, this persistent trigeminal artery will take over and supplies this part of the brain. So this is very much important. So how you get to know persistent trigeminal artery? There are two things, Stallman type 1 and type 2. But in this, which we usually do in MR angiography, whenever in the cavernous segment, is there any blood vessel which comes to midline? For example, there is nothing, no significant vessel we can see in TOF, where something comes into posterior fossa. If it is coming, then that is persistent trigeminal artery. This one is coming from the ICA, left ICA, to reach to the basilar artery. So that is a sign in our imaging diagnosis. Then this one, this is which canal? Normally in the lower part. If something is like flow voids noted in this, persistent hypoglossal artery. Similarly, this is persistent pro-atlantic artery. There are two type of variation, whether it is coming from ECA and ICA. And finally, we go into the supraclinoid segment, that is ophthalmic segment. And ophthalmic segment will have an ophthalmic artery which supplies the our globe, and there is a lot of variations in between. We are further not going through that. And another important about anterior choroidal artery. Can anybody say how it looks? Stroke, anterior choroidal artery, how it presents? So if you say this is that supraclinoid segment, ophthalmic artery comes in, then this is PCOM, then most cranial part is, this is anterior choroidal artery. Usually present with this type of stroke. And how, even it is this is small lacunar stroke, it can be present with complete hemiplegia. Okay, so anterior choroidal artery anatomy, if you look into your anatomy books, or you can remember that how it presents, that is very much. So if a MR comes, if you just say acute lacunar infarct in left gangliocapsula or right gangliocapsula, that not make sense. If you can say, okay, it's an anterior choroidal artery infarct. Next is we further into the classifications of various stages like anterocerebral artery. There are A1 segment, A2 segment, A3 segment, A4 and A5, depending upon from the bifurcation of the ICA till the ACOM starts, that is A1. From that to the bifurcation of these two branches, that is till that A2, then A3 and further A4 and A5. So there are a lot of variations which usually seen in ACA is like one of the ACA will be hypoplastic and the other variation is azygous ACA, where there will be totally absence one side of ACA and the another side ACA will hypertrophy and supply bilateral ACA supply. Similarly, there will be like this the totally absent and which is supplying, and here if it is bilateral 2 is seen from the A2 segment, this is normal, but when it supplies single artery till A2 segment even, then it comes azygous. So there will be multiple like variation like duplication, fenestrations. Fenestrations mean like the artery in embryological fusion not happening. So that is the anatomical variations. And if you look into MR, as I told, like if you look into stroke and you can say it's anterochoroidal artery infarct, then you should be more aware of this one also. Which territory is ACA territory, which territory is the MCA territory, and which is the PCA territory. So that helps us where the stroke is happening, whether any large vessel occlusion is there or not. So another known artery, you people are aware of recurrent artery of Hubner, which comes from A1 segment. Okay, maybe some part of normally not A2 but A1 and ACOM. So A1 supply, this is a smaller artery. Even it's a very small artery, it has a views impact. They will present again acute contralateral hemiplegia. So coming to M2 like MCA, so from ICA bifurcation, it is like till the bifurcation that is called M1 segment. These are the two M2 segment which goes around the operculum and wrap around the cortex. So the M2, M3 and M4. So this is the arterial phase where we can see the early arterial phase, the vessels, and this is the delayed phase in the DSA to look for the perfusion deficit and all. So even MC also, there are a lot of variations like early bifurcation. For example, in this here, you can see there are almost 2 to 3 centimeter it is there, but if the early bifurcates, it's very much important in stroke, mechanical thrombectomy as well. Similarly, there can be accessory MCA coming from ACA as well. So these are the variations, and this is a fenestration. So coming to after AC and MCA and ACOM, then posterior circulation. Posterior circulation includes bilateral vertebral system, like vertebral arteries. One can be hypoplastic, and after basilar artery formation, these are the two what? Say, it's a PCS, then it's downstairs, it's a superior cerebellar artery, then it's ICA, anterior inferior cerebellar artery, and this is PICA, posterior inferior cerebellar artery. So in coming to vertebral artery, there are various segments, V1, V2, V3 and V4. From V1 till the foramen, it's V1, then till it comes out from C1, it's V2. From here, if it go above the, and like from C2 to it above into the C1 arch, till that, till the extradural it is 3, from intradural it starts V4 segment. So here is the common variation, that is hypoplastic one side artery. And here if you can say what is very much important about bilateral vertebral system is ASA and PSA. Okay, so bilateral like ASA comes from bilateral vertebral artery. So anything occlusion from here, if that segment supplies the ASA somehow, then you can present with quadriplegic, maybe in ASA infarct. So this is one of the common variation in the basilar artery, that is basilar artery fenestration or non-fusion of proximal basilar artery. So again the stroke territory we have to look into in MR to look for further like which segment. For example, P1 stroke happens, it can be seen the temporal, medial temporal, occipital, as well as some part of thalami and brainstem. But when it happens, stroke happens in the P3 segment, you might not see any stroke in the brainstem and thalami. So this is again another known territorial infarct, artery of Porcina infarct. What happens, the perforator, whenever it is some dominant one side, all the perforates comes from a single dominant, you can see if occlusion happens in the P1, then bilateral thalami infarct will happen. One of the dominant artery which have a variation is PICA. which supplies the like brainstem, and we know lateral medullary syndrome, how it is usually presented with pica in like tertiary infarct. So these are the territory which already we discussed. So if you anybody says what is this, I think next 3 minutes we will complete. So now there are few cases, case-wise discussions, and then venous system. What is not there on this side? It's an MC occlusion, right? It's an acute stroke. So usually this is how we do in angiographic wise, and we do mechanical thrombectomy from this part, and using a stent retriever and aspiration catheter. This is what? Where we do brain angio most commonly. What is this? And top of basilar aneurysm. So in external carotid artery, there is a lot of things are there, lot of various anatomy, like if you look into like lingual artery, facial artery, ascending pharyngeal artery, then IMA, STA, then posterior auricular artery, occipital artery. So these have multiple variations as well. But one of the clinical important in our IR practices, this is what? A large mass in the sphenopalatine foramina, for example, I say. JNA. So JNA embolization usually we do. And also there is something called dural AV fistula, which is having multiple fistulous component from external cerebral like ECA territory. So after arterial, we have to go through the venous anatomy. As I told, there will be superficial and deep cerebral veins. Superficial variations will be there, trollard and labae, and the deep veins, which medullary veins, which further go into deep veins, like which further into straight sinus and vein of Galen and all. So these cortical veins have a typical presentation with cortical venous infarct, and there will be territorial, like how the veins supply, that will be a stroke. So we have to be very conscious, like if for example temporal lobe, some bleed is there with some form of infarct, whether it's a venous infarct or arterial infarct with hemorrhagic transformation. That you have to look into how it is there. So in the deep system, as I told, vein of Galen, then like inferior sagittal sinus, straight sinus. This part of deep vein usually presented with altered sensorium and dehydration. They usually presented with deep vein thrombosis. This is what? Which imaging? MRV, right? Top MRV. So this is the venous anatomy. So we have to look into whenever stroke happens, how we can see territory wise, we can analyze whether it's a venous anatomy or arterial anatomy. And for venous venous thrombosis, what we do normally? CCT, brain. What you can see? You see in plain CT, what you see? Hyperdense sinuses, and on contrast you will see delta sign, right? Or empty delta sign or delta sign. Are you people are aware of this one? Nobody told empty delta or delta. Okay. So even TOF, you can see there is no filling in the sinuses, MRV, where we can say there is a thrombosis there or not. This is the deep vein thrombosis, how it presents, symmetrical. If a vein of Galen or straight sinus thrombosis happens, bilateral basal ganglia and thalamic infarct. And these are the cortical venous thrombosis. They will be like small, this is a cashew nut sign, the small bleeds which happens in the cortex. This is a deep vein thrombosis. So there will be a lot of pitfall in the imaging, like in MR, like if you say, depending upon the of lot of things, like the wank when we used, and for example in TOF also, how much the velocity and all. However, there will be a lot of variations like arachnoid granulation, which mimics as a thrombosis. Also, sometimes it can be like, there will be like hyperdense on the sinuses. It can be hypoplastic contralateral side. And also there is like, depending upon how you do CCT in the brain. For example, if you do very arterial phase, early phase, when like CCT, then you may miss this delta sign. So if you are suspecting a patient having a CVT, you should have a little bit delayed scan. And this is hypoplastic one side of transverse and sigmoid sinus. which is a common thing. And another one, the last one is cavernous sinus, which is very much important, which is present in the bilateral side on the like sphenoid body, and where we can see a lot of mimickers. Like one is cavernous sinus thrombosis, which can be due to orbito nasal infections, which can spread further to cavernous sinus thrombosis. It can be some of like granulomatous diseases like tuberculosis, sarcoid and all, that also can presented with cerebral like cavernous sinus thrombosis. So as we discussed a lot of things about why we should be worried about brain anatomy, because it has to recognize our main important is stroke, also the bleed, how it is, whether it's in territorial bleed, whether it's a venous bleed or arterial bleed, and further which helps us in various neurovascular interventions and plan those things. And thank you the organizers and the IREP team for giving me the opportunity. And one of the site which we usually see, that is neuroangio.org, where all the various anatomy of brains are there, that is freely available. You people can check it out. Thank you.
Thank you, sir, for that emphatic discussion. The upcoming topic is on interventional radiology and will be discussed by Dr. Ranjan Patel, who is an assistant professor and interventional radiologist at IREP Bhubaneswar. Dr. Patel takes an eager interest in continued learning efforts for all of us students. We welcome sir to teach us about focal hepatic lesions and how to characterize them in the non-cirrhotic liver.
First of all, I would like to thank the organizers Satya sir and Adya bhai for inviting me here. We are already running late and everybody is exhausted actually. So this is the few left topic in the day. So we'll quickly move through the topics, that is focal liver lesion in non-cirrhotic liver. It's a very commonly encountered topic in the day-to-day clinical practices. So what is the role of imaging? Everybody knows that basically we need it for characterization of the liver lesion. Even if we cannot characterize a liver lesion, we need for surgical planning, and even surgeons are more interested not knowing the nature of the lesion, rather than they are more interested whether they can resect it or not, or whether patient can be opt for further transplantation or other any surgical interventions. Imaging also helps to evaluate the exact route, whether we can go ahead with a straightforward biopsy or we need any further procedural modification. So we also need prior to the intervention. The imaging protocol for the liver lesion is straightforward. It's a triple phase CT, and where the portal venous phase and delayed phase are more important, where you can actually see the washout. And if you are looking washout in a lesion, that means that is more likely a malignant lesion than a benign lesion. And MRI is more helpful than a multiphagic CT, and in fact multiphagic MRI is the investigation of choice today to characterize a liver lesion. And whenever you are evaluating a liver lesion, if you are doing an MRI with hepatobiliary phase contrast agent, that is gadobenate or gadoxetic acid, that will be more helpful. The difference between the gadoxetate and gadobenate imaging is basically the timing. Gadobenate has a delayed biliary excretion, so you have to take imaging at 1 to 2 hours, whereas gadoxetic you can take imaging at 15 to 20 minutes. And whenever you are dealing with a post-contrast MR images, you must rely more on the subtracted images than the non-subtracted images, because some lesion can have intrinsic T1 hyperintensity, which can be wrongly interpreted as post-contrast enhancement. So in such cases, you have to look at the subtracted post-contrast images to delineate between the intrinsic T1 hyperintensity and real enhancement. So this is more important. The morphology and the enhancement of the lesion basically depends upon the tissue biology. So if you look at it, tumor who has a fibrous tissue like cholangiocarcinoma or sclerosed hemangioma, if a tissue has the fibrous component, that means if you are giving contrast, that will take contrast late and that will remain enhancing in the delayed phase also. They will show delayed progressive enhancement. Like if you have fat in the tissue, then that will show signal suppression in the fat suppressed image, or if a lesion has a microscopic fat, then that will show signal suppression of off phase images as compared to in phase images. So depending upon the different tissue type, different lesion will have a different kind of enhancement in different phases. So if you look at the enhancement of the lesion, either it can be iso enhancing, hyper enhancing, or hypo enhancing lesion. And if you are looking at the washout of a lesion, if you are dealing a lesion which is showing washout, that means that is more likely to be a malignant than a benign lesion. Always as a radiologist we get struck in the enhancement, but if you look really well while you are doing reporting, rather than the enhancement, the more important is the lesion morphology along with other clinical factors like tumor marker, clinical demography of the patients in a clinical context, and of course the enhancement characteristic also matters. So in certain cases, whatever you do, you cannot diagnose a liver lesion, so don't be worried. In such cases, even if you cannot diagnose a liver lesion, you can go ahead with a biopsy if patient is very much apprehensive, or you are having a doubt whether it is benign or malignant, and then the further treatment of the patient can be planned according to the liver biopsy. So let's see a case. This is a 25-year male patient, non-cirrhotic. And if you look at the CT images, these are the multiphagic CT scan. There are multiple nodules which contain fat within. So multiple fat containing lesions in the liver. There are also hyper-enhancing area which are not showing washout in delayed phases. So depending upon fat containing lesion not showing washout, the differential on imaging remains either it's a multifocal hepatocellular adenoma, or it can be a very well differentiated hepatic carcinoma. So in these cases, as there was no washout, someone gave it as a hepatic adenoma outside. FNSC was also done, and that was given as a hepatic adenoma. But in the second set of images, you can see the lesion morphology. The lesion has a very irregular margin. It looks angry looking, and when we look at the alpha fetoprotein level, it was 260. So it is quite elevated. And considering the aggressive looking of the lesion, elevated alpha fetoprotein, then again we did a repeat biopsy, and ultimately this was turned out to be hepatocellular carcinoma. So not always look at the lesion enhancement and lesion characteristic, also look at the lesion morphology, whether it is angry looking, whether it is looking any suspicious, and also take help of other parameters like serum markers like AFB and PIPCA. This is another case. This is a multiphagic CT of a 56-year male patient. If you look at the first set of images, there is a diffuse fatty liver, and you can see a little bit hyperdense liver in non-contrast phase. The second, third, and fourth images are the arterial, portal, venous, and delayed phase images. In the all phases, you can see a hypervascular lesion that is not showing washout. But remember, in the setting of a fatty liver, if you are even if you are looking at a hyper-enhancing lesion in the portal venous phase or delayed phase, whether the lesion is showing washout or not showing washout, it will be difficult to say, because the normal intensity or normal attenuation of the liver is less because of the diffuse fatty infiltration. So this is one of the scenario. The real washout characteristic of a lesion may not be applicable. And this patient, again, we did a biopsy, and this was turned out to be a hepatocellular carcinoma. So in fatty liver, don't rely upon the washout characteristic in a lesion when it is showing arterial phase hyperenhancement and not showing any washout. So again, as I told you, this lesion, this hepatocellular carcinoma in fatty liver may not show washout in portal venous phase or delayed phase. MRI is a better modality, and often these patients may need biopsy to confirm the diagnosis. So this is the basic classification of the benign liver lesion or malignant liver lesion that we see in the liver. I am not going into the detail of the benign liver lesions. You all know how a hepatic cyst is seen. in the second image, a liver abscess. The main important feature of a abscess, you have to look at a hypo-enhancing rim in the periphery that indicates the edematous rim. You also know how a biliary cyst adenoma looks after how different stages of hydatid cyst are seen. So coming to the pseudo lesions, these are actually not the real lesions but can pose clinical challenges while dealing in day-to-day practices. So because of either the focal fatty infiltration or focal fatty sparing, you may find a lesion on any kind of imaging like ultrasound, CT or MRI. Look at the first images, you can see there is a hyperechoic, homogeneous hyperechoic lesion. This may be wrongly interpreted as a hepatic hemangioma or any other focal lesion. But if you see at the MRI images, there is the in and approach page images. In approach page images, the third images, you can see there is signal suppression in the lesion. And if you see carefully in the second images, the normal hepatic vessels are going through it. So it is not causing mass effect. The vessels are normally traversing through the lesions and the area is showing signal suppression of off-page images. So all are the features of focal fatty infiltration, which is a pseudo lesion, not a true lesion, and nothing should be done for this region. It can be left as such. The fourth images, again, as I told, there is diffuse fatty infiltration of the liver, and you can see a geographical marginated lesion. That means very sharp angulated lesion located in the segment 4. That is very a typical location of focal fatty sparing or focal fatty infiltration. So you have to be aware of these pseudo lesions and should not misinterpret as a true lesions. Another clinical common scenario you come across like the hemangioma are the most common benign lesions seen, and when you have a background of malignancy somewhere else in the body, you have to differentiate whether this is actually an hepatic hemangioma or it's a metastasis from that lesion to the liver. So there are certain features which will help you to differentiate between the hepatic hemangioma and hypercellular hypervascular metastasis in the liver. The hemangioma typically shows the peripheral discontinuous nodular enhancement with gradual centripetal enhancement, whereas the malignant lesion, like in the second row first images, you can see there is a continuous hypervascular enhancement, but it's a targeted pattern of enhancement, not discontinuous peripheral enhancement. And unlike hemangioma, which shows gradual progressive enhancement, usually metastasis can show washout rather than progressive enhancement. Like in this second images, this is a neuroendocrine tumor in the lesser sac with hepatic metastasis, which shows hypervascularity in the arterial and portal venous phase, but in the delayed phase you can see washout in those lesions. Moving to the next benign lesion, that is the hepatic adenoma. These are basically commonly seen in the young patients who are having on long-term oral contraceptive pill or having diffuse fatty liver. In that background, usually you can find those hepatoma. And hepatic adenomas are basically consist of the abnormal hepatocytes without any much collagen vascular tissues. So these tumors have a very high tendency to rupture and cause spontaneous intraperitoneal hemorrhages, and some kind of hepatic adenoma can have also tendency to convert into a malignant hepatocellular carcinoma. So this is one of our case. You can see this patient presented with abdominal pain and there is drop in the hemoglobin. If you see the first set of images, it's a large lesion in the middle of the liver. This shows areas of internal hemorrhages, also areas of fatty attenuation. So both, if you see a lesion which show internal hemorrhages, which show fat, that means you are more dealing with a lesion, either it's a well differentiated HCC or a hepatic adenoma. Again, if you see at the other pages images, there are peripheral solid enhancing areas, and that remains iso enhancing even in the delayed phases, not showing washout. So a lesion which is heterogeneous on non-contrast images containing hemorrhage, containing fat, showing arterial hyperenhancement, not showing washout, that means that is more likely a hepatic adenoma than an hepatocellular carcinoma. Again, as I told, if you compare CT and MRI with hepatocellular contrast phase imaging is the of choice, and imaging wise, it can completely mimic like a HCC, like this case. It's a T2 hyperintense lesion, not showing any fat on the T1 in and off phase images. But if you see the gradual enhancement pattern, the lesion is showing arterial phase hyper enhancement, and in the delayed and hepatocellular phase, it is showing washout. So this imaging wise, this can mimic like HCC, and you may need a biopsy to confirm it. So again, as I told, there are certain type of hepatic adenoma that can have a higher tendency of malignancy, that is the beta catenin type have a highest tendency of malignancy. And if you look at the risk factor of malignant transformation, if you are dealing with a larger lesion more than 5 centimeter in a male patients, on histopathology come out to be a beta catenin type, that means those lesions have a higher tendency of malignant transformation, and in such cases the ideal mode of treatment should be the surgical resection rather than follow-up. Although some patient may not opt for upfront surgery, in such cases at least you advise the patient to have a proper regular follow-up, so that the early malignant conversion can be detected on imaging and patient will be subjected to further surgery. The next focal liver lesion is the focal nodular hyperplasia. This is the second most common lesion in the liver, and FNH is never a malignant lesion. So it's always a benign lesion, but the important challenges is you have to differentiate it from a other suspicious lesion. If you can confidently diagnose it as a FNH, then you can leave the lesion as such. You don't need to do anything for those. These are most commonly detected in the young patients and often incidentally detected. The classical feature everybody knows, it's a arterially hyperenhancing lesion which remains iso enhancement even in the delayed phases, because these lesions contain the normal hepatocytes, and around 60 to 80% of cases this lesion can have a central scar. And if you see the MR images, this is the T2 weighted MR images. If you see a lesion which is slightly or moderately T2 hyperintense, if you see a T2 hyperintense central scar, and on the post contrast images, the arterial phase show marked enhancement, and the lesion becomes iso enhancing in the subsequent phases, and the central scar show delayed enhancement. If you look at the last images, that is showing delayed enhancement. So T2 hyperintense central scar which is showing enhancement in an arterial phase hyperenhancing lesion is more likely to be a FNH than other any lesions. This is another example. You can see the T2 mildly T2 hyperintense lesion, central T2 hyperintense scar which is appear hypointense on T1 weighted images. On post contrast images, it is showing arterial hyperenhancement, and in delayed phases the scar is showing enhancement. So this is a typical feature of a FNH. In this particular lesion, contrast enhanced ultrasound can have a particular role, because in some lesion characteristically you may find a spoke wheel appearance. So what is spoke wheel appearance is, basically FNH is supplied by a large feeding arteries to the center of the scar, and from the center of the scar there will be radiating arteries to the periphery. So if you do a contrast enhanced ultrasound in real time during the arterial phases, you may find a prominent feeding vessels, and that is supplying to the center of the lesions, and on the subsequent phases there will be centrifugal filling. That is called as the spoke wheel pattern. This is also quite characteristic of FNH. But remember, you may not find the classical feature in all lesions. If you have any doubt, either you keep the patients on follow-up or do a tissue diagnosis. So what are the typical features? Usually FNH does not grow over a period of time, but if you are looking at a lesion which looking like a FNH but it is showing interval growth, if you are seeing intralesional fatty changes, if you are seeing calcification, or if there will be any heterogeneous T2 signal intensity or any kind of atypical enhancement, then either keep the patient on follow-up or straight away go with a tissue diagnosis. The closest mimicker of FNH is the fibrolamellar HCCs. So these FNH and fibrolamellar HCC both appear in the non-cirrhotic liver and can pose a clinical challenges. But if you are looking at a larger lesion that is more than 5 centimeter, if you have a very heterogeneous lesion as compared to more homogeneous, like FNH is a more homogeneous than fibrolamellar HCC. If the central scar, you can see central scar in both the lesions, but the central scar is large, more than 2 centimeter, or if the central scar showing calcification, then those are more feature of a fibrolamellar carcinoma than FNH. So this is another example. Let's see. This is the non-contrast arterial phase and portal venous phase. You cannot see any lesion in the arterial phase images, any lesion in the non-contrast images. But in portal venous phase, if you see, it's a focal hyper-enhancing lesion in the right lobe of the liver. So this may be interpreted as a atypical hemangioma, flash-filling hemangioma, although it is not showing any enhancement in arterial phases. We did an ultrasound, and surprisingly we got a 5 centimeter lesions, which is not seen at all on CT scan. I don't have the ultrasound images, but if you look at the other CT images, this patient also has a large dilated portal vein. There is a splenomegaly, and on upper GI endoscopy there were varices. So this patient is a non-cirrhotic patient, but dilated portal vein is there, splenomegaly is there. So this is a case of NCPH, non-cirrhotic portal hypertension, means there is disturbances in the portal flow. So these are the conditions where NCPH or PSVD or Budd-Chiari syndrome, where there will be deranged in the vascular supply to the liver, or vascular derangement in the liver. In such background liver, you may find abnormal FNH like lesion. Those are called as FNH like lesion. So when did a non-contrast MRI, you can see a large lesion sitting in the right lobe. The center area is basically a portovenous shunting, and the lesion is not showing T2 hyperintensity, because the T2 hyperintense lesion more indicate towards either a FNH or an HCC or any other adenomatous lesion. But if we are looking at a T1 hyperintense and T2 hypointense lesion, which is iso-intense on post-contrast CT images, that means you are dealing with a lesion that is called nodular regenerative hyperplasia. These are this is a biopsy-proven case of nodular regenerative hyperplasia, and you don't need to do anything for this lesion. These are the benign lesions. Won't do anything to the patient. This is another case. It's a 25-year male patient, and this is the multiphagic CT scan. You can see a focal chunk of calcification on the NCCT images. In the arterial and subsequent phases, in arterial phases it is almost non-enhancing, but in subsequent phases you can see heterogeneous enhancement, but it is progressive enhancement in the delayed phases. So you have a lesion in the left lobe having calcification, there is progressive enhancement. So on this basis, either this could be a typical pattern of FNH, although the calcification is very uncommon, or it could be very atypical. It could be atypical, but it could be a cholangiocarcinoma also. It could be a sclerosed hemangioma also. But when we look at the clinical history of the patients, these patients have adult onset still disease, and patients is having type B symptoms. So in a background of autoimmune disease or adult onset still disease, if you are looking at a lesion which is showing calcification, which is showing gradual progressive enhancement, that means probably you are dealing with a case of inflammatory myofibroblastic tumor of the lesion. So we did a biopsy, and this was turned out to be an inflammatory myofibroblastic tumor. But again, as I told, imaging is only predictive, but only on the basis of imaging you should not make a diagnosis, and you have to have a biopsy to prove it. But at least you can raise a possibility of inflammatory fibroblastic tumor if you have a proper clinical setup like autoimmune disease, if you have a lesion which is showing progressive enhancement, and there is no other features to suggest any other alternative diagnosis like cholangiocarcinoma. This is another case. Again, you can see a T2 hypointense lesion, and that lesion is showing progressive enhancement. This patient presented with biliary obstruction because of the involvement of the myofibroblastic tumor into the CBD. So again, a lesion which is closely mimicking as cholangiocarcinoma. We gave it as cholangiocarcinoma, but on biopsy, this was turned out to be an inflammatory myofibroblastic tumor. So you should keep this entity on mind. The most common tumor after SCC in the liver is cholangiocarcinoma. Everybody knows the typical imaging feature of cholangiocarcinoma. It's a T2 hyperintense lesion hypointense on T1, there is peripheral enhancement of the arterial phases, and there is progressive centripetal enhancement. There may be associated capsular retraction, there may be associated satellite nodules, and ISBRD, which will point out towards the diagnosis of cholangiocarcinoma. Typical feature like target sign can be seen on diffusion weighted imaging. So what is target sign? Basically, if you read the histopathology of cholangiocarcinoma, basically it's a fibrous tumor having central collagen fibrosis, and the active cell will be in the periphery. So if you do a diffusion weighted imaging, the hypercellular zone will show the diffusion restriction, whereas the fibrotic core won't show diffusion restriction. That will look like a target, and this target sign on diffusion weighted imaging could be a helpful feature in the favor of cholangiocarcinoma. And another sign called cloud sign, as I told, there will be gradual centripetal enhancement of those lesions in the delayed phase. But in the hepatobiliary phase, the fibrous core will retain the contrast, whereas the peripheral cellular zone will show washout. That means those are atypical hepatocytes or non-hepatocyte. So the central core will retain contrast, whereas the peripheral thin rim will show washout. That is called as the cloud sign, which is also a feature of cholangiocarcinoma. Interestingly, certain lesions like sclerosed hemangioma identically mimic like a cholangiocarcinoma. There is no clear-cut imaging feature to differentiate between a sclerosed hemangioma and cholangiocarcinoma, but at least if you are dealing with a lesion which is showing peripheral nodular discontinuous enhancement only in a part of the lesion, there is associated surrounding vascular changes, and there is absence of diffusion restriction, then more likely this is an sclerosed hemangioma than cholangiocarcinoma. But upfront it's difficult to differentiate between the two entity, and you need to have a biopsy to prove it. This is another atypical lesion, a young 28-year female patients in the multiphagic CT. You can see non-contrast, there is a hypodense lesion. On the post-contrast images, you can again see there is capsular retraction, there is gradual centripetal filling, there is atrophy of the right lobe, and there is IHBRT because of the involvement of the tumor. So again, the differential remains as either this could be a cholangiocarcinoma, this could be an inflammatory myofibrillary.
Thank you, sir, for the emphatic discussion. I would now like to call upon Satya, sir, to felicitate, sir. To present, sir. Moving forward, please join me in welcoming Dr. Sambit Kumar Patnaik. Sir is currently working at Some Ultimate Medicare as a consultant and interventional radiologist, and will talk about the role of IR in acute DVT and expand the horizons beyond anticoagulation therapy.
Good evening all. Thank you respected teachers for giving me the opportunity to speak on this topic. Today I'll be discussing the role of IR in acute to subacute deep vein thrombosis. Coming to the introduction, DVT is a common vascular disease seen predisposed by virtuous triad, that is prolonged immobility, hypercoagulable stasis, and endothelial damage. These untreated DVTs can progress to PE, that is a life-threatening complication. Morbidity may also develop from recurrent thrombosis and post-thrombotic syndromes. The post-thrombotic syndrome is a long-term complication of DVT which restricts the quality of life and is characterized by chronic persistent pain, swelling, and other signs like venous ulcers in the affected limb. Coming to the epidemiology, DVT is a subset of venous thromboembolism and is a major preventable cause of morbidity and mortality worldwide. The incidence of VT is estimated as 1 per 1,000 people annually, with DVT accounting to approximately 2/3 of these events. PE is a dreaded complication of DVT that occurs in up to 1/3 of the cases and is a primary contributor to the mortality. Much of the morbidity DVT results from the development of this PTS, which occurs in up to 50% of the patients within 2 years of DVT, and it encompasses a number of symptoms including leg pain, swelling, and in severe cases with venous ulcer of the affected limbs. Vast majority of DVTs are diagnosed in the proximal veins of the lower extremity, that is the common femoral vein, superficial femoral vein, and the popliteal vein. The risk factors for the venous thrombosis are old age, obesity, previously diagnosed, previous thrombosis, surgery, cancer, varicose veins, or oral contraceptives, long travel. Straight away coming to the procedure, how a procedure like we do for this mechanical thrombectomy for this DVTs, the diagnosis of this acute to subacute DVT is usually made by venous color Doppler in ultrasound, or sometimes through this routine CT venograms to know the upper extent in obese patients. Then the CT venogram image you can see in the right side, there's the right common femoral vein up to the iliac bifurcation, it is completely thrombosed. Before the procedure, an temporary IVC filter is prophylactically placed either from the contralateral superficial femoral root or through the jugular vein below the renal venous orifices. We always deploy the IVC filters below the renal orifices. As we do the thrombectomy, the thrombus should not migrate to the renal veins. So, and this is just to prevent the complication of PE, thromboemboli during and after the thrombus removal. I'll just show the videos how we deployed to the femoral and this jugular approach. The first one, the image, the video you can see it is deployed to the femoral root, and the second video I am showing it is through the jugular vein, from the neck veins. And both are deployed below the renal orifices, as I said before. Then subsequently, a 8 French vascular introducer sheath is inserted through the popliteal vein of the affected extremity. By the ultrasound guidance, an initial venogram is obtained. This is the initial venogram after the puncture from the popliteal vein. You can see there is no flow in the popliteal, common femoral, and up to the in the iliac veins. There is no flow. Then ultimately the TPA that is of 10 to 15 mg with the average of 60 kg is diluted with 100 to 500 mm of NS is infused over the entire segment of this vein through this angiojet catheters or multi-hole pictal catheters and left for 60 minutes during the procedure, or in some cases we also give this altiplase overnight, like overnight thrombolysis is done. Then either with the angiojet gelante catheter or cleaner XT or penumbra catheters, the pharmacomechanical thrombectomy devices, the thrombus is macerated and then aspirated. The lower portions are done first, the caudally, and then treated with the upper segments cranially of the thrombus. The first video I'm showing is the cleaner XT device. That is a pharmacomechanical thrombectomy device which does maceration of the clots through the rotational technique. The second video is this angiojet gelante catheter. You can see how it will aspirate the clots. And the third and the latest one is the penumbra catheter. Just like a vacuum system, it aspirates all the clots and it gets accumulated within this jar. When the post-procedure venogram reveals any underlying stenotic thrombus segments of the affected vessels after the thrombectomy is done, and it is not like the flow is not very much good, then we'd go for a balloon venoplasty or stent placement in order to ensure there is adequate flow. This is the venogram after thrombectomy. You can see in this segment, the upper, in the iliac segment, the flow is not that adequate what we expect after thrombectomy. So what we did, we go through a balloon and we do a venoplasty over that segment. So the initial run I'll show and I'll compare with the final row after thrombectomy. This was the initial run. There was absolutely no flow in the vessels with the multiple collaterals, and this was the final run. You can see there was a very nice flow was maintained. These are the manually aspirated clots when the patient cannot afford this expensive this penumbra thing. We macerate with this cleaner XT and aspirate the clots manually. This was the post-procedural Doppler, venous Doppler, where we can see there is normal flow is there and no interluminal thrombus. And yes, as I said before, we always deploy these IVC filters before the procedure, before doing the mechanical thrombectomy, but these are temporary filters, so we need to remove these filters out. So we removed it with the multi-loop snare technique through the jugular access. These are videos showing how we catch hold of this filter and we just snare it out after a span of like 30 to 45 days. You can see the hook over here in the image over there. we catch out the hook, and over the long sheet, we just remove it out. And in the last image, you can see some amount of clots that is attached to the filters. Yes, these filters act as a nidus for fresh clot formation, but only in those patients who doesn't come up for follow-up or doesn't within the span that we have advised, like 35 to 40 days or 45 days, they come up after 1 year or like 6 months. These patients land up with the filters having clots, and such patients were treated, and where these clots can be found. And these devices are actually, I believe, are devices which actually prevents the patients from getting into PE, the pulmonary, which is a dreaded complication of this DVT. This is the first case I'll show. This is a young female, 28 years female, with a history of OP poisoning, presented with gross right swelling on the right hand. The USG Doppler showed acute to subacute thrombus, and on the DSA we saw there was right axillary and subclavian vein thrombosis. There is absolutely no, on the Doppler, and there was absolute no flow was seen. She had a gross swelling. Then we did a mechanical thrombectomy for her, and after thrombectomy the swelling was grossly reduced. And the DSA, we can see the flow was very well maintained. This is the second case. There is a 39-year aged male with a history of RTA. He had a fractured left femur and tibia, post-op present with gloss left lower limb swelling. On Doppler, there was acute or subacute thrombus in left popliteal, starting from left popliteal up to the common iliac veins. You can see there is a gross swelling of his left lower limb. The initial venogram that showed there was acute thrombosis of this lower limb veins, the popliteal, femoral, and there was no flow in the up to the iliac. Then after this thrombectomy, you can see how the flow is being maintained. And when he came up for follow-up after 1 month, the swelling was absolutely gone. So coming to the discussion, iliofemoral DVT is always associated with high risk of adverse outcomes related to femoropopliteal below knee DVT. The composition of thrombus evolves over time from fibrin-rich to collagen-rich, making it more resistant to thrombolytics. Mechanical thrombectomy is useful treating acute, subacute, and chronic DVT caused by various pathological conditions. Although adequate anticoagulation therapy prevents patients with acute DVT from developing PE, it is inadequate for preservation or restoration of the venous valvular function, which leads to PTS. Anticoagulation with unfractured heparin or low molecular heparin is a very gold standard for many physicians in the management of DVT and PE. However, an anticoagulation alone cannot diminish the inflammatory response to thrombosis and is rarely able to lyse the clots adequately. The incidence of recurrent DVT and post-thrombotic syndrome remains fairly high following an initial diagnosis of DVT. Advances in IR techniques allow early mechanical thrombectomy with CDT therapy with or without complementary balloon angioplasty stenting as early resolution for acute symptoms, preservation of the valvular structure, and avoid PTS. Obviously, every procedure has some advantages and disadvantages. The advantages of this mechanical thrombectomy, CDT, and placements of filters are this higher primary patency of the veins, lower incidence of major bleeding, shorter length of ICU stay and thereby reduction in cost, lesser requirements of venograms, the lower risk of post-traumatic syndrome. The disadvantages are injury to the endothelium during the thrombectomy or during the deployment of the filters. When we deploy the filter, the struts also causes the caval endothelial damage. The IVL filter, as I said before, can cause as an nidus for formation, but if it is removed like within the span that we advise and the patient is on anticoagulants for like 35 to 45 days and we don't treat as this filter as a permanent filter, then these complication doesn't happen. And the regular contact use of anticoagulants also is a high risk. So lastly, coming to the conclusion, IR plays a pivotal role in the management of acute DVT thrombosis, particularly in cases extensive of life-threatening thrombotic events such as iliofemoral DVT. Traditional anticoagulant therapy reduces the risk of thrombus propagation, recurrence, but does not address clot burden, which can lead to PTS, long-term morbidity. IR techniques including CDT, thrombectomies, thrombolysis, and placement of filters offer targeted approach, rapid restore of venous patency, alleviates symptoms and prevents complications. Advances in these imaging and minimally invasive tools have improved procedural precision, patient outcomes. While these therapies are associated with improved quality of life, lower rate of PTS, in selected population, they carry such bleeding and require careful patient selection. Thank you.
Thank you, sir. That was a very well assembled presentation. The concluding presentation of the academic program will be given by Dr. Ranjan Patel. I am so sorry. I ask Kingar Panda to please felicitate Dr. Sambit. So for the concluding presentation, Dr. Ranjan Patel will come back on stage and talk about hepatobiliary interventions.
We'll end with some intervention topics, that is hepatobiliary intervention. This is in fact the most common area where everybody used to do some kind of intervention, at least whether they are dedicatedly practicing intervention or not, starting from the abscess drainage to doing a percutaneous biliary drainage and all. So again, the spectrum of interventions can be either diagnostic, that varies from the biopsies to drainage, diagnostic aspiration to angiogram, and therapeutic procedures can be like simple drainage procedure to complex vascular procedures. So the basic drainage procedure that you know, ultrasound guided procedures, which is done under either ultrasound or CT guidance. In some patients of pancreatitis where CT guided drainage could be very helpful. PTBD, again, everybody knows when ERCP is failed or when patient cannot be shifted out of shifted to the ERCP suite, then percutaneous biliary drainage can be life saving. And in today's time, with the available hardwares, even if you don't have any biliary dilatation, then also you can do a PTBD using micropuncture set. And in very sick patients, if you have a dilated biliary system, even without any fluoroscopy help, you can do a PTBD at the bedside under ultrasound guidance, and that can be a life-saving measures. So in some patients where you may not be able to enter into the biliary tree through the transhepatic route, then you can approach the biliary tree through a gallbladder route. So you can puncture the gallbladder through the liver, because gallbladder is quite a large structure. From the gallbladder you can enter into the CBD through the cystic duct, and you can place a stent like the endoscopist used to do, and placing a stent across the cystic duct and draining the CBD into the duodenum. So again, if you have a biliary PTBD in situ, then additional procedure like biliary stenting and ballooning can be done. Biliary percutaneous cholecystostomy, that means draining the gallbladder. It's a procedure that is done in critically ill patients who are not suitable for surgery. So on ultrasound guidance, you can puncture the gallbladder, you can drain it, which is called the percutaneous cholecystostomy, and particularly done in case of acute gangrenous cholecystitis or severe acute acalculous cholecystitis in sick patients. Liver biopsy, everybody knows, to diagnose the liver lesion or to diagnose the background liver disease like cirrhosis or cause of the cirrhosis. You can do it either percutaneously if the patient doesn't have any ascites or coagulopathy. If patient has ascites or coagulopathy, you can do it from the transjugular route, which is called the transjugular liver biopsy. In some cases of anatomically feasible cases where because of the acute hepatic vein angulation, if you cannot do the biopsy from the transjugular, we can do it from the transfemoral route, that is called the transfemoral liver biopsy. This is the third images. Therapeutic procedures come to the arterial GI bleed. You must have assisted few procedures, I think, if you were doing DSA. So this is a case of pancreatitis related bleed. You can see a hematoma in the lesser sac in the first CT images. In the second images, it's a large splenic artery pseudoaneurysm. In the DSA, you can see the splenic artery pseudoaneurysm which has coiled. And the technique that is used to coil this aneurysm is called Sandwich technique. That means you have to block the vessels across the neck, that means both proximal and distal to the neck, because if you only block the neck block the vessels proximal to the aneurysm, then there is a chance of refilling through the collaterals. So the coiling technique is called the Sandwich techniques. This is another case of pancreatitis. This patient has chronic pancreatitis with a pleuropancreaticoparenchymal fistula. And you can see the second images. There is a pleuroparenchymal fistula with a cavity in the lung, and this patient was bleeding from the gut also and bleeding from the bronchus also. So this patient has hemoptysis as well as upper GI bleed. And when we did a CT scan, you can see a pseudoaneurysm arising from the left inferior phrenic artery, which was subsequently embolized to tackle both the hemoptysis and melena. Sometimes and the endovascular procedures may not be helpful because of anatomical constraint. So this is the first image. You can see there is stenosis of the splenic artery, and because the small aneurysm that is seen in the second images was not accessible through the splenic artery because of the splenic artery stenosis, we saw in the ultrasound we could found a window to the pseudoaneurysm through the transsplenic route. We directly access the aneurysm through the transsplenic route, and we injected to occlude the aneurysm. And the fourth images you can see there is glue deposition inside the aneurysmal sac, and there is also embolization of the transsplenic route through which we entered using the same glue. So basically this is an alternative route, and this can save 40,000-50,000 of patients, because the percutaneous glue is basically done on the ultrasound guidance, don't need any much catheter or any advanced hardwares. In some kind of tumors also embolization helps in managing the symptoms. This is a case of large giant hemangioma. On CT you can see it's a large hemangioma showing peripheral discontinuous enhancement. There is still non-filling of the central part because it's a large sclerosed hemangioma. So in such cases, if you are doing an embolization using a bleomycin, that can give you an wonder regions. So this case we did the bleomycin transarterial embolization, and this is the baseline images, and this is the almost 2 years follow-up. You can see there is marked shrinkage of the hemangioma with hypertrophy of the contralateral liver. So bleomycin test would be a very helpful tool in dealing the large hemangiomas. In some patients, because usually in transarterial procedures we go through the transfemoral route, that means puncturing the femoral artery and go. But if patient have coagulopathy or very low platelet counts, where after the procedure compressing the femoral arteries would be difficult than compressing the radial artery. So in such cases you can go ahead with the transradial approach. This is a case of idiopathic thrombocytopenic purpura with a large spleen. Patients is having very low platelet of 7,000, so we entered into the splenic artery, so the left side radial artery, embolize the spleen around 70 to 80% to achieve the adequate results. And the fourth images you can see there is almost 70 to 80% decrease in the parenchymal blood of spleen if you compare with the second images. Moving to the therapeutic approach in the portal hypertension, if you see the basics pathophysiology of portal hypertension, any kind of portal hypertension can lead to increase in the portal pressures, and that can lead to formation of ascites and hydrothorax. That can lead to formation of portosystemic shunt, and if those shunts are very large, then they can induce shunt-induced hepatic encephalopathy. They can lead to variceal formation, which can lead to life-threatening bleeding, and because of the portal hypertension can lead to increase in the spleen size and secondary hypersplenism. So in interventional approaches, if you are dealing with a portal hypertensive patients and patient is having ascites or hydrothorax, then either you can drain those ascites or hydrothorax, but you are not dealing the primary causes. So to have a temporary, to have a more permanent effect, you can reduce the portal pressure. But how can you reduce the portal pressure? You can reduce it by creating a portosystemic shunt, which is called the TIPS. Or if patient is having variceal bleed, either you can obliterate the varices, that is called variceal embolization. If patient is having a large shunt and causing HE. Then to improve HE, you can occlude the shunt, which is called as the shunt occlusion, or in hypersplenism, you can embolize the spleen, called as the partial splenic embolization, to improve the counts. So this is a case of ascites with right-sided hydrothorax, and for which we took a transjugular route, puncture the portal vein, and create a portosystemic shunt, and then subsequently the ascites and hydrothorax improved. Again, as I told, in patients with refractory variceal bleeding also, you can do a tips to decrease the portal pressure, and along with it, you can embolize the varices simultaneously. So this case is a patients having refractory esophageal variceal bleed. So this was managed with tips with variceal embolization. Not all patients are fit for tips, and you should know the indication and contraindication of those procedures. Gastric variceal bleeding also can be managed with IR, because these gastric varices have a different anatomy. Usually in 80% of cases, the gastric varices drain through the left renal and cava through a large dominant shunt. So through the shunt approach, you can embolize the varices. Like in these cases, in the second images, you can see a large gastrorenal shunt with a large varices, which was approached through the femoral vein, from the femoral vein to the left renal vein, from the left renal vein to the shunt, and after occluding the shunt with a large block, then we embolize the varices. And this is the follow-up images. You can see the initial post-procedure variceal position, that is the hyperdense substances. In the 6-month follow-up, you can see there is disappearance of the varices. Again, as I told, in medically refractory hepatic encephalopathy, like in this case, a large portosystemic shunt in the past images, which was occluded using plug and glue. The shunt occlusion to manage medically refractory hepatic encephalopathy. Hepatic venous outflow tract obstruction is another domain where IR has a very eminent role. Hepatic venous occlusion can lead to ascites formation, liver failure. So that can happen either at the IVC level, in the hepatic venous level. So if IVC will be occluded, you can go ahead with the IVC recanalization. If hepatic vein is occluded, then you can recanalize the hepatic vein, doing a hepatic vein angioplasty or stenting. And whenever you won't be able to do any kind of hepatic vein recanalization, because all the 3 hepatic veins are gone, then you can directly create a shunt between the inferior vena cava to the portal vein. That is called the direct IVC to portal vein shunting or DIPS to manage the portal hypertension. In EHPBO patients also, in anatomy or physical, then you can go ahead with a endovascular procedure. This is a case, you can see there are a bunch of gastric varices, EHPBO with portal cavernoma formation. And in the second images, there is a dominant extrahepatic collateral vein. The conventional tips was not possible, so we punctured that extrahepatic collateral veins under the image guidance, and then we extended shunt from the SMB to the IVC through the liver. So this is basically an endovascular mesocaval shunt to manage the portal hypertension, and subsequently in the same patient, the gastric variceal embolization was also done. So IR in hepatocellular carcinoma is very well established, and depending upon the lesion, patient performance, different kind of endovascular therapies are available. This is a case of cirrhosis with a solitary HCC less than 3 centimeters. So these solitary HCC less than 3 centimeters are usually more feasible for ablation techniques. So these patients, we did radiofrequency ablation, and you can see the post ablation imaging, that is complete response with no residual enhancement of those tumor. So other ablation like microwave and cryoablation can be done, which have a better efficacy than the RFA, and depending upon the availability. IRE, that is irreversible electroporation, is a non of tumor ablation, and this is available in very limited places, but can be useful in very particular lesions which are very adjacent to the critical structures. In lesions which are not suitable for TACE, like larger lesions or multiple lesions, can be managed with transarterial chemoembolization. For this example, 2-3 nodules that are more than 5 centimeters were managed with tips, and there is complete response of the TACE. So transarterial chemoembolization can be done where ablation is not an option. So, but remember, not always the endovascular procedures are enough to have a better outcome. And in some patients, particularly those patients who are surgically fit, not cirrhotic, in such cases, the best treatment of HCC is the liver resection. Either it's a minor liver resection or it's a major liver resection. Let's see an example. This is an HCC in the non-cirrhotic liver. In the right lobe, a necrotic lesion with highly aggressive HCC on biopsies. So the plan was to do a right hepatectomy, but the future liver remnant, that is the left side of the liver, that will remain in the patients, was insufficient for the patients. So we calculated on CT volumetry. So initially what we did the transarterial chemoembolization of this tumor to have a local tumor control till the patient remains fit for surgery. Then we did a right-sided portal vein embolization so that the left side of the liver will get more blood and will more hypertrophied. Even after portal vein embolization, there was inadequate liver hypertrophy. Then we occlude the right-sided hepatic vein, which is called as the hepatic vein embolization. And if we do portal vein plus hepatic vein embolization, then that is called dual vein embolization or liver venous deprivation, LVD. So and ultimately the patients achieve the adequate FLR volume, and ultimately patient underwent hepatectomy. So not always a singular events will lead to the optimal outcome. You have to have an multiple interventional therapy depending upon the case. Sometimes the interventionalist may not be enough, or not the surgeon may be enough. Let's see an example. This is a case of post-hepatectomy, portal vein thrombosis. On the day 3 of the right hepatectomy, there was extensive portal vein thrombosis of the left portal vein. The liver function was declining. The ascites was rapidly reaccumulating. So what the surgeon did, the surgeon took the patient to the OT. They opened up. They removed the major clot from the left portal vein through a open approach, but they could not they did not able to access the clot inside the intrahepatic parenchymal branch of the portal vein. So what we did after the surgical embolectomy, on the table we took the help of the C-arm. We puncture the portal vein under the ultrasound guidance. On the C-arm guidance, we place a left portal vein stent, and in the this is the intra-operative ultrasound that show the patent flow after the surgical embolectomy and on-table portal vein stenting. So it's a hybrid procedures, and as I told, sometimes alone is not enough. You have to have a combined approach to have a better outcome. So, and this is the follow-up images. You can see there is complete recanalization. If you see the baseline images, there is occlusion of the portal vein, and in the this is the follow-up images after open embolectomy with intraoperative portal vein stenting. There is complete recanalization. Patient ultimately got discharged after 28 days of surgery. So, to take home message, IR can be very efficacious or equally efficacious in some settings, but not always. It has its own limitations. Importantly, it can be complementary to endoscopy or surgery therapy if you are talking about the hepatobiliary systems, and one should be know more about the contraindication where these procedures are not helpful or can be more harmful to the patients, and one also should know the indication of this procedure to have a optimal outcome. Thank you.
Thank you, sir. That brings us to the end of the academic program. I now request the Secretary of ORIA and our beloved HOD, sir, Dr. SSG Mahapatra, to please say a few words.
So, good evening, everyone. So, practically, there is no one left apart from Ranjan. All we left are our department only. So, it's a big thank to all of you. But customarily, we must thank like ICRI and IRIA to give us a chance to host IREP for the first time in Odisha. So, anyhow, we did it. Good, bad, or ugly, that everyone will tell later on. But hopefully, we did well, and everybody had a chance to listen to all the good speakers from state and outside state and have a good learning experience, and everybody will go home with a take home message that we had a fruitful 2 days. So big thank you to everyone, like all faculties of our college, Ames, Tara, Ranjan, Manoj, from our college, Adya, and every other faculty who even stayed back in department to do the job and couldn't attend the session. So it's a big thanks to everyone. And coming to the residents, like actually you did the most of the work, Hemlata, Sukanya, Amrit, everyone, Hemant, like where is he? Ah, like a big thank, a big salute to you, like the way you helped. Thank everyone and thank from my bottom of my heart, like all the support staff, Prasanna, like the department, our, like for doing the logistics and all. And thank everyone. Thank you everyone. Have a great day.